volume on stream and pull out background music. One, two, 1, 2. Sound. 1, 2, 1, 2.
Good morning, everyone. We just allow the last few delegates to grab their seats. Perfect. Good morning, everyone, and welcome to the 2026 SAMA Clinical Coding Conference. My name is Dr. Andrea Jacobs, and I have the privilege of serving as your program director and host for today's conference. I would like to extend a warm welcome and sincere thanks to all of our speakers, delegates, sponsors, partners, and organizing teams. Clinical coding plays a critical role in modern healthcare systems, influencing clinical communication, governance, reimbursement, data integrity, healthcare sustainability, and patient care outcomes. This year's conference theme, Innovate to Elevate, speaks to the importance of continuously strengthening our systems, advancing collaboration, and embracing innovation across the healthcare landscape. We have an excellent program ahead, bringing together experts from across healthcare, technology, governance, and funding sectors to engage in meaningful conversations that challenge our thinking, strengthening collaboration, and support the future of healthcare delivery in South Africa. Just a few housekeeping points before we begin. The restroom facilities are located on your left, and refreshments, including tea and coffee, will be served further down the corridor during the scheduled breaks. May I kindly ask that all mobile devices be switched to silent mode now for the duration of the sessions. Should you require any assistance throughout the day, members of the organizing team will be available to assist you. Thank you once again for being here. Please also remember, if you've booked with ConfGo, if you are to check out tomorrow, please recheck in if you are staying for the rest of the weekend. Without further ado, it is my pleasure to introduce our first speaker, our SAMA CEO, Dr. Mzuno Dikida.
Thank you so much, ladies and gentlemen. And I'm not used to have such a very thin kind of mic in front of me. I think we are really innovating to elevate here in the kingdom of the Zulus. Let me take this opportunity and welcome all of you here in KZN. Special greetings to our colleagues from the Americas. The American Medical Association is here with us today. Dean Paresi, and is accompanied by, I don't know, Dean, if you want to maybe just stand up for the colleagues to see you. Dan is going to have to do the same. Dan is from the, I just want to see that I'm getting the acronyms correctly. It's AAPC, yes. Dan is leading the team from the AAPC, from the Americas. Yeah. So thank you very much, colleagues. It's really an honor and a pleasure for me to be here in front of you today. Of course, I was not really prepared to open the coding conference. I was looking forward to open the main conference, but I think the coding conference acts as an important precursor to the summer's conference tomorrow. And I must say that as the association, we are starting to realize something that you are telling us as coders in the country and as practitioners in the country, that there is a gap in coding in South Africa. We've had about two dialogues that we've organized last year, and they were all oversubscribed. And we started asking ourselves with the team in SAMA that, is there a gap that we probably are not filling? And that's why we felt that we must set this day aside specifically for coding today. And when we were planning the conference, I must also tell you that the first seats to be taken were the coding seats. So when I was talking to our colleagues last night from the US, I was saying the conversations we were having 2 years ago about the possibility of an academy for coding within SAMA is actually, there's no time in history that was more needed than it is now. So with those few words, I want to welcome you and say the South African Medical Association acknowledges that we still have a huge problem with the National Health Reference Price List of 2006. You can imagine, and I'm quoting 2006. That's because that's the default reference that you have in the country. And medicine has evolved so much since that time to now. And SAMA's coding team is working very hard to make sure that that gap is closed, working closely with the medical aid schemes and with our specialist societies that we have in the country and the CMS on these important matters. I think it's important for the medical practitioners to have ownership of these things. That's why SAMA is really proud to play this leadership role in coding, because we can't leave what we refer to as almost the cardiovascular system of the private health sector to chance. So we as a professionals have the responsibility to actually take charge of this. The Department of Health has committed itself to implement what came out of the health market inquiry. And we are also very happy under the leadership of our chairperson who's just walked in, that we've agreed with the minister that we must have regular conversations about reforms within the health system. So all the recommendations that were there, I mean, it has gathered dust now, you would know, the health market inquiry report. But we've agreed, at least with the minister, that we should be having regular conversations on this. So as part of the new coding process, we continue to engage medical aid schemes on new codes intended for publication in the MDCM, with the aim of addressing gaps in reimbursement and in new codes. Our head of the specialist committee is here today, and let me acknowledge your presence, Dr. Conrad Mashilwane. Thank you very much for the work that you are doing with the team at SAM. Maybe you should also just stand up, Conrad, so that they can see you. Yeah. So as a South African Medical Association, we continue to maintain a very strong relationship with our American counterparts, the American Medical Association. And in this regard, we are the sole provider of the CPT licensing within the Southern African region. They will tell you that I drive a very hard bargain. I spoke to them yesterday and I said, we're gonna have to extend that sole provision to the rest of the continent. Because SAMA is probably, maybe I must also say this, that our chairperson is currently the president of the African Coalition of National Medical Associations. And we have a leadership role there. Our colleagues have acknowledged this, and we think that it is important that we have that right for the rest of the continent. So we're very pleased to really announce that our second edition of the Coding Campus will be available to delegates who are attending this coding conference. We really appreciate that you've made the time to be here. But I probably be fired if I leave this stage without acknowledging the presence of the president or the chairperson of the South African Medical Association. And I think it's important that he must greet you, colleagues, today. I know among us there are representatives from the Kenyan Medical Association, Dr. Elizabeth Kitao. I don't know if she has walked in. We also have gotten a request from the Zambian Medical Association to attend today. I am not sure if they've already walked in. They could probably be still having some breakfast somewhere. But ladies and gentlemen, the president, the chairperson of the South African Medical Association, to just greet you. Thank you very much. Dr. Mzugwa. Oh, today you've got a tie. You've got a tie. Yes.
Good morning, colleagues. To the president of the South African Medical Association, Professor Naidu, I'm not sure if he's around, the leadership of the South African Medical Association, Board of Directors, our CEO, colleagues from the American Medical Association, and our counterparts from the Coalition of the African National Medical Associations. We acknowledge you. I know that we have our political capital, that is Zambia, amongst us. And I also acknowledge that there's Kenya and many other colleagues that are coming that have not yet declared themselves if they are here. I just want to acknowledge you and appreciate the fact that you've taken time to come down to Durban to embrace this very important and critical conversation that we are having as the South African Medical Association. We are privileged as SAMA to have a younger CEO to be taking us through this thing, and navigating the space. I think as I will be stepping down as chair in July, I'll be leaving the association, in the hands of good and younger leadership. And I think we are going forward, and welcome to KwaZulu-Natal. You can see it's not only the hearts that are warm, even the weather is warm. So thank you so much, colleagues. All the best.
Z, thank you very much, colleagues. Thank you.
It is now my great privilege to introduce our keynote speaker, Professor Morgan Chetty. Professor Chetty is a specialist family physician with more than 4 decades of experience in healthcare leadership, quality improvement, clinical governance, and health system strengthening. Throughout his distinguished career, he has served in numerous national and international roles, including advisory positions relating to healthcare reform, patient safety, quality in healthcare, and healthcare benefits in South Africa. He is widely recognized for his contribution to healthcare leadership and innovation, and has received several prestigious awards, including the Discovery Health Life Achievement Award for Quality in Healthcare and the BHF Titanium Award for Excellence. Professor Chetty is also a respected author, educator, mentor, and international speaker with a particular passion for best practice medicine, patient-centered care, and sustainable healthcare reform. Ladies and gentlemen, please join me in welcoming Professor Morgan Chetty.
Good morning, colleagues, Program Director, the executive members of the South African Medical Association, distinguished guests. It indeed gives me privilege to set the tone for this one-day meeting, but I want to say very clearly that when you talk AI or when you talk anything to do with technology, if you want to frighten anybody, frighten practitioners. They see AI as a competitor and not as a complement to healthcare. So what I'm going to do is I'm going to set the tone, discuss a little bit of the vocabulary. I don't intend to do a deep dive into the vocabulary. I've looked at the program, and I think individual speakers are going to be taking you deep into what let me say what the mnemonics stand for and how they all come together. And I think at the end of the day, we will get a fair idea of how all this comes together, and it's not intimidating. Maybe it's easy for me to say that because I'm not in active practice. So, medical coding per se is the backbone of health reimbursement and data management, and has been labor-intensive process reliant on human expertise. As healthcare grows more complex and data volumes increase, the traditional approach faces mounting challenges. And these challenges are reflected as errors. I want to pause and say, when I say errors, I don't think these are intentional errors. These are errors because of the complexity. Inefficiencies in the health system, we see that very often, and delays in the way we submit accounts and get our queries attended to. But this altogether costs the healthcare system billions annually. Enter AI, a transformative force that is redefining medical coding as we know it of 2026. This is only the beginning, and if we put in 2 or 3 landmarks, we have 2030, the UN date for SDGs, we have 2063, the African Union concept of the Africa we want. So we have a lot of deadlines that we've got to find how all this fits into it. Imagine a world where medical billing errors are the thing of the past and healthcare providers can focus on patient care. And I think this is one of the things that I'm passionate about. I'm passionate about the fact that we don't spend enough time on clinical care of our patients. Maybe some of you all do, but many don't. It's because of the challenges around us. So the healthcare industry is no stranger to technological advancements, making a profound impact on medical coding. AI-driven systems are revolutionizing the way medical codes are signed, where they are reviewed and processed. Digital technology has helped in a wide healthcare functions such as data collection, research, medical billing and coding, remote monitoring, compliance with health regulations, and timely diagnosis and treatment of diseases. So it's got a big repertoire of benefits and uses in not only in the healthcare industry, in virtually every single industry. From diagnosing medical conditions to personalizing treatment plans, AI is making healthcare more efficient and effective. The biggest advantage of using technologies is streamlining each function optimally, saving time, reducing medical paperwork, which is the biggest bugbear into the healthcare system. On a daily basis, we are sitting with queries about how do we archive millions and millions of pages of important information that we may be called to use in the future. And removing medical errors. The healthcare industry is evolving at a rapid pace. When technological innovations transforming the medical services are delivered, documented, and processed. One critical aspect in healthcare administration is medical coding services. The process of converting medical diagnosis, reviewing medical notes, procedures and treatments into standardized codes for billing, for record keeping, and data analysis. In recent years, significant technological advances in medical coding, software, and artificial intelligence have streamlined workflows, improved accuracy, and enhanced efficiency across the healthcare sector. You must forgive me because I'll have to look at 3 screens, and let me do a disclosure. I'm just a few days past having had my cataract removed. So I'm seeing Mazuka there twice. So traditionally, coding has been labor-intensive, process handled by certified medical coders. That's a huge industry on its own. Medical coding is an accurate process for accurate billing and patient record management. AI has emerged as a potent tool to revolutionize medical coding. Now, having said that, let me look at the impact that not having coding and not having these benefits and these tools have. And I've extracted some information because when you use a rand value, it sounds very small. So I said to our American colleagues, I decided to use the dollar. It makes it big. So estimates of research in the US found that 80% of medical bills contain errors. These errors cost the Americans $210 billion annually, just on errors. And up to 75% of medical bills contain coding errors that amount to 42% of the Medicare claims denials. Compounding all this, approximately a quarter of the US healthcare spending goes to administrative functions, away from clinical functions, and AI is brought in to revolutionize accuracy and productivity and reduce these huge financial burdens. Even in South Africa, we are grappling with the fact that of what the patient pays in for health care, and it's so variable, the amount of money that actually goes for clinical care and amount of money that goes for non-clinical or administrative care. As the healthcare industry continues to adopt new technologies, AI is making a profound impact on medical billing. AI-driven systems are revolutionizing the way codes are done. I've said that so many times. I think it's very important because the average practitioner, the average person out there, keeps commenting on the fact that it's going to replace our jobs. What does AI do as well? It helps in codes being assigned, reviewed, and processed, resulting in higher accuracy, faster turnaround times, and more efficient workflow for healthcare providers and coders alike. AI in medical coding refers to the use of machine learning algorithms, natural language processes, NLPs, and predictive analytics to streamline the coding process. I will not go into details on these terminologies, but I think the subsequent speakers will talk about how these processes work. But as coding gets more and more efficient, it becomes more and more automative. It becomes more and more accurate that you can actually complement and remove the human element from it, but you can't remove the human element completely from the coding process. With the vast amount of data in healthcare, ranging from clinical notes to lab results, AI systems can analyze this information, extract relevant details, and automatically assign medical codes. Sophisticated algorithms can analyze vast amounts of medical records, identify and categorize information with superior accuracy, reducing human error, streamlining workflow, enhancing the quality of patient care. One of my preoccupations is looking at all the modalities, all the challenges, and everything that compromises patient care. The centrality of the patient in the healthcare system and the fact that he deserves quality healthcare sometimes eludes us. One of the most common applications of AI in medical coding is automating routine and repetitive tasks. AI algorithms can scan physician notes, identify key terms, and match them with appropriate codes. I'll give you just an example, and it's not just meant, we understand there's lots of other interest in the audience besides just medicine. Example, acute bronchitis. In a patient clinical record, an AI-driven system can recognize this diagnosis and assign the corresponding ICD-10 code. This is so important because in the last 30 years, I've been involved in a program called peer mentoring. And I keep finding a difficulty with data, a difficulty with recording, where a diagnosis of upper respiratory tract infection is made. And when I look at the prescription or the laboratory results to confirm this so-called upper respiratory tract infection that doesn't need too much of confirmation, I see lots and lots of other things being done unrelated to the code submitted. So we don't have a better feeling, we don't have a better understanding of what the impact it is and what are the multiple other issues that that practitioner has to contend with besides just the code to get paid. By automating these tests, AI frees up the medical coders to focus on more complex cases that require nuanced judgment. This leads to greater productivity and allows the healthcare organization to handle larger volumes of patients without sacrificing accuracy. In the third world country, particularly in the low and middle income countries, one of the challenges we have is that the number of patients that each doctor has to deal with is enormous. And we've got to find a way to help these doctors to free them from these large volumes so that they spend more time in clinical care. But in the same time, generate accurate data. And this is the data that helps us to readdress and address the health system needs. Very often we do this on guesstimates, and I want to caution us here. This is South Africa, with the South African challenges, with the South African culture, with the South African specific disease burden. Importing the issues or the solutions from abroad doesn't address our needs. And we've been doing that since 1994, calling in external experts to manage our South African challenges. This is now something of the past. AI-generated suggestions still require review and validation by the experienced billers and coders. I also want to add to it before I get to this. Medical coding is a process taking the patient's diagnosis and treatment notes and converting this into what we call alphanumeric codes for accurate billing. I just labeled just a few, just to get you to see something that I'm saying, not in abstract. These are the different types of codes that we use, and somebody must be competent enough to choose the right code or the right combination of codes so that we have the right data at the end of the day. So the different codes will be the CPT for codes, the International Classification of Disease, Health Common Procedural Codes, RPLs, UPFS, and the NAPI codes. I just want to pause and tell our American colleagues that 35 years ago, I was with the task team that attended the American Medical Association meeting for about 10 days, looking at then how to adopt the RBRVS system in South Africa. Since then, I've become gray, and younger people are doing it. So there's a wide variety of software solutions and tools that are available that automate and assist coders in accurately translating patient information into codes. These tools have a profound impact on the accuracy, speed, and efficiency. So we have to have an interim kind of body that is able to validate the codes that are most appropriate for our uses in the various disciplines that we work with. So some of the coding softwares and tools. We have electronic medical records for integrating. Sadly to say, till today, a number of our practitioners still use paper-based records. And this is really cumbersome. It doesn't give us a good idea of what the data is, and it also doesn't help us to give a more evidence-based scientific reason of how we manage or adapt the healthcare system. AI is expected in the coming years, and one of the most anticipated advancements in the integration of AI with electronic medical records and appointment scheduling. Just to tell you, the National Department of Health has completed and has done various studies in the CUPs and areas on the new electronic medical record system that they have developed. And just to give you a little bit of comfort, it's interoperable with the systems that you already have. But we've got to have a sight of this, and we've got to work with them. Electronic medical record stores detailed patient information, including medical listing, clinical listing, lab results, diagnosis, and treatments. The coding software is often embedded within the integrated with the electronic medical records. So I think it's time that we embrace this, even in the early stages of our lives, to try getting used to electronic medical records. The adaptability and the uses of this is enormous. I was just asked the other day by a practitioner is that I have a bundle almost in my garage of all my patient records. I've been in practice for long. What do I keep and what do I discard? So this is where we've come to. And with this system, we can archive very easily in the cloud. We can do a lot. We can get information retrospectively to help us to move forward. Coding software is often embedded within these, and one of this is the computer-assisted coding is one of the most transformative tools in the realm of medical coding. The CAC system analyzes clinical documentation and automatically generates appropriate medical codes. These tools use natural language processing to interpret physician notes, lab reports, and other unstructured data in the physician records, providing coders with preliminary set of codes to review. The CAC software reduces the risk of errors that can result from human oversight and fatigue. Another fallback that we have that coders can use, practitioners can use, is coding, auditing, and reliance tools and compliance tools. The accuracy of medical codes is essential, not only for paper billing, but also for compliance with regulatory standards. Auditing and compliance tools analyze coded data, identify discrepancies or errors in coding, that may need to be corrected. These are often programmed with specific payer rules, government regulations, and industry standards, allowing it to quickly flag deviations. We also have a fallback onto coding databases and reference tools. In addition to integrated solutions, coders often rely on sophisticated coding databases and reference tools. These resources provide up-to-date information on medical code rules and reimbursement policies. We live in a time of uncertainty. We live in a time of regulatory reform, and it's important that we have people who are dedicated to keep pace with these regulatory reforms and changes. So in conclusion, digital transformation is the integration of digital technology into all areas of business, just not healthcare. Fundamentally changing how you operate and deliver value to your customers. I'm sorry for using the word customers to include our patients. AI is changing the foundation of medical billing and coding, reshaping how health professionals process claims, audit data, and ensure compliance. By 2030, it is predicted that every certified coder will work alongside AI-driven tools that learn, that interpret, and predict errors before they happen. Medical coding automation is more than a trend. It is becoming the core part of modern health operations. So in conclusion, I want to make two statements. I think we need to strive not to be a success in our own rights, but to rather to be of value to our patients and the health system. And I want to leave a message. AI is not a challenge to you. Your colleague who is AI competent is your future challenge. Thank you. I'm told that this is a computer.
One that is ready for AI, Prof. I must say, I do agree. Perhaps it is time we fully embrace electronic medical records so that our coding colleagues no longer have to decipher a doctor's handwriting. Please allow me a moment to acknowledge the following guests in the room. May I ask them to stand? Dr. Masiku Piri, President of the Zambian Medical Association. Dr. Elizabeth Gitau, Chief of Staff of the President of the World Medical Association. Building on that foundation of Prof. Chetty, our next session explores how digital transformation is actively reshaping clinical coding practice. It is my pleasure to introduce Dr. Lee Moses. Dr. Moses obtained his MBCHB from the University of Pretoria in 1995 and has extensive experience in managed healthcare and medical coding. He has worked across primary care, hospital benefit management, coding education, and advisory committees with expertise in ICD-10, CPT-4, alternative reimbursement models, and healthcare data analysis. Dr. Moses currently serves as a medical advisor, quality and risk manager at Best Med Medical Scheme, with a strong interest in AI, machine learning, and the future of clinical coding in healthcare. Help me welcome Dr. Lee Moses.
Good morning. It really is a big privilege to be here, and I want to say thank you for the opportunity. I want to thank Salma Exco. I want to thank everyone that has been involved with the arrangement of this. It's been just one awesome experience. I would like to say that, and I would like to acknowledge that. And I would also like to welcome our delegates and our guests from abroad and from the rest of Africa. It really is a privilege also to have you here. Be very, very welcome. Obviously, I want to extend the thanks for our delegates, our speakers, and all the other guests that are here. And I hope that you'll find it interesting. I'm very interested in coding. I've been interested in coding for a very long time. And it's one of the fundamentals, as Prof. Chetty has indicated, in healthcare. But I actually want to extrapolate a little bit further, and I want to say that it's one of the things that are changing our life in modern times. Initially, I used Google for a lot of things. Now, I rarely use Google. I've now changed to some of the other models that are there available, so not promoting anything, just mentioning it. So I've been told I have a very dry sense of humor. I want to apologize for that up front. So if I didn't offend you, just hang on, we might get there. That'd be one of them. Please feel free to laugh extravagantly. These things are... Please don't try this at home. It's trained professionals only. Okay, can I have some binoculars? I just need to check my notes. So we're talking about Innovate to Elevate. Those are my disclosures, and I want to disclose also that my... Thank you. They actually could do that. I want to disclose that I support Liverpool Football Club, not for the past few months, but hopefully things will change there. So this is going to be an interactive session. So one thing I want to please ask you to do is, who sees, that's supposed to be a chessboard, okay? Who sees a whiteboard with black blocks on? Can I see by show of hands? This is not a trick question. This is just a random poll, right? Thank you. Who sees a, so we say white block with black blocks. Now we say a black box with white blocks on. Who sees that? Okay, can we agree that that's a very simple picture? I mean, it's very basic in its structure. So imagine having something like that and being presented with something like that as clinical notes and coding from something like that. So we're looking at people already looking at exactly the same thing on the one side and seeing different things, and then presented with something like this and having consistency in coding. So what I want to say is, it's not easy. It's not easy. And that's why I'm very grateful for AI, because AI, and Prof. Chetty mentioned, I'm going to reiterate a lot of things that Prof mentioned, Prof being one of my tutors and trainers in many aspects. I want to say thanks to Prof for that as well. But we need to move away from things like that, because we lose a lot of information. And ultimately, the information we lose is information that benefits the patient. And the patient has to remain central to whatever it is that we're doing. I'm addressing this as a clinical coder, but also obviously as a clinician. Patient has to remain central. Right. So we've done now the icebreaker. It's not that cold, but that will serve as the icebreaker. So we are going to be talking a little bit about digital transformation in healthcare, and just take 5 seconds just to memorize that. 4, 3, 2, 1. I also couldn't do that, so I'm just going to skip past that slide. So what's our current situation? Why are we doing bad? Let us just review the claims review process, just to make sure we understand why we're actually here, why we are talking about the things we are talking about. We're looking at patients receives medical services, service provider submits claims, There's a claims assessment that happens in the background. There's some claims decisions, either reimbursed or not, patients notified. Sometimes not all the claims are paid, and there's an appeals process, and I think we're familiar with then the back and forth and the up and down of correspondence just to get payment for this. Hopefully there's feedback and resolution, and then there's record keeping. So this hinges 100% on codes. 100% on codes. So translating what we receive into clinical codes. So I would like to propose that the function, current function, foundational function, core functions, or important functions of a clinical coder, it's a healthcare, and I want to underline professional. It can be the lady in the front, it can be your cousin's, mother's, brother's, sister's, aunt. But ideally, it should be a professional, so someone with experience, and we've also indicated a little bit, we've alluded to it, someone with encoding. Right. So who translates patient medical records, including diagnosis, procedures, these type of things, equipment, services, into standardized regulated alphanumeric codes. Example, ICD, CPD, RPL, UPFS. We're not even going to refer to DRGs and PRGs, your diagnosis-related groupers, procedural-related groupers, but these are things that are built on this. So we're just keeping it basic. For billing, reimbursement, and then also most importantly for data analysis. Because we're sitting on a huge amount of data and we're not using it productively, we're not using it sensibly. We're using it for, okay, these are the codes, we have check blocks next to it and we're going to pay for it or not. And we are sitting on a wealth of information. With the introduction of AI, now we have a tool that will enable us to collate and to look at the bigger picture of the patient, for the benefit of the patient. Right. So there is a duty in terms of, I've just put that up there, where coding is referred to by the Council for Medical Schemes, healthcare, coding in healthcare. So there's a little bit of a duty, a responsibility on clinical coders to adhere to that. And the one that we're looking at would be number F, relevant diagnostic and such other item codes that relate to relevant procedures. So there is a duty in terms of the Medical Schemes Act. And if we look at the coder's ethical principles, there's a little link there if you want to copy it. But these are the foundational things that we must remember as coders. Whether we code as an exclusive clinical coder or we as a clinician or healthcare provider also code, these are the things that has to be adhered to. For instance, number 8, clinical coder shall ensure that clinical records contain justified selection of diagnosis, procedure, treatment, consulting clinicians as appropriate. Okay, clinical shall participate in quality improvement, in quality activities to ensure that the quality of coding supports the use of the data, research, planning, evaluation, reimbursement in the spirit of mutual respect for colleagues. So not fighting, interacting. Okay, so there's the ethical responsibility also. So I would propose that the aim of technology in clinical coding, in the coding environment, must be moving from a manual, and Prof also, we haven't colluded, Prof and I haven't talked before our presentation, it's so aligned, it was just amazing. I was sitting there thinking, I can just say any questions to Prof and then call it a day, but I've been given 20 minutes, so I'll be taking 30 minutes. That's another joke, you may feel free to laugh now. Moving from manual or even paper-based silos to an automated, integrated, data-driven, patient-centric, evidence-based, so there's lots of other words that we can put there, ecosystem. And we are now able to do that. So if we look at the flow of data, we're looking at source data, and we're reminded again on of the first picture, the chess board, and then the very eloquent notes that have been scribbled next to it. So source data that has to be translated by either the clinical coder or the tool the coder will be using in terms of to form a coding data repository that can be drawn on for different things, for informing healthcare policy, for optimizing funding, getting reimbursement, for optimizing patient care, for research, and for predictive analytics, which is something that's very interesting. So if we could make predictions, we're going to go towards patient-centric care and targeted pharmacogenomics, and that will depend 100% on the information that we received in order to achieve that. So what are the challenges? There are some challenges. We sometimes use people in our practices, and sometimes the clinical coders lack knowledge of the newer procedures or clinical knowledge. You need to have some sort of clinical knowledge to understand coding, if I'm going to be very honest. So you need to understand there's a difference between a humerus and a femur, and tarsal and carpal. I know they sound the same, but they're not really the same. They're almost on opposite sides of the bodies. Of the body, so that's going to be important. In order to minimize misinterpretation or misunderstanding, so that the communication is not inefficient or deficient between stakeholders. And yeah, I want to emphasize between hospitals, between specialists, between referrers, clinical coders, funders, patients, and whoever is involved there, all the stakeholders. All right, we need to ensure quality, and we need to understand there's complexity to coding. Prof alluded to bronchitis a little bit earlier. So there's some treatment that one expects when a patient has bronchitis. We are not going to do an open reduction in internal fixation. Now, while this may sound crazy, these are exactly some of the things that we are getting. Open reduction, internal fixation for the treatment of bronchitis. No, I still can't bring that together. It hurts. Okay, and then we need to apply coding rules, modifiers, and interpretations on that. So it's not an easy thing. It is complex. People make mistakes, and it's not malicious intent. Sometimes it is. It's not usually not malicious intent. There are new procedures. We're moving away from the 2006, or we're stuck at the 2006. I know there are some associations that are working at moving away from that. And these are things that we actually have to become involved with. We need to work together in order for us to change our targeting. We're going to get to that. Right. So the next one is also a slide that's very busy, so I'm not going to apologize for it, and as soon as it appears, there we go. It echoes a little bit of what Prof. Morgan has said. We take source information, and we translate it into ICD-10 codes. We link to that RPL procedure codes or CPT procedure codes. There are NEPI codes for products and devices that can be implanted or not. And then there are NEPI codes, a validation in terms of PMB that determines how this will be reimbursed. Okay, PMB for our out-of-town colleagues, not Peter Maritzburg, prescribed minimum benefits. Okay, taking all that information and plugging it into a central EHR system, electronic health record. In other words, what I'm proposing is that we need to have access to that information. It has to be accurate, it has to be complete, in a very efficient manner, in a very effective manner, so that that information is available for the practitioner, for the clinical coder, that can be submitted to a funder for reimbursement, that can be submitted for data analytics. We had a little bit of a hiccup, I believe, with COVID-19 in terms of the coding, and I suspect that there might be some boat somewhere in some ocean that also will be giving us a little bit of a headache if we don't address it and address it appropriately and timeously. Right. So, what I want to do, the next slide is, so we've talked about source information, we've showed the doctor's note, and we've had a look at some of the other stuff. I want to go one step further. And what's on the slide, there's an iceberg, and underneath that's an iceberg, and underneath the iceberg there's a lot of information that we are not capturing. But I would argue that it is important, maybe imperative, maybe vital, maybe profound, for us to catch that information, for us to have a holistic view of the patient. When we're treating the patient, it's not going to be only what's in front of me. In other words, there's data out there that we should have access to in terms of wearables, biosensors, So social behavior and the information on Facebook, what I did this weekend, what I drank the weekend, that's information that can assist in building up a very complete medical record. Okay? Nutrition, what's the patient eating? People take photos of themselves a lot and then photos of their food. That gives some nutritional information. So the information is there. The information is available. It's scattered all over the place. We need one place where all that information comes together for the patient to be able to transfer that information to whoever it is that is now treating the patient. And we need to do that in an effective way, and we need to do that in an efficient way. And one of the ways we can do it is with the help of artificial intelligence systems. Right. So imagine we have all that information available, and we build on top of that expert opinion, case control studies, code studies, randomized control trials, clinical appraisals, systemic reviews. We will have evidence-based medicine that cannot be refuted on any level. I would be able to treat a specific patient for a specific condition at the correct time with no contention of my treatment, because it will also be based on and supported by evidence across the board. So we'll be able to pick up things that we are missing now, that we are dropping the ball on now. Not because we're not equipped. We are now in a position where we can be equipped to do these things. We need to move away from silo type of information gathering, and I know it's difficult getting lab results. A lot of inefficiencies as well, because if someone refers a patient to me, I'm probably going to repeat the results. I'm not going to trust really the results that I'm being handed. So there's a lot of replication, duplication, sometimes maybe unnecessarily so. So there's a lot of optimization that we can work towards. So in terms of unlocking the potential digital transformation, we can look at the electronic health record. We can get the information from the other devices. We have a clinical coder. Traditionally, we use clinical coding tools. We use books. I remember using 3 books. You have to use a third one for table index, and try to find within 300,000 million pages some of the words that I'm looking for. It was very tedious, and that's just the ICD-10 component. I can see some people smiling. I apologize for that nightmare image that I've conjured up, but it's a lot easier now. There's a lot more efficiencies now. So what we do is we take that information, and then we have dynamic population information. If we have access to all this information, then we can do predictive analytics. We can go to someone and say, listen, these are your habits. These are the problems. This is what you should do. This is how we prevent stuff. Not when someone is in hospital and say, oh, yeah, okay, no, let's give you some statins. No, we should have given statins before that. In fact, we'd have started with exercise before that, probably. So this is how we prevent catastrophe. So all of this must be geared towards patient care. Obviously, we've mentioned the pharmacogenomics, genetics, and we can also do precision funding and revenue cycles. So imagine having all this information and submitting to the scheme. What position would there be in the scheme to say, no, we're not going to fund for this? However, if the scheme does not have the information, if I'm going to code bronchitis and I'm going to do the procedure for open reduction and internal fixation of an irrelevant bone, that makes it difficult. That causes inefficiencies. That causes queries. That causes delay in payments. And ultimately, that is unnecessary. That can be avoided. So what are the challenges? So we need to look at AI. We need to look at the tools out there, and we must understand. We have to understand the tools we're using. We have to understand the car that we're driving. We have to put in petrol now and then. We have to put in oil. We have to replace the windscreen now and then, put in a steering wheel. You know, we put local nuances in that image. But ultimately, we need to understand what's happening in terms of AI. So AI is trained on models. And Prof mentioned some models, and there are lots of models that are available. And in terms of the models, the data is implemented. AI does natural language processes. There are other models that can interpret the information in the data, and then there's an algorithm that's created. So that's an application, and that application can be in the form of an agent that's running or plug-in application or things like that. And that can actually handle maybe 95%, 96, 97% of queries, of claims, of processes. So that the clinical coder just have to deal with the 2 to 5% of the difficult stuff. But the machine has to be trained to do that, and that's important. If it's not trained, it's not going to work. It's going to be with a car without oil or petrol or wheels. It's not going to go that well. All right. So what are the advantages if we do that? Increased accuracy, cost reduction, real-time coding, so there's no delay in anything, enhanced speed and efficiency, improve compliance, and then we are going to reduce burnout because of up and down communication the whole time without effect. So, are there disadvantages? I won't say disadvantages. There are some risks. There are some prerequisites that we need to be cognizant of. First of all, we need to understand that the model is trained on data. And guess what? The data is now reliant on what we submit now. So if we are going to submit bronchitis and the treatment for that being an ORF, the AI model is going to learn that for bronchitis, the treatment is an ORF. So what I want to ask is, whatever we do, so we need to look at the accuracy of what we're doing now and understand the implications of it going further. I know reimbursement is important, but I also know coding accuracy is very, very important for the patient. So what are we doing now? We form the basis of what's going to be used further on. Right, so if we don't do that, what are we going to do? We're going to have data bias inaccuracy, we're going to have compliance issues, there's going to be expenses that we are going to incur because we're going to do things again and again, and it's actually not going to help. So it's not going to be improved efficiency, it's going to be frustration, headache, costs, and not reaching our goal. So how do we do this? How do we get accurate? So how do we improve in our accuracy? Remember, quality is one of the things for coders that we have to adhere to in terms of the ethics. So we have to talk to the doctor, first port of entry, talk to the hospital, look at the claims that they are giving. We actually have to be able to pick up a phone and speak to a person for now on the other side and say, listen, this is what we need to... All that slide is saying, it's a lot of ports, but what it's conveying at its core is communication. Communication. Like my mom told me, use your words. Took me a while, sometimes I still struggle with that, but use your words, communication, all right? So, when I look at clinical coder now, I think we need to transition from the clinical code in the traditional sense, that managed chart, look at patient notes written by doctors' handwriting. That's focused on reimbursement only. That's important for now, but it's focused on reimbursement only. We're looking at it retrospectively after discharge, and we're looking at it as transactional workers, and we need to understand that it has to evolve, the function it has to evolve. AI-assisted validation with human in the loop, so coders, your work is safe. Human in the loop, that's coders. Focused on value-based care. Value is defined as, well, one of the definitions is quality over cost. Quality over cost. So value-based care, concurrent, in other words, supported by real-world data, not historic data. Historic data belongs in the past. It's important to take cognizance, to have cognizance of it, but it's important to apply it. It's not, yeah, that happened, well done, you know, yeah, you got the shit. In other words, the clinical coder must evolve to become the strategic partner to clinicians and insurers. There must be an evolution. Can't just be someone that try to decipher documents and try to assign ICD-10 tasks on a code by case basis. Right. Case examples. So are we doing that badly? Yes, we are. So I've just taken 3 main examples there. I apologize, it's a bit small. I'm going to read for you the first example. And for my own benefit, I've numbered them number 1 to 3. So I've got that under riff as well. And, I see people smiling, thank you for that. I've got names and stuff. Okay, please advise if code 0193 can be added to the treatment plan for this member. Now, that was asked. So the reason why that is asked is either the member hasn't been diagnosed with a condition where that code applies, where the information supporting their diagnosis wasn't submitted, where the patient hasn't been registered for their diagnosis. In other words, the application of the code is now in question. That is lack of information. Right, the second one is, initial ICD-10 code provided was J22, which is a non-PMB. Hospital updated the following codes, and that's excellent. But the code should be updated not from the hospital side. Guess what? The person who determines the ICD-10 codes, ICD-10 is diagnostic codes, is the clinician. Must be updated from the clinician side. The information is there, but the avenue the information enters is not appropriate. Right? Third one, some information is, although no casualty consultation notes or referral notes were initially submitted, the case notes below reflect acute metabolic abnormalities and indicate urgent medical management. So these are things that's extracted up to a point where if the information is available upfront, these delays and these requests can be avoided. So what we are doing is, when we don't submit information, we are fostering and we are paving the way to inefficiencies. So, luckily there are tools out there, such as the one that I've taken some screenshots of. So, and this tells you at the very minimum that we can look at in terms of what's available online or what's available electronically. It's tools that can have a look at your ICD-10 codes, your RPL, your CPT codes. It can look at clinical validation. It can also assist with cross-mapping. Cross-mapping is just the link between the different codes. That just makes it easier. So you can use books and the 49,000 ICD-10 codes on the tabular list, the ICD-10 coded, PMB coded list, or the 147,000. It can get difficult. There are tools there, and if we are not using it, I'm not sure we're helping the patient. I'm not sure we're enhancing practice efficiencies. We need to really consider why we are using it, and if there's still place for us to be using the old tools, the books, the papers, and if there's not a better way of doing that. The blocks number 3 and 4, that's been in a red box, and that represents AI, so artificial intelligence. And you can actually ask it a question. So I've asked it a question. I've said, give me the RPL codes for Z plus T. And it's given me a long list of codes, in different applications, and also interpretations on that codes, which makes it a lot easier to pick the correct one, the most appropriate one, the one that I've actually used, the one to the benefit of the patient. Right, where to from there? We've got all this information, everything is collated in an electronic health record, everyone has access to it, we're all very happy, AI is interpreting and sorting out the different type of information and drawing graphs, and we do predictive analytics. And this is basically what we can do with predictive analytics. So we can, in our clinical practice and elsewhere, we can look at chronic disease management. I can see whether this patient is okay with injections or oral medication, what the compliance will be if I prescribe medicine. If I prescribe this medicine, what's the history of compliance for the patient that would take that medication? It doesn't help me prescribing a medication or a molecule that the patient historically has indicated that they will not be taking. It's a very fruitless exercise. So the data is there, the data can help us to make the decisions. Someone might be more, okay, no, give me an injection, I want this over. The other one is, please keep sharp things away from me. I'll take medicine for 4 years, that's fine. And we need to know this. We need to know this. This is how we help our patients. Okay, we look at early intervention for disease progression. In other words, now we can see the patient's eating wrong. We now get the results from his biometric devices that say, hey, listen, between 2 and 3 in the morning, this guy's getting a little bit of a problem in his blood pressure, in his pulse rate. Something's happening. Diagnosis hasn't been made, but it gives me an indication that I need to look further. And without access to that information, I'm not going to know that. We can prevent readmissions, we can forecast, we can do preventing patient deterioration in, for instance, ICUs. And the very last one is obviously to the benefit of the practice and the patient, we can effectively manage insurance claims, reimbursement. So, Prof mentioned computer-assisted coding. I know that it's in its second iteration now, CAC version 2. That's a lot better, that's a lot stronger, faster, more resilient. We will be looking at ICD-10 type of integration for the future. Blockchain data integrity and predictive analytics, we've discussed these things briefly. Obviously, we can go into much, much more detail in this. But the intention is to open and to see and to motivate to move away from paper and manual processes where possible. So remember that first slide, or one of the earlier slides, top left corner, where I said we can memorize it. So that's where we are, very complex. If we do it paper-based, manual, code for code, if we do it the old traditional way. And then if you take the symbols at the top of the left picture, and you just convert the wingdings into normal text, that's the word. Just imagine. If we do this, just imagine what we can do. Just imagine. So the idea is to move away from the burden of documentation to the joy of medicine. Let's get in a clinician area again. Let's get the coding sorted, let's get the reimbursement sorted, and ultimately at the base of it, let's get the patient sorted, the value-based care. Ladies and gentlemen, thank you for your attention. I hope that this has been stimulating, this has been interesting. I'm very passionate about coding, and I trust that I've been able to impart and convey some of my philosophies to you during this presentation. Thank you so much.
It's very insightful.
Thank you so much.
Thank you, Dr. Moses. We definitely feel your passion. Welcome, a warm welcome to our virtual delegates. If the audience would allow, we are slightly behind schedule. So in the interest of time, we're going to continue with our next speaker and will allow for questions at the end of the final speaker for the morning. Our next speaker, Dr. Anadil Asawi, is a physician and healthcare expert specializing in value-based healthcare, fraud, waste and abuse, clinical documentation improvement, and revenue cycle management. She's a certified coding associate from AHIMA and holds a master's in healthcare management from Geneva Business School. She currently oversees Solventum HIS products and clinical content governance across the MEA region, and consulting programs supporting DRG optimization, coding quality, and revenue integrity. It is a privilege to welcome Dr. Asawi.
Thank you so much. Am I audible? Can everyone hear me? Okay. And I hope you can see also my screen. Thank you very much. It's a pleasure to be with you here today on this conference, and I'm happy to be taking you through the session today on the future of medical coding, AI-driven transformation, which is relevant to all the other lectures that I've been going through. So first, allow me to take a minute to take you through the Solventum evolution in healthcare revenue cycle with the clinical intelligence that we have in place in order to have the journey over time, since we moved from traditional coding into an AI-enabled healthcare ecosystem. We started in the 1970s with a strong foundation on coding, And the goal at that time was to help the organization improve their coding accuracy and, of course, standardization of data. Because once we standardize the data and everyone is using the same coding terminology and classification, that is key for our data to be used in the future. As we entered the 1980s, the focus expanded toward reimbursement. Now the data is standardized and we're supposed to be helping the payers and providers to improve their financial integrity and have optimizing payment methodologies. When we went to the 1990s and the early 2000s, we recognized in the industry that accurate reimbursement is directly related to a perfect or improved high-quality clinical documentation. And that led to the growth of the clinical documentation integrity or improvement, and the CDI team came into the picture to help the physician improve their documentation. As we went to the 2010, the conversation shifted from purely financial outcomes to include the productivity and the quality elements, helping the clinicians and the coding team to work more efficiently. Now, we had to include the quality in there to ensure that care quality is improved and not impacted by the financial gains of the system, and to ensure that we have compliance at all times. But around the 2020, and because of how we saw the documentation is key for our reimbursement, we were faced with an increased pressure and burden on the physician for the administrative task, and that led to physician burnout. And because of that, we had to shift the focus into what we call creating time to care, so that we are freeing the physician from all these administrative tasks and have them spend more meaningful time with the patients. As of 2022, we entered the era of cloud and automation technologies. We started leveraging AI and machine learning in order to have the autonomous coding capabilities in place and advanced clinical insights. As of today, and since 2024 and beyond, the conversation added to it was the revenue integrity, or it's the modern type of denial management that has to take place. And this is connecting all clinical, financial, and operational data in order to have better clinical insights to always improve our revenue cycle simultaneously. Now, it's very important to show how this transition moved from isolated coding functions into all connected AI-powered homogeneous healthcare ecosystem. Of course, our main focus is at all the time to maintain operational excellence and keep the ecosystem patient-centric care at all times. However, what happened is there is a crisis because of the way the healthcare system evolved. But when we talk about the healthcare, we usually focus on physicians, we focus on hospitals, or on AI, or the patient experience. But we rarely pay attention to the infrastructure that runs the entire system together. And this foundation is medical coding. Now, in the healthcare system globally, we see that we reached a point where we have increased complexity of the coding demand and increased demand in the workforce with less of coders availability. So we had to rethink how we can make this coding and clinical documentation to evolve moving forward, because there's no way we can just keep adding individuals into the ecosystem and more manpower. And that actually leave us with understanding why we have shortage of qualified clinical coders. There are multiple reasons for that, and we see the main issue is the supply chain. There is lack of clinical coders because we have a lot of the coders from the time the certification started until now, they have been retiring, where we see the demand to fill more seats is faster than the available clinical coders. And with the evolving of the ICD-10 complexity in the diagnosis and capturing those procedures and different type of classification, that also provided a reason to find out how we can switch this conversation from only looking for coders. And also, we can't deny that the cost of that at the organization side became very burden at their end. And with the recent shift or transition toward ICD-11, that also adds another layer of burden for finding qualified coders with this new classification, as well as increased burden for training costs on the organizations. Another item that led up because of that shortage of coders, we saw the burden or the shift to drown the physician in clinical documentations and the need for them to adopt technology. And we know that this is not the physician's best forte to cope up with technology or use computers, and the move toward electronic medical records where the physicians had to do a lot of clicks and touch points on those EMRs, and the physicians being asked to do their own coding by themselves, and they are not certified coders, so physicians coding became a very hectic issue to them. And that burden that happened to the physician led to their burnout. And I don't necessarily believe that physician burnout is an adverse effect of the ecosystem. However, it is a system failure, because when you have technology give you such friction while using it, then the human cost becomes very real, and we have to understand how we can improve that. And as you can see on the screen with these statistics and different numbers that we've collected, we see that the physician time spent with the patient is only limited to 68 care versus a 19% of administrative burden to complete coding and the patient's files. And of course, we have additional 13% that's the other activities they perform during their work. So this physician burnout and turnover is really alarming, because, for example, 49% of the physicians, they take the documentation to complete at home. And some physicians report they will have to stay additional 2 hours post their long working hours, as we know physicians, and they would have to take that additional 2 hours to complete documentation. And actually, 1 in 3 doctors would consider changing their career because of the stress that comes of the administrative burden working as a practicing physician. Now, when we look at the modern ecosystem and how we approach it at Solventum, we combine our deep clinical expertise in place and couple that with the advanced technology in order to create a connected healthcare ecosystem. Now, this approach is unique. Why? Because we didn't start with technology alone. However, we start with clinical contents. And when we look at the clinical side, at Solventum, we bring decades of expertise across various areas, as you can see, nosology, patient classification, quality, health economics, and clinical documentation improvement. And when we couple that and link it with the available technology side, we combine conversational and generative AI, machine learning, predictive analytics, automation, cloud capabilities in order to have advanced reporting. Now, the key here is to have the healthcare transformation become sustainable. It's very important that these 2 items, clinical and technology, start together from the beginning. And when you build on that foundation, you will see that you will have workflows connected the ecosystem completely, from capture to code and quality and reimbursement and revenue integrity as a whole to pave the road. We begin with speech technologies. We have multiple modalities for speech technology that supports the physician and is very flexible on how the physicians would like to capture their documentation. This speech technology evolved into ambient AI, wherein it uses the conversational and generative AI between the patient and the physician to allow more time to care, as I mentioned earlier, and to help more natural patient-physician interaction to take place. Now, on top of that, we have what we call computer-assisted physician documentation. At all times where this documentation and dictation is being captured by the physician, it looks at the medical record and analyzes it at all times to identify any documentation gaps available so that it has an intelligent feedback loop to the physician to ask to improve the documentation and streamline it. Now, once this documentation captured from the physician improved with the physician documentation, it pulls into the CDI workflow. And here we have our CDI team work with intelligent prioritization to focus on the cases that have quality impact or reimbursement opportunities, since the physician have taken care of the physician documentation in advance. Now, as this advances, it goes into advanced coding technologies, and automation comes into place with high confidence on cases and codes. They will move to autonomous coding queues, while freeing the coders to focus on more clinically complex cases that requires human interaction and review. Now, as these go, we reach to the element of reimbursement and then the payment integrity, or the modern denial management, as we call it, where we use predictive analytics so that we proactively identify denial risks and mitigate them at the source rather than being reactive to claims rejections. And finally, all these elements pour into your quality outcomes, ensuring that you are capturing complete actual picture of the patient's acuity, severity, and full proper quality measures are kept in place. Now, okay, didn't know it wasn't coming, sorry. So, as you can see, finally, when we bring in all these elements, we have to incorporate with it the clinical and the financial operations in place in order to have fully rich data that is available that we can utilize. And by this method, you are allowing physicians to have more patient interaction at a natural pace. You have your CDI team work on removing any waste in your revenue cycle workflow. You have the coders as well focus on clinically complex cases that requires them. And you at all time improve the outcomes of your revenue cycle and have rich data that is reliable and can be used for value-based healthcare initiatives as time goes by. So as you can see, we have different areas where we focus or we bring in useful tools or solutions in all aspects and or workflows in the ecosystem. And let me start with the physicians, as they are on the start of the chain, and how we can provide solutions to them. If you see on the screen, you have this very famous painting that happened for this little girl who had visited the physician's office with her family in the back. As you can see, she's sitting across the desk from the physician, and he is turned his chair toward the computer to complete his documentation. And this was her experience. And you can see that this is nothing but a pediatrician or a child. So this is obviously not something that we desire to have, where patient-physician interaction is completely missing in this encounter. And this is exactly the opposite from what we expect from physicians in terms of patients spend time, and the general concept of healthcare as a humanitarian profession or a care provider, this is absolutely here diminished. And that's what brought the concept of creating time to care or freeing the physicians from these administrative burdens so they can go back to their origin requirement of interacting with patients and being actually care provider. So the first solution to tap in is what we have is Fluency Align. It's using this ambient device that provides different modalities of the application. We have it on desktop that allows while the conversation is being recorded between the patient and the physician, the documentation are being captured and the notes being outputted to the physician to be transferred to the medical records. We also have the other modality of Fluency Align Mobile, where the physician over there can have his preference of different notes, and while the conversation is being recorded, also they would see the outputs and send it to the EMR. The third version of it is Fluency Align Web. It's not shown here on the slide, but also it allows to output the notes through the ambient recording and send it to the EMR. The key strength of Fluency Align is its flexibility to meet the physician within their existing workflow, whichever way they work, through the mobile, desktop, at any point of time, with minimal disruption of their workflow. Because the goal here we have is to create seamless documentation experience for the physician without any disruption to their existing workflow. Delivering the value beyond the note, as you can see, this is also additional elements to the Fluency Align. While the dictation is happening or the conversation is being recorded, the system is analyzing and capturing that there are certain medication orders given by the physician. They are then presented to the physician in order to look at, and with a click of a button, these are being sent to the medical record. On the left side, you can see also the intelligence of the system to capture the codes from the conversation and auto-suggest these codes, the ICD-10 codes, to the physician, and then once confirmed, they can be sent to the MR. So this is kind of amazing and different from when we ask the physician to enter the code by himself. Obviously, the physician does not have that level of specificity, and they will not be able to capture the codes in that mean. So as you can see, the documentation part becomes a byproduct of the patient's visit, of the physician-patient interaction, and we remove this administrative task from the physician, transforming everything into actionable clinical and operational intelligence. Oops. On top of that comes the what we said, computer-assisted physician documentation that I spoke about earlier. So while the physician is dictating the conversation, the system has intelligent nudges so that at any point of time, the documentation is incomplete or there is gap of a clinical data missing. It softly nudges the physician and tell him that something is missing here. Let's take up the example of if the doctor, while dictating, he says the patient has chronic kidney disease, and moves to the next to complete the conversation, the system would realize that chronic kidney disease is an incomplete clinical data. We still need the specificity of the stage of the chronic kidney disease. So it would nudge the physician and tell him, you need to specify which stage of chronic kidney disease do we have. And thus, we have better chance of our revenue to be captured at its optimization. And when the case moves to our coding and CDI team, we see that they will be able to complete the coding smoothly without further disruption to ask queries to the physician and track those queries have been answered or not. And everything will be streamlined. So that's about the physician. Now let's look at different elements in that solutions for the coders, which is automation. Now, automation is brilliant because it would further elevate the workflow that we see with coders. So instead of the traditional where the coders would have the codes assigned from scratch, now we have the system or the technology select the codes, and the coder is now elevated to a role of an auditor where he will review the selection of the system on the codes and approve or deny or see that there would be better codes in the system. So now we see that the shift became it's improving and elevating the coders to auditors' role, and we decrease human error and we have better coding accuracy at our end. And we see that there will be elevation from volume to value. That is, we have the coders focus on what truly matters, and we created a chance for coders to accelerate in their coding career or find more options to further grow, and rather than the usually a small or dead end in the coding career to grow. Now they can use auditing or analytics in further to grow and have better outcomes. We also saw that a lot of organizations that have adopted automation, they did report better productivity of the coders and better coding accuracy, so that we have now our coders focus, of course, as I said, on what matters, focus on clinically complex cases that actually requires human judgment rather than looking at all cases and slow them down in the process. This solution we have to include that is 360 Encompass, is a complete solution that we have that gets integrated into the medical records, the organizations. It is infused with natural language processing, computer-assisted coding, computer-assisted CDI, and quality elements, so that we have a single platform for our coders, our CDI team, our quality team to work on the cases. So when this system is incorporated into the medical records at the organization, it does the task of reading all the clinical documents of the case, of the encounter, organizes them, capturing all the important elements from these documents and organizing them for the coders and the CDI to have a focused view on where the actual documentation are available in the file, rather than skipping through all the 5 pages in order to find or capture various information to have a complete coding workflow. So now with the computer-assisted coding, CDI assisted as well, we are able to have our platform in one with reporting and data quality improved, and we improve our revenue cycle workflow. On top of that, we have the autonomous coding, and I would like to show you how it evolved over time using the coding technologies. It took a lot of time, as you can see, it started from the 1980s up to date, and it's a continuous work in progress, where we had the traditional coding assisted to move to full autonomous coding capabilities. So in the past, we heavily relied on the coders to do the manual review and complete the coding with the help of rule-based experts or coding software that would support the coder at all time during the process. But over time, as we advanced in natural language processing, machine learning, and AI, all of that allowed us to transition to what we call auto-suggestive coding. And these codes would be then providing intelligence evidence from the documentation. As I said, it collects all the documents from the file and present them to the coder with the codes that are suggested, and the coders would then approve the codes accordingly. And as that's happening and the machine learning is there, the code confidence is being scored. So every time the coder accepts the codes are being accepted, the machine learns that this is done correctly. And as we moved from that to what we call semi-autonomous and autonomous coding, scoring these high confidence cases, they would start moving to a queue where minimal interaction or no coder would be touching those type of records that have high code confidence. And the ones with low confidence would move to the queue for the coders because they are clinically complex encounters and they would require the human judgment. So the key message here is autonomous coding is not here to replace coders. It is actually augmenting their human experience with AI to improve the efficiency and improve the coding accuracy and free the coders for tasks that they actually should be looking at. Our autonomous coding solution at Solventum is very unique because what we have in it is we allow the control at the end or at the side of the client or at your end, wherein you decide what are the cases or which type of encounters in your practice you know that they can go to an autonomous, completely coding workflow without the interaction with the coders. And usually those would be the high volume cases with low complexity. For example, repetitive visits to the outpatient office for chronic conditions to refill medication, etc. Or, for example, your routine same-day discharge or day case surgeries, cataracts or lab polys, etc. These the ones that would go usually as electives. These can be also included into the autonomous coding. Now, the machine learning is coupled with it at all times, and we have also the semi-autonomous coding with the low chart confidence. These ones would move to the queue, as I mentioned, where the coders become the auditors. That's the quality assurance queue for the coders to review those, versus the ones that have high code confidence, they would move to totally autonomous. But this key of autonomous given to the client to select which cases they want to automate and which ones not. So it's not plug and play and blind because it has this clinical intelligence at its end. At all times, we always look at encouraging the providers to aim for 70% automation and maintain 95% accuracy of their encounters. And that's the aim, the goal, so that the 30% remaining would be taken care by the coders at all times. Now, switching gears to the other aspect that we have, which is revenue integrity, or what we call denial management in a different way. Why this came into place? Because we have to acknowledge that we have high costs for the denials, and we know what the implications or the aftermath that comes with it. It disrupts the relationship between payers and providers with the denials and the resubmissions, appeals for those cases. And we have the revenue loss and the delay on all the denied claims until the cash flow comes in if the payer approves those denied claims. And there is an operational cost at your end as a provider you would have, because we see in revenue cycle the team that you have to look at these denied claims is usually half the size of their initial submission claims team. So let's say you have 10 billing team or 10 coders for the initial submission. They work on 80% of your initial revenue, and then you have 20% denied claims. You will have to hire half the team size that you had at submission. Let's say if there were 10, you will have to hire another 5 coders or clinical experts to look at the denied claims, and they will only improve the denials or the resubmission by an additional 5% maximum. So the question becomes, is resubmission team really effective? Is it worth that we have this investment in such a team? And we see a lot of organizations, they do not go with resubmissions or appeals of their denied claims, and rather they leave it till the end and have a closure with a reconciliation on the table agreement between payers and provider, and that would make the data to be skewed or inaccurate, that we cannot be using it forward. So this brings the concept of revenue integrity system at Solventum. And it has multiple layers to it. And the first layer has the denial intelligence, that it looks at the historical data that we feed it to the system, and it starts identifying different trends of risks of denials or opportunities, and brings that to have better intervention. It is also infused with the second layer of AI and machine learning, so that it brings you better predictabilities of the denials over time and improves the workflow. And lastly, we have the curated actionability, wherein the reports are taken into actionable guidance directly for the operational workflow, so that we are able to reduce the denials and improve our reimbursement over time. So what we're trying to say is, the denial management has to shift from the reactive usual denial management to rejected claim, and it's better to have it through predictive and preventive revenue integrity approach. And let's look at some of these dashboards, how we can use these denial predictability as such, with different views you can have at your organization. The one on the left we see is the overall denials, and that dashboard or this type of report is at the point where we are able to identify the different trends, the different denial groups, so that we can improve our process over time. And the second one is the mid-cycle denials. Here, with these, you are able to highlight the opportunities for the coding and the CDI team, so that they can raise the queries or do better intervention before the claims are submitted. And the third type of view, which is very amazing view, where you can look at your denials per denial code or denial category, and that's the way you can bucket the different denials you have, and you are able to reach or treat the root cause of the problem. Let's say, for example, your denials happen to be due to eligibility of the patient accessing your care, or he's not covered in the organization. If we have high volumes on those type of denials, that means I need to take back to my front desk for accepting the patients into the hospital or the admission office, and give them further training on our type of networks covered. Or furthermore, if you have your denials due to coding errors, high volume of coding denials, that means we need to invest in educating our coders or improving our systems. And if we have medical necessity denials, we take back that feed loop to our physicians to improve those. The fourth type of dashboard or report is the denial rate by query activity. And by that, we are actually looking at the denials with a relationship between the documentation effort that we did and measuring it against the financial outcomes. What I'm trying to say is, for example, are the CDI and the coding queries that we are doing actually leading to less denials? Are we actually investing in improving our documentation quality, and it's giving us better reimbursement outcomes? So this is where you see these type of denials and improve your outcomes. So what we're trying to say is this this predictive analytics and denial prevention, it's helping you to support proactive decision making and continuously improve your revenue cycle. And lastly, I would like to go back to the journey that we discussed initially, and to complete that journey all together, we are showing here how, we spoke about speech, ambient, computer-assisted physician documentation, CDI, all the elements up to quality. These bring, of course, the improvement in the revenue cycle, but the actual gain is not at the reimbursement value. It goes beyond, wherein you are now having trusted, high quality data in place that is rich in clinical information and data. And this is the foundation for value-based healthcare initiatives. As you can see, we can have a lot of organizations move toward pay for performance, and they acknowledge the different type of potential preventable events, preventable complications, preventable readmissions, so that we improve the quality of care and quality and care outcomes. And we see only when the data is streamlined and great, we can have benchmarks in place, and we can move toward what we call population health or clinically risk groups. That is some classification that measures population health through value-based healthcare. Now, a lot of governments take in an organization, they are able to design more effective payment reforms, and we are able to look at the outcomes across our population. Accurate documentation and all, it would gonna be the foundation for that. So you have to see and understand that now coding and improved clinical documentation is not just a function of the revenue cycle, it actually becomes the strategic enabler for value-based healthcare transformation. And this would take us actually to the very important way or important say that we have, wherein prevention is better than cure, and this is the ultimate goal that we are trying to achieve. I leave you with that, and thank you very much. And lastly, I would like to remind you that there is a QR code available at your table if you would like to get any more information or you would like to get in touch with Solventum.
Thank you so much.
Let me know if we're going to be taking questions now or at the end. Thank you.
Thank you so much, Dr. Asawi. What an insightful morning it has been, with valuable perspectives shared across healthcare technology, governance, and clinical coding. For those who are bursting at the seams, you are welcome to make use of the restrooms on your left-hand side. Alternatively, if I may ask our speakers to remain behind, if anyone has any pressing questions, you are more than welcome to address them to our speakers. We will allow now for a refreshment break. May I ask everyone to please return at 11:05 sharply so that we can continue with our program. Thank you so much.
Oh, great. Thank you. I will stick around, right? Okay.
Do you want to come and join us? Big boss. Big boss. There was a whole thing for your feet. You want to come sit here? I'm going to say it now. Come, let me help you. Can I ask that the last few delegates just grab their seats? Thank you so much. Welcome back, everyone. I trust you enjoyed the tea break and the opportunity to connect with colleagues and industry partners. Our next session focuses on current procedural terminology within the South African healthcare landscape. To begin the session, we will hear a presentation from Deshri Munian. Deshri is a professional nurse and certified professional coder with experience in clinical case management, PMB case management, and clinical coding validations. She has nearly 20 years of managed healthcare experience and extensive knowledge in medical terminology, anatomy, surgical procedures, and medical scheme benefits. Since 2023, she has served as a medical coding specialist at SAMA, contributing to coding accuracy and coding standards. Following the presentation, we will transition into an interactive panel discussion featuring experts from across the healthcare and coding environment. We would therefore like to encourage delegates to actively participate and engage with our panel through questions and discussion. Joining the panel will be Dr. Conrad Mashulwane, Chairperson of the SAMA Specialist Practice Committee with a strong interest in medical coding, healthcare policy and health economics. Ms. Benita Naidu, a certified professional coder with nearly 25 years of experience in medical coding, claims management and clinical validation. And Karen van der Westhuizen, an independent clinical coding consultant with extensive experience in coding systems, coding analytics, and healthcare coding strategy. We look forward to what promises to be a highly insightful and engaging discussion. Ladies and gentlemen, please join me in welcoming Deshri Munian and our distinguished panel.
Good morning, everyone, and thank you, Dr. Andrea. And yeah, we have almost the whole coding team up here. It's quite comforting. Okay, so I'll try to be quite quick. I just have about 40, maybe about 5 slides to get through. So, okay, yes, I'm just joking. All right, my topic today is based on CPT. And to different people, CPT means different things. When I first encountered CPT, I seen it as a complicated coding system. But for others, I think, you know, it's, if you really understand the CPT coding system, it can be, it's quite a logical system. You know, if you understand the intricacies and all of that, you can really appreciate the CPT coding system. But for me, my journey was at first that I didn't really understand the impact of CPT on the South African coding system, and more specifically to the MDCM codes in South Africa. I didn't feel like it was really relevant to the South African medical coding system, especially to the MDCM codes. But as I became more involved in coding, I came to understand that CPT is far more than just a billing system. It actually represents a structured clinical thinking and standardization of codes. It also involves innovation and collaboration in a multidisciplinary team. So, you know, there's clinical and non-clinical coders that work together with medical doctors and specialists in that field. And over time, I realized how strongly CPT has influenced the development of MDCM codes and many of the coding principles that we use today in the SAMA MDCM codes and other coding systems in South Africa. So understanding CPT, it showed how robust coding systems, that we don't have to imitate other healthcare systems, but so that we can build coding systems that are both intentionally aligned and they remain locally relevant to what we are doing here in South Africa today. So today I would like to share my why the understanding of the foundation of CPT remains relevant for the future evolution of coding systems such as the MDCM. And the topic of my presentation is how CPT remains relevant in South Africa and its role in innovation and in collaboration in our country. Oh, goodness. Okay, we are already at the introduction. Why is coding or what is coding in real life? Coding is not just admin, and I think that all the professional coders here today can identify with that, because to be a coder is not just to pick out a code out of a coding manual, but it is the application of your anatomy, your physiology, your pathophysiology. And medical coding is probably the only profession where reading handwriting is considered a survival skill. Do you agree with me? Okay, yeah, the doctor's handwriting is being picked on a little bit today, but I think that you can handle it, right? Okay, all right, so yeah, it involves identifying keywords from clinical documentation, analyzing complex clinical scenario, crosswalking, the codes with the coder's desk reference, and also with the CPT professional code book. And we also do peer review discussions. We do consultations with with medical doctors and with specialists, and there's so much more that goes into selecting that that perfect code, the most accurate code for whatever scenario that you are dealing with. So behind every correctly assigned code is clinical reasoning, there is technical expertise, and there's critical thinking that goes into it. So that's the day in the life of a coder. And there's many coders here today, so yeah, you can identify with it. So, and then the next question is, how many of us here have dealt with coding disputes and with rejected claims? And I think that almost all of us, have encountered that at some stage or the other. So we all know that that wrong coding can result in claims rejection, in revenue leakage, and inaccurate healthcare statistics. Coding affects not only medical doctors, but also it affects hospital data, it affects the patient directly, with the claim rejection, then you have your pocket expenses for your patient. The patient gets stuck in the middle of everything, and then it also affects the national healthcare planning in a country. South Africa has a unique healthcare environment where where we must balance international best practice with local healthcare needs. We have a unique healthcare system in South Africa, so we must adopt the coding to suit our unique environment. In South Africa, we primarily use the medical doctor's coding manual. But CPT plays a significant role as a benchmark in shaping how we develop and how we structure our codes. I think I'm back on my slide behind. No, there we are. Okay. So what is CPT? It stands for Current Procedural Terminology. And it is a globally recognized coding system that is developed by the American Medical Association. And the reason why it is globally influential is because the CPT system is consistent. It has consistent principles, it has consistent rules that is worked into the system. And it has standardized coding rules. The codes are scientifically researched. Codes are not just randomly picked and placed into the system. And there is a strong physician involvement. So the medical doctors have quite a good input into the codes that are in that coding system. And there are regular updates of the codes in the CPT coding system, which it represents the current clinical practice. There is yearly updates of the codes. There's a new version of the CPT professional every year. So it provides a standardized language for describing medical, surgical, and diagnostic procedures. And the word current, it means regularly updated to reflect modern medicine. The word procedural, it's focused on procedures or services and it doesn't have anything to do with diagnosis or diagnosis coding. The word terminology it means that it is a standardized set of terms and descriptions of the codes. So the overall description of CPT is that it's a continuously updated language for describing a medical procedure or a service. Okay, and then why SAMA uses CPT as a benchmark? And I think that one is quite a burning question. There's quite a lot of misunderstanding around the benchmarking of CPT in the MDCM code. So we're going to address that this morning. If I don't cover everything here, then I have my Q&A panel that will help me to fill in all the gaps. So SAMA we did not import the codes blindly. There are specific reasons why we are using CPT as a benchmark. Firstly, because of its international credibility. CPT is globally recognized and it's already well developed and it has an established structure in place already. Secondly, because of its clinical accuracy. The codes are developed with strong clinical, medical doctor or clinical input, and they reflect real clinical practice. Thirdly is the established logic. They have built-in principles like the integral services, procedural hierarchy of codes, and which is essential for ethical and consistent billing. And then fourthly is the practical efficiency of CPT codes. It's easier for SAMA to adapt an existing system than to build one from scratch. And it's not that SAMA is lazy, but there is a system that is in place already. It is in place already. So, and it's already scientifically based and it has everything that there is. We are being innovative and we are adapting the system to suit the South African environment, and therefore it remains relevant in South Africa. So SAMA uses CPT as a foundation, but adapts it to the South African practice through the MDCM. The CPT principles, they underpin coding logic, procedure descriptions, definitions, and the bundling rules. But South Africa we still use our own codes. We develop our own codes. We don't use the 5-digit codes that CPT uses. We have our own codes, but we adapt the descriptions, the interpretations to suit the South African environment. Okay, and then how CPT works in the USA. In America, CPT codes are used together with the relative value unit or RVUs. It's more commonly known as RVU. The RVU is the actual numerical value that is assigned to a medical procedure or to a service, and it is relative. It is not absolute. So therefore, the value is not a fixed figure. It's not a fixed amount. RVU. Okay, so then we have there's closely related terms. There's the RVS, which is the resource-based relative value scale, and that is the methodology that is used in America to work out the RVUs for them, or to calculate the RVUs. Then it's the RVU. That is just basically, it refers to specifically to the RVUs that are generated through the RVS methodology. Okay, the RVUs reflect the value of a service that is based on the physician work, the practice expense, and any malpractice costs. In South Africa, MDCM is also allocated RVUs, but the way that we calculate the RVUs is not based on the methodology that America uses. So what happens in the MDCM is that we use the RVU that is used in America, and we multiply it by 10. And those are the units that are reflected in the MDCM that is allocated for the different disciplines for each medical code that is in the MDCM. So to break it down, the physician work component, it relates to the amount of time, the technical skill, the risk, and the mental effort that goes into each procedure and each service. So you can think of RVUs as the weight of a procedure. And to break it down even further, you can take a procedure, or not a procedure, a service like a consultation, which is a low complexity. Therefore, it will be a lower RVU. Then you get a procedure like a appendectomy with a moderate complexity, and therefore it will be a moderate RVU. And if you have something like a cardiac surgery, which is a high complexity, it will have a higher RVU. So the system, it ensures that procedures are valued consistently across the healthcare system. Okay, how CPT works in America? America uses a conversion factor to calculate the total payment for a procedure or a service. And in America, of course, they're using the dollar conversion factor. It's not it's not the same as the conversion factor in South Africa. So the formula that is used, it's the total RVUs times the conversion factor, which will give you the total payment for a procedure or a service. The conversion factor is a dollar amount, and it is set by the Centers of Medicare and Medicaid Services, or the CMS. And the process, it generally it considers things like the national healthcare expenditure targets, the economic factors and the inflation in the country, legislative adjustments by Congress, and the physician cost trends. In South Africa, the conversion factor differs because reimbursement was historically based on RVUs, on the scheme tariffs, and on negotiated fee structures, rather than in comparison to the calculation that they use in America, which is the Medicare-style RVU conversion factor. So in South Africa, in the South African context, the units are also RVU for the MDCM codes, but the RCF converts those units into a RAN value, and that is the payment that is paid on each procedure code or service. The RCF, it also differs, so it will be different for medical schemes, for provider networks, for discipline or specialty, and so on. So the RCF is independently determined by each of these groups. Therefore, it will be a different percentage for each independent group. Okay, we're still on the relevance of CPT in South Africa. In South Africa, the procedural coding is primarily based on MDCM, like I've already mentioned, which is maintained by SAMA, who is the custodian of the codes in the industry. The MDCM, it serves as a foundation for procedural coding, for billing, and for reimbursement within the South African private healthcare sector. Although the American CPT system, it's not directly implemented in South Africa, again, it plays an important benchmarking role in the development and the refinement of the MDCM codes. CPT provides internationally recognized reference point that supports alignment with global coding standards. So we can keep abreast, with the international trends that are happening out there. That's why it is innovative for us to also use CPT as a benchmark. And SAMA also adopts the CPT into the complete CPT for South Africa. And this we do in the, it's a licensed product, and it's in both the electronic format and in the flat file format, and it is mainly used, the CCSA is mainly used by hospital groups, by healthcare administrators, by coding and tariff specialists, and so on. So it is still being used in South Africa. Innovation in medical coding does not always mean creating an entirely new system from scratch. In many cases, innovation, it involves refining existing coding systems and contextualizing the international standards for our local use. It's also adapting to evolving clinical practice and healthcare policy. And why does this matter in South Africa? It matters because this ensures local relevance and it supports reimbursement of services in South Africa. It promotes consistency, it aligns with global best practices, and it encourages continuous improvement of codes in the MDCM. Oh, sorry. I forget about that. Thanks. Usually somebody turns the slides. So I forgot about putting it on the next one. So we are on are we on benchmarking? Oh no. I'm behind. Where? I can't see. What is the...
How CPT supports collaboration and innovation.
No, I went back now. I should have brought my glasses and my walking stick. Oh, okay. No, I need to go back. Is that benchmarking? Yeah, that's the benchmarking process. So... Okay, so I'm going to just wrap up, I think, because in the interest of time, the Q&A panel is going to take over. So they'll cover, questions regarding the benchmarking process. We also I didn't cover the adaptation of the units and the valuation, the RCF component, and the example of the MDCM wording adaptation, the pap smear code example, if maybe you all can just address that, just so that I can give you all enough time. And then also I just go quickly over this one, how CPT supports collaboration and innovation in South Africa. So SAMA does not develop MDCM codes using CPT as a benchmark in isolation. We use CPT as a reference. So it allows collaboration with professional societies and other healthcare stakeholders. So we do this when we are identifying coding gaps, when we evaluate procedures, when we make coding recommendations, when we are adapting the wording, the RVUs, and applying the principles of CPT into the MDCM codes to create our unique codes in the MDCM. And then CPT also supports innovation rather than limiting it. CPT is not copied directly into the MDCM. It becomes it's a foundation for local innovation. So the benchmarking process allows South Africa to refine the CPT codes for us to be able to adapt the codes in the MDCM and for us to modernize it or make it locally relevant in South Africa and to improve our coding systems collaboratively in South Africa. Okay, so thank you. I'll just hand over to the Q&A panel to address some questions.
So, any burning questions from the floor for the panel? We have SAMA's coding committee, CPT experts. No questions from the floor?
Okay, just to emphasize what, thanks for the great talk. I think we are saying, if you have a good wheelchair, don't get rid of it until you can walk. And I think for us, we look at CPT. I wouldn't have learned coding without going to CPT. This processes are robust. And, I see us as content creators for coding. What makes CPT special for us is the fact that the people who actually produce the services are the ones who produce the code. You have to experience the content in order for you to actually create it. And that's a strength about CPT, how it's developed, how it includes the people who produce the services. Just like the financial people, they develop the financial models. They look at the data. We have the data coming in front of us, the patient, and that's what makes CPT strong. And nothing is perfect, and we're basically here to learn, and we're learning from something. Yes, maybe one day we'll be ready to have our own coding system, but we have to have processes. We have to have structures in place to go forward. Any comments from you guys?
No, I can
While
just,
you're waiting for questions.
I can just confirm what Conrad said, but the one question that I always had was, what do you do if there isn't a CPT code for a specific procedure? And that does happen, or if it's still a temporary code in CPT. We do have cases where some of the funders would outright reject such a CPT code. If they use CCSA on their side, they use the temporary codes as well. So that is something from a systems point of view in South Africa that one will have to look into. But there is a process. If it is a temporary code and you have the data and you have the research or the meta-analysis to show that it is actually a valid code, just because it has not been approved in America yet, does not mean it's not a valid procedure to be done. Remember, South Africa does practice slightly different from America, and no offense to our American colleagues, America also have their own gremlins. If they don't get the data they need to make the clinical decisions, they don't have the data. You can't just thumbsuck something. That's what makes CPT so brilliant. It is absolutely well researched. So while they're waiting for their data, we might need that code urgently. So if you can provide the information, then SAMA is more than willing to look at it and come up with the relative value unit for everybody to be happy with, and in collaboration with the providers, with the funders, get that code up and running. I'm thinking one example is the renal denervation code. Has been a temporary code for a very long time, but there is an actual SAMA code for it in the book, and the cardiologist can use that code. So there is a way of doing it, and it is possible.
Thanks, Karen. Benita, any thoughts?
No, nothing to add to what Karen and Dr. Mashulwani said, but we just like to give a few examples of how CPT was adapted for use in South Africa. We used it regarding the introduction of a code for the pap smears that was added to the MDCM from January this year, and we also used CPT widely when we did the whole introduction of the RESM procedure. We referenced CPT a lot and looked at the procedural steps involved and the units. We broke down each component of the procedure, its units, calculated it, and got a code or a value that would be reflective of, fair remuneration. That's what we did.
And I think the other important thing is that we have developing codes. We have to involve our stakeholders, the funders. The nice thing that I like about CPT is that when you come with the code, the funders have already done their research because it's there. They know what to expect. There's a desk reference, and so it doesn't just come out in isolation. There was something to reference. And they actually query certain things, our interpretation of CPT. We've got codes that are actually still pending, because funders have actually found errors in how we've dealt the code, and we have to go back and do the homework. So we don't just throw a code at people. We actually collaborate with them. We ask them to give input, and where there are problems, we go back to society and we say, no, we can't basically take this code because funders have done A, B, and C, and we think what they've told us is actually logical. So it's a very inclusive process. Yes, society and doctor-driven, but it's very inclusive. It includes the stakeholders, the funders, etc.
Thanks, Conrad. I see 2 hands. Do we have roaming mics for the hands, please? There's one question in front, in the second row, and I see Simon has a question as well.
Good morning, everyone. My name is Dr. Valencia Mandiluve-Klazi, and I am currently working as a casualty officer. I'm a junior doctor, by the way. I'm currently working in Casualty Hirolim Private Hospital in Mthatha, but I'm also a founder and the CEO of Regimet Health Group, which mostly motivated me to be here today. So I have two questions for our panel today. I am working on an integrated healthcare ecosystem to assist our National Health Department that is going to link private healthcare clinics from the grassroots level in our communities, especially in the outskirts of South Africa, to urgent care centers and emergency and trauma centers that, according to the demand of that particular region, can then later on establish a private hospital in that area. This is all in support and in attempts to decongest our current public hospitals in the state that they are currently in. And digital health systems are the center of my vision, because we want our low-level healthcare centers to be overseen by medical doctors and specialists via telemedicine as well, just to ensure that all people deserve the same quality standard of care at all levels of care. So today for our panel, given the presentation that was so insightful that was given here today, I want to ask, how can younger practitioners and emerging healthcare operators improve coding literacy early enough to prevent revenue losses and claim rejections? And question number 2 is, do you think South African medical training should include formal coding and healthcare administration exposure? Because at the end of the day, we are not only being trained to work in the public sector. That's not the reality after training. We also work in the private sector, and the private sector supports our public health sector and the national health system. Thank you very much.
Thanks so much, Doc, and that's very good questions. Karen, do you want to start? I see you nodding very aggressively.
First of all, congratulations on what you're doing. I think it's absolutely amazing. Regarding the curriculum, absolutely yes. It should be included in everybody's curriculum, not only the doctors. Remember, coding is not just billing, it's ICD-10 also. The nurses have their own billing schedule, the pharmacists use the ICD-10 coding, physiotherapists have their own billing system. Everybody needs to understand at least ICD-10 from the beginning. And don't tell me you're going to do your Zuma here, so you're not going to go into private practice. You use ICD-10 in the state as well. So definitely, ICD-10 without a doubt, immediately, yes, it must be part of the curriculum. And I've forgotten the first question.
It was the first, I think.
It was also in terms of training.
It was also in terms of training, or you did ask a specific question about junior doctors, how they can, coding literacy. I know at UCT there is a current coding program running. I know SAMA has been talking about running a coding program. I don't know if it's still running. But you learn through doing it. You do need to have a basic knowledge, yes, definitely. But if I can have my dream in South Africa, I would go for a statutory coding body with training, with set standards that everybody can adhere to, that we have a library where you go to say, if I want to code pneumonia, I do it this way because. This is the code that I use for doing a cardiac bypass because. And not just do creative coding, and that's my pet name for just adding codes to get reimbursed. That's not the way to do it. But we do not have a set system with a statutory body that can enforce proper coding. That it should be the base for a training program, so that you don't have 6 training schools and everybody trains something differently. Everybody must train the same thing. Thank you.
Currently, though, as physicians, the MDCM is a good place to start. Yeah. Yes. Anything further from the panel? Okay. Simon had a question. Do we still have our roaming mic? Simon?
Thank you. Good morning, everybody. Dr. Simon Strawn. I'm a pediatrician in private practice, and I am the CEO of the South African Private Practitioners Forum. So SAPPF represents 14 different specialist disciplines, and every single one of those disciplines runs annual coding training programs and access to coding. My thinking is that what you should be doing is asking the HPCSA in terms of CPD points to allocate CPD points to coding education, that people have to actually acquire them every year to keep up with coding. I think that would be a good way to try and regulate it. I know we hate that word, but sometimes democracy sucks. So the next point is about RVUs. And Conrad, I'm asking the question just so that the audience understands. I'm not really expecting an answer. But just to state that the 10 times multiple for the RVU is an arbitrary number. There's no scientific basis to that 10 times multiple. And I've never actually heard anybody even try and explain why it was 10 times. But certainly, cost studies that have been done in South Africa over the years are suggesting that that 10 times multiple should be more like 12 or 13. So the question actually is, I like the analogy of don't give up the wheelchair, that we can work with what we've got and we can make it better. So why can't this be the only coding system we use in South Africa? We know that hospital groups and schemes are moving away from CPT because of financial implications. So why are they looking at something else? Why don't we all just use this one coding system? Thanks.
Simon, just to answer your first question of the times 10, I can increase the RVU times 100. It doesn't matter. I can increase it by 200. It's a relative value scale. If you look at how it's developed in the CPT system, you take a benchmark, a code. If you want to develop new code, you're developing a code for a robotic hysterectomy. You take a benchmark, you choose your benchmark, the current codes that exist, and then you work from there. It's a benchmark, it's a weighting system. It's a weighing system. Let's say it is not correct. The issue is what ultimately determines your value or price value is the budget allocated to one RVU. That's what determines. So if you do your cost studies, you just adjust your RCF, which is in your control. So no practitioner can feel undermined by an RVU when they've got a control of the RCF. The RCF is in the control of the practice. Yes, the RVU was not, at that time, was not scientifically determined. It was basically using like your dollar and exchange, and it was times 10. Yes, it was never adjusted, but you are able to adjust your RCF, and you can do that using your cost studies to adjust your RCF. We can't adjust, the RVU has to be standardized across the board, but the RCF is determined by the budget of your own practice, which you can adjust. The funder has no control unless you contract. The second question is the issue of developing a new coding system. One coding system. We've got a coding system at the moment. It's a summer MDCM. The societies have it's their platform. They can influence it and develop it as how they feel fit. But you cannot import a coding system into a country. You can import the digits, the whatever, but the descriptors, it's how you practice medicine. Its coding has to be localized. You can change the name, but the principle doesn't actually change. I can't speak for hospital groups why they're using CPT, but I can definitely say that we can choose to be, we can be on the same platform and choose the summer MDCM and participate to improve it. That's all I can say for now.
Thanks, Conrad. I'm going to take a last question. Anton, is that you? I can't see with the light.
Yes.
It's technology. Okay, so I'm Anton van Skalkwyk from Insight Health Solutions. and previously from SAMA, so I can talk with some experience. Now, Deshri spoke about the RBRVS, and we also heard about T codes in the CPT book that doesn't have any RVUs yet, and therefore we have a struggle of getting it admitted for payment at the medical scheme level. I think the big problem that we have in South Africa is we do not have our own independent actuarial costing system yet. And that is part of the issue. And the thing that Simon spoke about the 10 times, absolutely has merit in some form, because when you look at the RBRVS, it consists out of three things, basically. The physicians or the doctor's work that's being done, that's around 50% of the cost that the RVU is being made up of. But secondly, practice expense and professional liability, and that's why he's speaking about 12 or 13%, because it looks different in South Africa than it looks like in the USA. So my plea is rather, when it comes to the processes, that we start looking at very specific processes for specific disciplines, or for every specific discipline, to determine the second and the third part of the costing. The work is the same, whether it's done in America, whether it's being done in South Africa, the work is the same. But when it comes to the second and the third part of what the RVU exists out of, then you will have a more accurate way of determining the correct units for South Africa. Then it's not times 10. It may be when a specific practice is very much relied on very expensive technology. Let's, for instance, take ophthalmology, who have very expensive technology that they use in their practices. It will have a definite effect on the way their codes are being determined. When you look at gynecologists and their professional liability insurance, that's extremely high when it comes to deliveries. It will have a very definite effect on their RVUs. And I'm not speaking about the rand conversion factor here, but it will be a much more reliable determination of what the doctor is actually supposed to charge. And when we have that formula, then it's easier to take a T code and say, listen, here is actually the correct RVUs for South Africa. Because you know the intensity, you know the amount of time that it takes to do this procedure. You know the practice expenses for this, on average, for this particular discipline, and you know the professional liability that this type of discipline is paying. And therefore, this would be the correct RVUs for a South African practice to use. So when it comes to our processes in which we decide on specific codes in South Africa, that is actually the way that we should go to.
I think we agree with you, Anton.
Yeah.
And I think from a committee perspective, we're definitely encouraging people to do their research and to bring it to us so that we can have the conversation. I mean, we're very inclusive and we agree with you that our own studies are definitely needed. Was there a question that you wanted to ask the panel?
All that it's more of a plea that it becomes standardized. I've been moaning about this for years now, that it becomes standardized to ensure that we have the correct RVUs in South Africa. And I'm sure when it comes to SACHI, on the long run, this is going to become standardized. But yeah, this is just a comment that I want to make in terms of the RVUs. The RVUs is very scientific, but it needs to be standardized for South Africa as well.
Thanks so much. That's valuable insight. Thank you so much to our panel as well. Our panel is roaming around, so if you have more questions for them, they're very passionate about coding. So please come and approach them, ask them. They will share with you as much knowledge as they can. Thanks so much. Our next interactive panel discussion, you are most welcome to leave the stage, thanks. Our next interactive panel discussion, and as I introduce them, are welcome to join me up on stage. The next one is titled Transforming Healthcare Together, Coders, Clinicians and Technology. The discussion brings together perspectives from across the healthcare ecosystem to explore the evolving relationship between clinical practice, coding, digital transformation and technology. Leading the discussion is Dr. Conrad Mashelwane, Chairperson of the SAMA Specialist Practice Committee. Conrad is a specialist in obstetrics and gynecology with more than 20 years of private practice experience. In addition to his leadership with SAMA, his interests include medical coding, healthcare policy, health economics, law, ethics, and alternate dispute resolution. Joining him on the panel are Stephanie Fourie, clinical coding specialist at Discovery Health with extensive experience in professional coding, billing, and provider relations. Matt Zylstra, Senior Principal Actuary at Discovery Health, specializing in healthcare analytics, reimbursement models, and predictive modeling. Sitara Sityadev, founding member and strategic lead at AfriCode Consulting with over 26 years of experience in healthcare coding, consulting, and training. And Dr. Simon Strawn, CEO of SAPPF and a leader in healthcare advocacy, policy engagement, and private practice sustainability. Ladies and gentlemen, please join me in welcoming Dr. Mashelwane and our distinguished panel.
Thank you. Morning, everybody. I think this is both an easy topic and a difficult topic. My interest really is administration. That's what my interest. Administration is not creating new products. Administration is protecting the information that is given to you. That's all we do at SAMA. We're there to protect information because information can be distorted. But the issue is, at the same time, there's a song by George Benson that says everything must change, nothing stays the same. And that's why we're here, because everything must change. But in order for you to change, you have to know what doesn't change. There's certain things that you can't change. The Greeks called it divine, fundamental. You study science to understand what doesn't change. Then you can change from the foundation. So we're just here to say, guys, I've worked with especially Stephanie and Simon. We disagree about a lot of issues. And that's why we're here. I'm coming to ask you a question. Tell me, in your honest opinion, what are our pitfalls? What is wrong with what is going on now? That's the first thing. And we're not talking about the SAMA coding system. We're talking about our platform in South Africa. We're a society. We need information. We need coding. What is it that you think doesn't work or the pitfalls? I'll start with Stephanie.
Hi, thanks, Conrad. I think, there are a list of pitfalls, but the one I'm going to touch on is really about the clarity around codes. The guide, and with the newer codes, there's a lot more clarity of what is meant by the procedure. There are some billing rules and guidelines documented in there, but there are a lot of historical codes that sit in the guide, and there are no guidelines. There's no guidance on how to bill it, what's included in that procedure, what can be built together with it. So today we sit with a situation where a provider doesn't know whether they can combine a code with another code, or whether they only build the one code. So that causes disputes, inconsistency, and quite a lot of frustration. So I think that's the one for a start. I don't know if you want me to say what I would suggest as a...
Can we pack it there?
Sure.
But somebody needs to write for us all these, maybe they should just write so that when I come back, we know what to address.
Okay.
Can we just pack on this, start with the problem first?
Okay.
Yeah. Can you pass it to Matt, please? Thank you.
Thank you very much. I feel very much like an imposter here. I'm not a clinician, I'm not an expert clinical coder, I'm an actuary, I'm probably the only one in the room. So I think from an actuarial perspective, I think the issue is that every single scheme is doing their own impact studies whenever there's a new code that's suggested. They're often, provided to us very late. There's not much time to do these impact studies. And there's no real independent organization that can do these independent kind of impact studies and come up with any recommendations. So on the CPT side and ICD-10 side, there's the Private Healthcare Information Standards Committee, which generates lots of guidelines in terms of which codes can be used, when and how you should be using the various sets of codes. Nothing like that exists in the billing side, as to Stephanie's point. So I think in terms of coming up with the billing rules and the impact studies, costing based on the utilization that everybody has access to, what those codes are going to cost and whether it is affordable for the schemes and sustainable for the schemes to take on these, all at once or over a phased period becomes quite a challenge.
Sitara?
Thanks, Conrad. I think there's been a lot of talk about doctors' handwriting. So if you speak to clinical coders, I think most of you in the room will agree that the quality of the healthcare documentation does not support the codes that you need to actually assign to a patient's claim or a healthcare record. So to this end, ladies and gents, I think most clinicians are not trained to document in a manner that supports clinical coding. And this is a huge challenge in South Africa and out of South Africa as well, is that in training, doctors get trained how to document for patient care, diagnosis, treatment, etc. Now, clinical coding requires a very specific manner of documentation. So I'll give you an example of a doctor documents laceration for suturing. If you look at CPT or any other clinical coding system, that information is totally incomplete with regards to which code you can select, because you need the anatomic site, you need to know how many centimeters, you need to know the depth of that laceration. So to this end, coders experience many challenges in getting correct information to document. So ladies and gents, we have had brilliant presentations speaking about transformation moving into AI. So whether we use the patient's record manually to do the clinical coding, or we're going to input into an AI tool, the quality of healthcare documentation needs to improve. It needs to be complete, it needs to be concise, it needs to support clinical coding. So I think that's one of our huge gaps currently, Conrad. Thank you.
Thank you. Simon?
Thanks, Conrad. So if you can't read the script a doctor gives you, give it back to the doctor. Don't accept it. You're sitting here bashing the doctors, say to them, no, I can't read a word you're writing here. So, all right, so for me, Conrad, the issue is around the complexity of different coding systems. And as a big category, and the second is, what are we coding for? So under the different coding systems, I would like to suggest that we never, ever again in a coding meeting refer to the RPL, because there is no RPL in South Africa. 2006 NHRPL were SAMA codes, codes set up by government, and now SAMA, with a reference list of prices. We do not publish price lists, so we should never, ever again refer to RPL. The coding system we use in South Africa is the SAMA MDCM book. CPT-based, referenced. And I think that's it. And that if we look now at we've decided as healthcare professionals that we're happy with the coding system that we currently have through the SAMA process, and that we are committed to improving it as we go along. And yet funders and medical schemes use different coding systems. And that can lead to issues. And there are activities around coding that will happen within the funder and hospital space, and healthcare professionals are not included in those. So I think there's a lot more collaboration that needs to happen around this, a lot more understanding that needs to happen around who's using what coding system and how they overlap. Why do we code? So if you ask most healthcare professionals, they'll tell you because they want to get paid. And when they code for expediency. So they will code this as simplistically as they possibly can. We know that even within the prescribed minimum benefit framework, again, the terminology appendectomy was used earlier, there are a number of codes that fall under appendectomy, but only 3 of them are actually included in the PMB guidelines. If you use the wrong code, you don't get paid. I was presenting to a room full of psychiatrists, it was a madhouse, psychiatrists the other day, and to my surprise, the majority of the audience agreed that they only used 3 ICD-10 codes in their entire practice. And the reason they do it is because those are the ones that are paid by PMBs. Okay, so we need to understand that. So certainly, yes, it's about being reimbursed and being reimbursed properly. I don't think, there are very few healthcare professionals who will go, I'm coding as accurately as I possibly can because it's data that's going to help me. No, it's what the schemes are doing is the schemes are using claims data to profile doctors, to see who the outliers are, to see the ones that we can visit. And I'm not saying it's a bad process. I've been involved in it for 20 years in pediatrics. I'm just telling you what it is. But the point is that if, in some situations, if the healthcare professionals coded to granularity and coded to accuracy, their profiles would look different. So this brings in the whole thing about education and why we code, and that ICD-10 and whatever procedural coding system we're using is so important. And my last point, just to put in the mix, is that of all the codes in the SAMA MDCM, only 350 of those codes account for 92% of all claims submitted. Only 350. And in any one discipline, so as a pediatrician, I probably use 20 to 25 billing codes. That's it, to cover the work that I do. Obviously, vascular surgeons and general surgeons will have more, but the point is, not every discipline is looking at the whole big, thick book. Small number of codes, and the 92% is covered by 350, so we can tackle this.
Okay, so let's just go back now to Stephanie to say you've identified a problem in terms of lack of guidelines, and for me, it's also it's a problem with the society. The question is, what have you done about it, and what do you think should be done about this issue?
Can I just also touch on what Simon said there about collaboration?
Yes.
And I think, that is an important point, is that the more you collaborate, the better and the faster, and you get the buy-in, and everyone's on the same page. So I think, just around the actual process, and I must say that the introduction of new codes and the evolving of the guide with SAMA is improving. Over the last year or so, it's become more collaborative and more people are involved in the process. But I'd like to emphasize that if it could become even more so, okay, and not that the new codes are then published or put out there for the industry 2 months or a month before they go live into the new year. So just around billing rules and guidelines as well, I think that is extremely important, because sometimes a code is submitted for introduction for the next year, but there are key components of that procedure code missing, which are fundamental for any system to understand how one code can be built with another, And unfortunately, there are financial impacts if those guidelines and rules are not clearly published and in the public domain and everyone understands what does it actually mean. So the appeal, and the plea is really that it becomes more of a collaborative process earlier within any year, that all stakeholders are involved and right from the beginning to give input into the process. And that so as we move towards a new year, that when the new codes or the codes that are introduced into the system, everyone has given input, there's been collaboration across the board, and even from a funder side, and that it's an easier transition for the system. And I think, one of the things that has, I think most people would agree, is that the detailed billing rules are not clearly documented anywhere. And in the CPT environment, they are clearly documented. You can have access to them. But in South Africa, there's sort of pockets of where they are. I'll take, for example, the process we went through with the Gynae Society. It was extremely collaborative, very, it went down to unpacking the procedure codes and getting everything clearly defined, and it was an easy process then to take a section of codes live, new codes. But if that doesn't happen across the board, it becomes very difficult if a new code is just introduced without that clear definition of what it is, what are the rules around it, and then that becomes a challenge in the industry.
Stephanie, I think what you're telling me is actually achievable, because this is
Absolutely.
Where we're going through. And I believe that SAMA will not take a code and publish it if there is not enough information on it, if there are unanswered questions. And you know that we've got actually 3 codes sitting from last year that we are not ready to send out there because we're not happy with the information that we're getting from the society.
Yeah.
So I believe moving forward, what you're telling us from the SAMA point of view is achievable. Because the issue is that you should not have a published code if there are unanswered questions in terms of guidelines.
There are some historical codes that we need to move back and just rework some of that.
So that basically means a discovery, engaging with the societies, because we can only, we administrators, we publish what the society has agreed to in collaboration with the medical aid. So I think that's challenge is achievable.
Absolutely.
I'd like to come to Matt. You talk about impact, independent impact. There are 2 parties involved here. There's a buyer, there's a seller. To be honest with you, from my point of view, I'm a seller. I need to study my impact, how it impacts on my practice, all right? You are, as a funder, you're going to have to do your own studies and understand how it impacts on your members. Really, that's got nothing to do with me. I'm here to provide a service, and I know what my impact is for my accountant. And the question is, when you start independent impact studies, and that who is obliged to the information? Because as far as I'm concerned, my obligation is my accounting and my costs of my practice, etc. When you talk about impact on whom?
Yeah, thanks, Conrad. I think what I was referring to is impact on the medical schemes. Yes. I think we need to make sure that both the private practice as well as the medical schemes are sustainable, because in the private industry, we kind of need each other. Yes. There wouldn't be sufficient funding for doctors if there weren't medical schemes. And I think the issue is that because schemes are not-for-profit entities that don't generate profits, insurance profits at all, any surplus that arises is used for members' benefit in terms of enhanced benefits or lower contributions, and conversely, any deficits result in much higher member contributions or cutting in benefits. So the issue is, when there are new codes proposed, we need to make sure that they can be implemented sustainably and not result in excessive contribution increases or cuts in other benefits if they're not necessary. So we've got a responsibility to make sure that the limited pie from all the members' contribution is, distributed fairly and equitably across all the medical providers and all the services that our members need. It's not an easy job. But what I'm saying is that, just if we decide that a code is unaffordable to fund, it doesn't mean that we're saying that the service is not valuable and that you shouldn't be providing it and shouldn't be charging our members. It's just it's unaffordable for us to provide that level of reimbursement at the level that it's been set at, without the, as Steph was saying, the adequate billing guidelines as to when it should be built. What I was talking about in terms of the impact assessment goes probably back to what Stephanie was saying. With the billing guidelines and knowing exactly what the utilization of that code would be, it gives us far more certainty in terms of the cost impact to the schemes as to what that code is going to do. Without those guidelines, we're trying to infer utilization from other codes, and it becomes very difficult to understand whether we can affordably introduce that code.
I mean, that's fair in that I think as a provider, I don't think that we think that schemes have we don't have resource constraints. We know that we have resource constraints, but from a clinician point of view, that we introduce a code because of the benefits, the clinical benefits. Now, I can't say, no, we can't take this code into the SAMA platform because the schemes can't afford it. We are saying the schemes must look at their own impact and decide what they cover, don't cover. But the question is, we are here to provide a service to the South Africans. And those who can afford it, they should have access to that code. So we are not saying once something is published that we can't force you. There's no legal tool to force you. But we are saying if a procedure comes up, scientifically it's been proven in a journal, we have to basically code it. And you then do your impact study and decide how you and the scheme can actually afford it. So I don't think that we're on a collision course. We agree.
Agreed. And I think to Stephanie's point, that the earlier we start collaborating on this gives us more time to bed down those impact studies and determine whether we can introduce those codes. So it's a question of, timing.
Can I just add there? I think, in instances like that where there is an affordability constraint, there are instances where some funders may look at an alternative reimbursement model, like a global fee or some other mechanism. So even when, and specifically with new technology, you sometimes have to find a way, and it might be a different model and not in a fee-for-service model.
Which we accept that. We support ARMs. The issue for us is the service must be available, and the actuaries should come up with models on how to fund it. But the value is the service from the doctor. I think we agree there.
Yeah.
Thank you. Sithara, I'm going to ask you about documentation. I'm a clinician. I write codes to how I was trained to treat patients, not to code. So I'm saying that when we're writing coding, when I'm writing my notes here, I'm writing not for coding, I'm writing to treat a patient. So I'm not saying so, but if that information can be turned into a code, then it's for me as a doctor to correct my information, but not to write clinical notes to code, to write clinical notes to treat a patient. And then I find a code that actually suits what I've written. If there is no code that suits how I've written, either I correct my information or I'll go for Rule C to say that the information doesn't exist. So I don't think that we're on a collision. We are saying that notes must be taken probably, but not for coding. Then coding guides clinical practice, which should be the other way around.
Yeah. Except that, Conrad, if you're not doing the coding yourself, and you've got someone else doing the coding on your behalf, if it's not completely documented, there's a huge risk of undercoding.
Then they must go back to the clinician.
Yes.
He must write his proper. We are saying doctors must write proper notes.
Correct.
That is not negotiable.
Correct. That's
and the
not
coding
negotiable.
Must be appropriate to how you've practiced.
No, absolutely. You cannot change your style of documentation to support coding. Yes. So your documentation needs to be the way it is currently. The additional layer is, if you're not doing the coding yourself, you then have to provide that additional information to say this laceration is in a certain area, it's so many centimeters, this is the depth, so that when you do your billing, that actually corresponds to the code you're selecting, because you could end up selecting or applying for Rule C when there is a valid code, because someone did the coding and didn't actually choose the correct code because the information was incomplete. So if I may, I just want to add to the whole collaboration discussion that's been taking place. So the question often arises, and this causes a lot of frustration amongst a lot of clinicians, is that Discovery is paying for this, but this medical aid doesn't pay for this. Why? There isn't any body like, I'm going to bring FISC in, Matt. Matt and I are both ex-chairpersons of FISC and current members of FISC. So FISC is your only kind of health standards body that looks at clinical coding and other health standards currently in the country. And FISC does work that the National Department of Health has often adopted and implemented as national standards, like all the rules, guideline standards around ICD-10. So often we get queries coming to FISC, please assist with this particular billing query, and FISC doesn't have a mandate to address any issues around billing. I mean, 2 days ago at the FISC meeting, a neurosurgeon came through with assistance on how to bill and code for PRF, pulse radio frequency modulation for pain management. There is no standard. In fact, the AMA has suggested that we use an unlisted procedure code, which medical aids are not accepting. So they're using codes for rhizotomy and a whole lot of other CPT codes, and there's 2 RPL codes that they're paying on that has nothing to do with PRF or radio frequency in any case. So FISC can assist in the standardization of the CPT and the use. I know Simon says RPL, but RPL or NHRPL is the word that gets thrown around, Simon. NDCM doesn't come in quite often in that space. So we can standardize that from a FISC perspective, but the billing guidelines, the billing rules around that, FISC cannot do that. So the question I'm asking, Sama, is why isn't there a body with representation from all funders, as many providers as possible, that can actually address the collaboration issue that's been raised by Stephanie, by Simon as well, so that everyone can get together and say, okay, for this particular MDCM code, these are the bundling rules. If you do this, this is unbundling. There's so much of errors happening around bundling and unbundling because there is no explicit information documented anyway to say, I can use this code with this code, but with this code I cannot use. And this is where clinicians experience a lot of rejections because those rules are not documented. Not every scheme understands it in the same manner. And one scheme might accept 3 of those codes and another scheme says, no, that's bundled in, I'm only paying on 1. So Conrad, I think there's work to be done in that area.
I think there's always work to be done. What you're talking about, basically anybody can set up an independent body to deal with the problems that we have. And we don't actually expect a society just to come to summer running with a new code. We expect them to do thorough work. Actuaries go to this new body called SACHI before they come to summer. We are just publishers, administrators. We are there to mediate between 2 parties, the society and the clinician, and the funders. Simon, just basically, just can you keep it short because we've heard your solutions. We're running out of time. But your solutions to the problems, the pitfalls that we have.
It's called the South African Classification of Healthcare Interventions, SACHI. It's an independent non-profit organization that was set up in 2008. We are at the end stages of completing the MOI. The 4 founding members on the board will be SAMA, SAPPF, Board of Healthcare Funders, and Health Funders Association. It is a centralized national governance of coding where the codes will sit through the SAMA process that will not change. The coding experts will sit there. There will be an education. There will be a resource. There will be utilization committees, RVU committees. In other words, when somebody brings a code for review or addition, that code is visible to the entire ecosystem as it starts its journey. So that before that code is published in the SAMA MDCM, we have all seen it and we all know what the system is going to do with it. And it's working on the premise that if I bring a code that is international best practice and there is a descriptor that describes that, it is unacceptable for the funder to say they won't pay for it. They can't just say it's not scheme benefit. There has to be a system within the process where we can look at projects, we can look at utilization projects, we can look at impact studies. So this is going to help innovation, it's going to help bring in new coding systems, and it's going to answer all of this that we're speaking about. Conrad and I are sitting on the steerco looking at that Moy, so we've advanced this quite far. Thanks, Conrad, for the opportunity.
No, thank you for this engagement. We've written all these issues, and I think we are capable of addressing a lot of the problems that we brought forward this summer. Thank you.
Thank you so much. Thank you to Dr. Mashalwani, and thank you to our panelists. I think it's been very insightful. Collaboration, collaboration, collaboration. I think the conversations shared this morning have highlighted the importance of collaboration. In the interest of time, we will now break for lunch. I ask that we please reconvene at 1 p.m. sharp. I will ask my colleagues to ring the bell again as we will continue with the afternoon program at 1:05. Thank you so much. The clock has struck 13:10 now. I think we're going to get started. Welcome back, everyone. I trust you enjoyed the lunch break and the opportunity to connect, network, and have discussions with colleagues. We now move into our next session, focusing on prescribed minimum benefits. Hi. We now move into our next session focusing on prescribed minimum benefits, an area that remains critically important within healthcare funding, patient access, coding reimbursement, and clinical governance. To lead this discussion, we are joined by Dr. Sandile Mhlongo. Dr. Mhlongo is a medical doctor and health economist with expertise in healthcare financing, managed care, and healthcare strategy. He has held leadership roles at Discovery Health, Netcare Group, and currently serves as Managing Director and Chief Health Economist at Curus Solutions. Please join me in welcoming Dr. Sandile Mhlongo.
Good afternoon to everyone. It's always amazing to lead the graveyard shift where everybody just wants a siesta after lunch and relax. But on the other hand, I guess I can say a lot of things that nobody will pay attention to because nobody's really in the room, isn't it? Thank you very much for the opportunity, Andrea, and thank you for the invitation to the summer team, especially the clinical code unit and professional affairs team. I was asked to talk to an interesting topic. It's actually quite dull, to be quite honest. Nothing is new about prescribed benefits. We've interacted with them since their promulgation, I think 2003. But we still have challenges in getting appropriate reinvestment. In fact, just understanding of how do the PMBs fit into the whole spectrum. I like what was said earlier on about we should code for the clinical services and clinical conditions that are confronting us rather than to code for reinvestment. And that's where the first mistake is made, when you are trying to fit reinvestment into what the clinical circumstances were. And if we can just firstly deal with that, what it is that we are trying to do is to just try and codify the clinical services and procedures that were performed and the condition that the patient presented with. And reinvestment is secondary to that. If it does fit the PMB, great. If it doesn't fit the PMB, you can't go back and then try and revise that and say it needs to fit the PMB. So I don't represent the National Department of Health, nor do I represent the Council for Medical Schemes, nor do I represent any medical scheme for that matter. So I'm just trying to actually contextualize with the best understanding of what this topic is about as it pertains to coding. So we all know PMBs, actually the history of PMBs promulgated, as I said, and added as a part of the regulations in 2003. But there are three aspects to PMBs, the emergency medical conditions, the DT-PMBs, as well as the chronic disease list. I'll outline that in my next slide. But the essence of PMBs is really to ensure patients actually have continuity of access to essential healthcare services and they do not face catastrophic healthcare expenditure when afflicted by serious healthcare conditions. In the US, which is perhaps what we often reference, people actually lose their homes when they have a serious medical conditions. And the intention around PMBs as a principle was to ensure that it never happens. So when patients need access to essential healthcare services, the prescribed minimum benefits were intended to guarantee that. It's not akin to saying every single healthcare interaction is therefore a PMB, but I think the the understanding of catastrophic healthcare expenditure when facing serious medical conditions should always inform how we need to think about the principle informing prescribed minimum benefits. So it's about access and continuity of care. There are certainly lots of faults, and I'm not here to defend those, and I'm not here to say they are right or wrong, but there are lots of faults, and I think we can have a whole month of discussion around what are the faults within PMPs. But as they exist, we need to exist within the confines of that. When I talk about faults, I like the example of thinking around, if I'm driving on a road where the speed limit is 40, and I think the speed limit is 60, it doesn't mean I therefore drive at 60. It's 40 because that's what the law says. Be it I think it should be 60, or vice versa. If it's 60 and I do think it's 40, that's just what the confines of the law say. And I think our understanding is often misplaced because technology has morphed. Especially healthcare services technology has evolved significantly, and the PMPs have not been updated since they were initially promulgated, and therefore there's that gap. But you can't solve that in the billing system. You solve that through a legislative intervention. So we must keep that in mind, that when you are coding for what exists within the defined prescripts of the regulations. So emergency medical conditions, emergency in fact is defined in the Act. In the regulation. So it's not subject to my interpretation or your interpretation. It's defined. It's a sudden and at the time, unexpected occurrence of a serious condition afflicting a patient, without where there's no immediate medical intervention, be it medical or surgical, the patient would have faced either loss of life, loss of limb, loss of organ function, and that's very well defined. I'm not going to reread it for you. It's on the screen. The chronic disease conditions, there's 26 of them, as well as HIV, however you want to see it, as a DT or a CDL. But there's 26 conditions. They are very well defined. For instance, diabetes, type 1 and type 2, ischemic heart disease, and so on and so forth, heart failure, those are the conditions, epilepsy, those are the conditions. And then the DT PMPs, there's 272 pairs of DT PMPs, and we often refer to those as a pair because there's a diagnostic component and a treatment component. They go hand in hand. You have to see that as a complete picture. And I think most of the challenges on coding for PMPs particularly happens within the context of DT PMPs. I won't talk too much about CDL. CDLs, the ICD-10 codes that are permissible are explicitly listed in the annexures, in the regulations, so you only need to refer to the listed ICD-10 codes. If it's outside of that, that's the end of the story. But how do we code? The framework is very simplistic in and of itself, but it's how we apply it, and that's really where the complexity is. The diagnosis and billing must align. So what is the diagnosis? Particularly, I'm treating this patient with diabetes. And there must be, therefore, the secondary part, which is what is the treatment that's allowed? And I think a part of what I just want to differentiate is understanding what is fundable as a PMB versus what the doctor then, or the clinician at hand decides what is appropriate for the patient. Those are two separate issues. So we should be able to separate what the doctor, if, for instance, the doctor decides for this condition, this is the treatment. I'm going to make an example with breast cancer. If the doctor decides this patient requires the most innovative treatment, dual hair tooth therapy for their breast cancer, that's all said and well, and it's fine. Is the breast cancer treatment that's prescribed in line with what the doctor is prescribing? And that's where often the tension arises. So there has to be a match between the codified condition, the treatment that's prescribed, and what is allowable within the Act. So the important part is how to ensure that there's complete information. So chest pain, is that sufficient? If a patient presents with chest pain, it could be gastritis, it could be reflux, but it could also be ischemic heart disease. And ischemic heart disease is a PMB, but the chest pain in and of itself could have been any one of those. So how do we make sure that the coding is updated as far as accurate as possible and updated to reflect the final diagnosis, not the clinical presentation. And that's really where the gaps happen. So if we don't have that final diagnosis, you will end up missing out on that condition being recognized as a PMP. And therefore, even if the patient actually did suffer from ischemic heart disease or an acute myocardial infarct and presented with chest pain. So that those are the nuances that we need to be aware of. And so when we miss that, I think an earlier presentation talks about revenue cycle issues, and that's one of the biggest challenges. It affects reimbursement, so we miss out on potentially getting appropriate reimbursement. But also sometimes patients need future authorizations that can be missed. So if I did not actually code it correctly and it's not recognized as a PMP, an authorization for a future dated procedure can be missed. And so how do I make sure that as I code in the primary event and also submit the information to the medical aid, it is as up to date and accurate as possible? So one of the biggest pitfalls, I'm not too sure how many people use this spreadsheet. It's an industry published document, and most of us use it, right? We all are aware of it. If you're a coder and you're not aware of this Excel spreadsheet in the background, I'm not too sure what you use. But I don't know if you should call yourself a coder. But anyways, we are not there. But in the same location where you find the spreadsheet, the Council for Medical Scheme publishes the excerpt that I've just put up front, right? This is not legislated. It's a guide. So the fact that a code exists in this spreadsheet does not define that condition as a PMB. And I just want to read at the bottom here, they say, the codes in this guideline may be associated with the cause of the condition or may describe the functional state. The inclusion of the code here does not imply that the condition automatically qualifies for prescribed minimum benefits. Very important, it's a nuance, right? It's what the CMS publishes for all of us to actually have some kind of guidance around this was the intended, and most likely this list of conditions will often fit the definitions. But it doesn't mean that they will always do that. So if you go to their website, this is the first thing that pops up. Before you even download the spreadsheet, this is the pop-up that you get. But I guess often, what do they say? If you want to hide information, you've got to put it in a book. So this is how it's hidden, actually. It's just written out there. So this is one of the biggest pitfalls that we over-reliance. And so I think Simon was talking earlier on about the narrow set of lists that we use. So we kind of actually find the codes that actually we know will be on the spreadsheet. And so if I use these codes, they should be reimbursed. And it doesn't always necessarily work that way, So then you start with ICD-10 codes that are reimbursable because I found them on the list. And which ones have previously succeeded is a procedure code in getting me reimbursement. And then I link those two. And then voila, Bob's your uncle. And so therefore that we use that as a reference point. And it was quite interesting what you were saying, Simon. It's so true. Matt, you were talking about outliers. If you found a doctor who actually does this accurately, the coding for the conditions that they see, that's the guy who's an outlier. And that's the guy you will be sending your outlier management team to go and meet and say, go to peer review because something is wrong at your practice. Why? Because that guy actually codes appropriately for the conditions that they see. So what is legislated and how should one interpret it? And I've just used here a couple of examples. So this is in ophthalmology. 405B is the provision code. And the diagnosis that's prescribed in the regulations is glaucoma associated with disorders of the lens. It's not all glaucoma. It's glaucoma that is associated with conditions of the lens. And that falls under that provision. And what is the prescribed treatment? Surgical management. In the second code, there's more. It's 407B, primary and open-angle glaucoma with failed medical management. And so that's the nuance that actually we often miss. So the ICD-10 codes don't often describe these things. So in the first example, the commonly, and even in the Excel workbook that the CMS publishes, they actually give you age 40.8 other glaucoma. So other glaucoma could be a lot of things. But the Act stipulates glaucoma associated with diseases of the lens, and that's really truly the nuance. That's how you will get that recognized as a PMB, not because it's just other glaucoma. So if you don't substantiate and give, because there isn't a code that actually will define glaucoma specifically, you have to use a secondary code, or you'd actually have to provide medical, clinical information to say, this is the underlying disorder that I'm trying to code for. Only then that actually meets criteria as defined in the Act. And so if we use what doctors love, glaucoma unspecified, where does that leave us, right? And we all know the 0.9 is the savior for almost all doctors, right? Any ICD-10 code with a 0.9, we love it. It just says unspecified, so I don't have to tell you more of a story beyond that. So, and this is actually some of the challenges that actually lead to reimbursement, that if a patient actually did meet the criteria and it was coded appropriately, this should be a smooth, systematic approval that leads to better reimbursement. But also, not only that, we also then, what we also don't understand about coding, understand the current context of our medical problems, so we know which people actually have failed medical. So it's easy when we then talk about we need to escalate care because patients, or we need to find possible avenues for funding patients because we can see that a substantial portion do fail medical therapy, but we don't code that. And so the implications downstream is that actually it comes back to bite us because we actually only use that which is convenient in the moment, but in the background, all of that information is lost and it doesn't help us plan the healthcare system better and actually prioritize which conditions require better interventions or more sophisticated interventions. So the last one I just wanted to talk, and also the specifics around the treatment pair is important because you can see here there's very specific legislated information. One, surgical management. The second one is trabeculectomy or other surgery. And the third one is laser surgery. Now, it's not to say laser surgery is the most current form of medical intervention or form of intervention appropriate for retinal vein occlusion. I'm not saying that. I'm not saying it's appropriate. But what you're not going to succeed is arguing this as a PMB in the current guise because the legislative mandate that allows the scheme or the regulator to actually look at this is prescribed like that. So we have to look at what is the correct avenue to get that changed. And there are actually ways to get these things changed because actually if the legislation is not moving with the time, we need to find ways to then get this addressed. I'm not saying I have the answers to that, but certainly how do we argue this case? The case actually here for me, it's a case closed because the legislation only prescribes laser surgery. So, and as I said, this doesn't require any repetition. We must quote the clinical truth. The reimbursement is a subsequent outcome. And of course, we do want doctors to get paid, and as a doctor as well, I do want to get paid when I've seen patients. But the coding is not led by reimbursement. The coding is the clinical information about the clinical intervention, the healthcare service delivered, and the reimbursement is a subsequent issue altogether. So the impact, as I wrap up, the impact of incorrect coding is often patients face unexpected co-payments. And there is a way to have coded for any of those conditions in the previous slides so that they are reimbursed as PMP. So patients will be paid, will experience co-payments, out-of-pocket expenses, delayed authorizations and treatment access, and also an interruption in continuity of care, but more so for the doctors that we work with, particularly delayed claims. Claims rejection is the biggest issue. And so therefore the revenue cycle management is impacted, and so we actually end up having to find alternative ways of actually improving our reimbursement rates and the money that we get. And often the other issue is that then when we find alternative measures to get reimbursement, we find actually incorrect substitutions that lead us to audit and then medical legal exposure because we are not reflecting the clinical truth. We are reflecting that which would have achieved the reimbursement. And so in summary, really, accurately use the high specific ICD-10 code reflecting the condition, and I'll just give one or two examples to show what I mean by this in the next slide. and show that the diagnosis and procedures do align appropriately. So the procedure that was performed must be in clinical context and appropriate for the condition that we are coding for. So it must make intuitive sense. And of course, which we know is the biggest gap, the clinical notes. I'm not too sure, Simon, if they should give us the clinical notes back, because oftentimes there's no notes to give back. So you're just working off what, and I think the coders here will attest to that, right? There's hardly any clinical notes that actually you are working off like really shorthand scripts to say this is what happened. And that's one of the biggest, when medico-legally, that's one of the biggest pitfalls in the healthcare system, that we don't document, let alone document properly, let alone document appropriately for the context in which the patients are presenting. So just as a few examples, so if you look at in the first column here, gastroscopy, R1004, that's abdominal pain. So that doesn't tell me what the condition, but if I say it's gastroscopy linked to a gastric ulcer with hemorrhage, it's the same patient with the same context, but that makes a massive difference because now there's a clinical justification for the condition that I'm coding for. And equally, angiography, when there's just chest pain, may or may not make sense, but it's much more clinically appropriate and it's intuitive as well clinically that if it was unstable angina, then that's a patient who should get angiography. And equally, a CT brain linked to a cerebral infarction makes much more sense than a patient presenting with a symptom code of dizziness, right? And so that extra layer of what was the final diagnosis, what was the most accurate and final detail of the diagnosis in the ICD-10 code that defines the patient clinical circumstance that I need to use is actually what makes the difference. And you can see that this could have been actually appropriate. Clinically, there's nothing wrong, but it makes a huge difference because just taking the extra step of saying I updated the coding once the final diagnosis has been achieved, and therefore I reached the conclusive diagnosis, is what actually leads to better reimbursement, better treatment care, better appropriation of benefits. The key takeaways from me really is that we should make sure that we review the clinical notes, we revise the clinical information as it presents, particularly for protracted clinical presentation. So a patient may present at casualty with a symptom code and upon discharge from the hospital, and often you see that that's carried right through the event. Right, the patient was admitted because they needed to be worked up. They did have chest pain and the authorization was granted on the basis of chest pain. But that evolved over time, and it's the doctor's responsibility, and I can't remember who said it earlier on in this morning. It must be the doctor who leads because that's the diagnostician who leads the diagnosis change, and therefore the hospital diagnosis must align with what the doctor has provided. So that is one of the key things. And the clinical documentation that supports, because sometimes we don't have just, like for instance, the fact that there was a lens disorder, there's no code that defines that. But the clinical information in the notes is what will actually make explanatory notes so that when there's an audit, first of all, even if there's no audit, but I can explain and justify why I'm asking for this procedure or why this condition is a PMB. And lastly, we must just be aware that the reimbursement part is secondary. But also schemes do actually have allowance in terms of the rules in terms of the Medical Schemes Act, how they can actually, for instance, DSPs, protocols, and so we must also understand those come into play when we want to interact with PMBs. Thank you very much.
One second. Do we have a question for Dr. Mhlungu? We've got about 2 minutes. Simon. Thank you.
Your comments on the fact that the PMBs have not been reviewed for so many years are now actually out of date. So if you take where the prescribed treatment or the funded treatment would be surgery for glaucoma, that's the question is, what is that surgery? And the answer would be, well, it's what's standard practice in the public sector, state hospitals. But because the PMBs have not been reviewed, the level of care that is now offered in the state hospitals is much better than it was 17 years ago. And yet they're still applying to what was 17 years ago. That's causing huge problems.
You're right, Simon. This is just you are right in principle in what you're saying, that actually the PMBs need a review, and I think we do need to take steps to force the National Department of Health to actually go through a process of reviewing. We go through year on year, firstly around the 2010s, the ITAP process and then PMB definitions review, but none of that gets actually into the regulation. So that's, I think we do need to take it up, and I think your experience in the last week should tell you that there are avenues to get these things done the way we think the healthcare system should be done, right? So it's not that we should just accept that the legislator, the policymakers are sitting and sleeping when they should be doing work that's meaningful and that will impact patient lives. But one of the misconceptions around the standards of what should be prescribed, the Act actually doesn't say it's what the public sector provides. Annex B is very clear that if there are significant differences between the public and private sector, and so often the starting point is to establish what is the prevailing level of care. That's what the annexure speaks to you. Firstly, establish what is the prevailing level of care. And prevailing level of care may or may be different between the two sectors. And then I think in that case, and we know the public sector will always be, a couple of decades behind private sector levels of care. But that's most people actually just default to. But this is not available in state, and that's not what Annex B speaks to in the definitions.
Thank you so much. Thanks. I love the quote, code the clinical truth first. And to yourself and to Simon, I don't know if giving the script back to the doctor works, because sometimes they also go like, can't read their own handwriting. We will now move into our breakout sessions for the afternoon program. Delegates will have the opportunity to choose between two concurrent sessions based on their area of interest. Session 1, presented by Anton van Schalkwyk, will happen here in this room and will focus on accurate coding through electronic health records to improve access to funder and scheme benefits. Anton became involved with claims at MediHelp Medical Scheme. In 2014, he became involved with coding and clinical validation for surgical claims. In 2018, he became clinical coding specialist at SAMA. In 2022, he took the lead in coding at SAMA. He has now moved to Insight Health Solutions as clinical coding specialist in May of 2025. Session 2, happening in the room next door, if you exit the doors, the first door on your right-hand side, is presented by Dr. Joe Samsonovitz. Will focus on the challenges faced by GPs with common in-room procedures. Dr. Joe, as she's affectionately known, is the medical advisor in MedScheme's Healthcare Forensics Department with experience in healthcare forensics, fraud and abuse, oncology, and clinical hematology. She has worked in both South Africa and the UK and has held medical advisor roles at MedScheme for over 10 years, including within healthcare fraud, clinical review, and medical advisory services. Delegates are kindly requested to proceed to their selected sessions, and we ask that everyone please break at 14:10 for the afternoon refreshments, and we will reconvene in this room at 14:25 for the final session of the day. May I please ask that all speakers speak directly into the microphone so that our virtual delegates are able to hear you. Thank you. For those who would like to join the session 2, you are welcome to exit through the door, first door on your right-hand side.
Are we all sorted? Everybody where they want to be and need to be. So we are going to talk about electronic health records in South Africa, something that keeps on eluding us. Let me ask you a question as a coder. What is the one thing you wish you had when you code for a difficult case? I bet that the answer would be something along the way of information that's missing that you wish you had. So let's look at the current context. And once again, I so wish I had I had stronger glasses for this one. Because I cannot see on the screen there. Let me just see if I can get a better version here for myself. I just want to open that slideshow for myself. So I'm going to turn myself a bit because I don't think I will be able to assist myself with this one. There we go. Okay, so that monitor is not working. But let's go on. We sit with a situation where we are totally working with different realities as coders. There we go. Now I can help myself. What we sit with as coders is patient histories that are totally incomplete. We sit with continuity of care that is often invisible to the very people responsible for translating it into codes. And clinical records that are dispersed across facilities. Now, one thing that we have to understand about electronic health records when we talk about that is it is more than just the uploading of reports. If you think that is what it's about, you are sadly mistaken. Because there's some intelligence that's these days being built into electronic health records, and we are going to look not only at what we sit with in South Africa currently in terms of the silos that we are working with, but also best practices out there internationally. So there's the absence of universal patient identifiers that we currently sit with. Even if you have electronic health records working in some ways in South Africa, they are working in a siloed environment. there's the absence of universal patient identifiers. So, you know, if you are on the one electronic health record, the other one doesn't necessarily know about you. There's the inconsistent adoption of digital records. You have different electronic health record systems in South Africa, but it is not adopted in a consistent manner. And then there is the lack of interoperability. So you would have, for instance, very nice electronic health records that Discovery has. You would have a very nice electronic health record that some hospital groups have, but they do not necessarily have interoperability. So in some way, we are working blind in terms of prior diagnosis, chronic conditions managed elsewhere, and interventions performed in other facilities. And if you are a smart coder who knows about comorbidities and so on, you start to know when to ask the right questions in terms of a patient. Especially if the comorbidities needs to be coded with and doctor doesn't provide all the information. And therefore, we are coding blind, but that, in terms of that. It's not only the clinician that's working blind. Patient comes in, cannot speak for themselves. Doctor is coding totally. Or doctor is working totally blind. You and I are coding totally blind. So the result is fractured records. There's a variability in coding outcomes across providers as well. The hospital, the clinician, and various clinicians, for instance, working in ICU, and the anesthesiologist would often claim totally different things. There's administrative duplication, which puts an extra burden on everybody. There's not a person or a company within the healthcare space that doesn't feel that extra administrative burden because everything is being duplicated. And it also has an effect on extra claims. Therefore, it affects the affordability of healthcare. We have undercoding of comorbidities. We have already discussed this because of fractured records. And there's a misclassification of complications. And as a result, what we often get is clawbacks. What we get often is forensic investigations, and who can blame anybody for not knowing what the right outcome should be because everything is fractured. So coding accuracy begins with data integrity. That's what we need to say to each other. Coding accuracy begins with data integrity. And doctors' bad handwriting that we have been joking about is only part of it. It's the total inability to get the correct information sometimes. That's the problem. Instead of working with completeness, we are working, all of us, with broken records, fractured records. And what we need is the structure of electronic health records. with data availability in real time. All that we need to do is to pull it up. So what we sit with is waste and duplication. The GP would request certain information, refer it to a specialist, and the specialist would ask for exactly the same information after seeing the same patient. Supporting evidence-based policy and pricing. This supports national actuarial modeling, and I've been talking about the actuarial part earlier. Without supporting evidence and pricing, we cannot do the actuarial work. Part of the problem that we have in South Africa is that because we do not have accurate data, it's very difficult to do accurate costing. And therefore, this can be remedied by universal electronic health records. Accurate coding would, in the end, equal accurate funding. In the end, ladies and gentlemen, what we need for accurate funding is to be able to see exactly what the hospital sees, to see exactly what the doctor sees, to see exactly what the pathologist and the radiologist sees. The talk of the town these days is value-based healthcare, and some of the societies are working towards it. I know psychiatry is working very, very hard to get to a value-based healthcare solution. But here's the problem. Value-based healthcare struggled to be legitimate if we do not have the data to support the value that we want to base it on. And therefore, again, when it comes to actuarial work, to ensure that the value-based healthcare is not only clinically correct, but also financially correct for the payers, we need data. So let's look at international benchmarking for EHRs. One of the first was the United Kingdom. Of course, they are very proud of their public health care, and they needed that. So what you have with the United Kingdom is a very old and established system where the United Kingdom saw to it that even the most cash-strapped clinic could access the necessary information. And therefore, in terms of the United Kingdom, one of the things that we need to look at in the way in which they structure it is, first of all, they have the unique identifier for every patient in the NHS. And secondly, they work very strongly with open source software architectures to make it as affordable as possible. Implementing proprietary EHRs software across thousands of resource-constrained public clinics would be financially impossible for them. And therefore, when we look at the South African setup where some providers are sitting in rural areas, they do not have the resources of very wealthy urban providers, it must be it must be conducive for us to look at the UK's architectures to see what are they doing to make it as affordable as possible. Estonia is, of course, one of the countries that are doing extremely good work in terms of their electronic health records. And the way in which they are winning it is in terms of their, shall we say, X-road data exchange infrastructure. Nothing is centralized with them. What you have with Estonia is a federalized system that are talking to each other. So each organization can have their own independent software, but they link it with each other in terms of the necessary information exchange. And therefore, when one system crashes, it's not the whole system that crashes, it's only that one. So the independency of each facility's infrastructure and software is also conducive to their success. Finland is of course another one that's doing extremely good work. And one of their strong things that they do is it's not merely the digitization of records with them. They created a national archive, an exchange layer that also works towards other parts of their healthcare system. Their system also speaks to welfare records. Welfare organizations that are part of the system can also pull up some of the information. And therefore what you would, for instance, have in South Africa, if we take the lesson from Finland, is you would have a private consultation with a private doctor in private care. Say, for instance, you have been diagnosed with HIV, but now the HIV clinics can also, which is most of them are on the welfare side. They are using donor funds to be operational. So now the HIV clinic can also have access to that information to prescribe the correct information. And therefore, the necessary information can also go through to welfare organizations that have to look at the psychological impact of your diagnosis. So it speaks not only to formal private healthcare organizations and doctors. It also speaks to the welfare side of the community. Denmark also has a very good system. And what Denmark is doing is they, on the other hand, decentralized with regions, municipalities, and national actors involved. So they decentralized in terms of regions in their country in order to get the information together and then share among each other. And one of the things that they have done is they have made it as user-friendly as possible to empower patients to understand their records as well. It's not only for the clinicians. Singapore is also one of the countries with an extremely good public health sector. And as you may know, Singapore's government is extremely strong. So what they have done is they have merged it so much into their electronic systems in the country, that they have mobile phone penetration, so that you have apps in which you can even you can make your claims, you can post your claims, as well as the public can see those claims in real time. They also have various tiers of security to ensure that they are accessing the correct patient's information. And that all comes to those various tiers of security layers that you have with your cell phone, in which you have to okay certain things on your cell phone that happens in your bank account, for example, to ensure that your information stays private. And then one of the actors that can really speak to what South Africa is doing is Thailand. Thailand, for instance, is one of the newest ones in universal health coverage and universal health records. So we have a lot to learn from them. They are very strong on digitizing information that has always been paper-based. So they are trying to get the historical records in there. But one of the other things that they are doing is that they have proven that digital health records can successfully monitor public fund distributions and provider performances without relying on continuous high-speed fiber internet. And this is something that can really help South Africa to see what they have done, because not all regions in South Africa have 5G or fiber. Sometimes you have to rely on a very weak cell phone signal in order to be able to get to the internet, get onto the internet. And Thailand proves time and time again that they can service even the most remote areas of their country with their health records. And then, last but not least, there is Israel. And one of the things that they are extremely strong on is predictive population health and managed care. The strongest contribution that they can give us is that they monitor patients very actively on their health records, mining health data to flag high-risk chronic patients, for instance, before they deteriorate. And in that way, they can also, such a system can also play a very important role in lowering health costs in South Africa and improve health outcomes in South Africa. So South African initiatives include that of Netcare, and I must say Netcare has one of the most advanced electronic health record systems that we can have in South Africa. They have contributed a lot in terms of what we have to learn. They have their iPad ecosystem, for example, that they distributed. They have a centralized system to ensure that that data cannot be stolen. So you can watch, you can look, but on the iPads you cannot download the information. They have device and vendor interoperability and live equipment feeds on their health records. We have heard some of it from Dr. Lee Moses. They have pathology and radiology sync, AI pharmacy safeguards, that's very important, and patient-centered data continuity. Discovery also has quite an advanced system, and whereas the HR from Netcare is there to give an internal clinical workflow system towards all role players within a hospital. Discovery would follow that member wherever they go. Put the two together and you have something very good. HealthBridge has also done some good work in that regard in capturing the necessary information and making it available to their coders. But once again, it's still limited. If you are not part of the HealthBridge system as a doctor, the information that you provide is not part of that system. So we have to get rid of the siloed mentality, and that was the problem with Care Connect. We had Care Connect, wherein the big hospital groups, Discovery, MedScheme, Momentum Health, poured millions and millions of rands into that system, which was good in essence, but it did not penetrate the market enough. There was a slower than anticipated adoption. There was still a silo mentality. And in the end, it had to be shut down and all the information destroyed. And what is significant is that 100 million rands was invested in a project that did not survive. So the question is, can we do it? Yes, we can. Yes, we can. And what we need here is an electronic health record that is not a simple document that's being uploaded, that has the architecture to handle it. A patient record can be anything from 1 to 10 gigabytes. In South African terms, petabytes if you take it nationally. That's big. But it also requires that we do it here locally. I'm going to motivate this, what I'm saying now. And this is something that came to my attention for the past few weeks. Inside the European Union, they woke up to the fact that they are way too dependent on American cloud-based companies. And what woke them up was the fact that the International Criminal Court was suddenly kicked off Microsoft. All the information that they had on the cloud was being locked because of politics. It was because the American government put pressure on them. So for the sake of the integrity of our cloud-based system that we plan to invest in, it is very important that we do this locally to ensure the sacredness of our electronic health records and to ensure that we are papaya, that we are based on papaya rules. Here's the thing. If you do it through an American company, the American government always has the right to spy on any of the information, no matter what they say in terms of the security of your information. Why do we need it? Private public healthcare to NHI needs it. And if we do not do it now, government is going to prescribe the architecture to us. So in terms of private design of what we need to do it now. And we need to do it urgently. If we do it now, we can ensure that we have a sustainable future for healthcare in South Africa. So what we need is we need to learn from the lessons from the past. Care Connect wasn't in vain. There was incredible important information that we can take into the future. Lessons that needed to be learned. The best international EHRs out there all have lessons for us to learn, to do better than any one of them. And we have the IT expertise to be able to do it. Let's go back to the early 2000s, and I'm now giving away my own age. I think it was in 2002, Simon, you will be able to correct me, when South Africa, ouch. But I know you have been historically very involved with SAMA as well. I think it was in 2002 when we had a werksberaad, a bosberaad, to decide on CPT. And the whole of the industry came together. I mean, we spoke about CPT today. How did it come to be that we use CPT? We decided together as an industry that CPT is going to be our benchmark. Everybody came together and said, we cannot continue the way that we continue. We need to do something new. We need to benchmark our coding. And that's how CPT became the national benchmark. So we need to come together again as an industry and say, this is how we are going to do this in the future. Maybe it's good to take something like SACHI and make SACHI the necessary home for electronic health records where our coding should also be housed, where we all come together to decide on our coding. This is the place where we can decide also on the protocols and rules that our electronic health records should be based on. And then finally, we decide on an architecture for interoperability. You see, Discovery has their electronic health records. Netcare has invested hundreds of millions of rands in their own electronic health records. All that we need to do is we need to have the architecture where all of these can talk together. You can have your fancy electronic health record that serves your patients and that serves your doctors. But the necessary information needs to be carried over. Maybe a federalized system for our system is a good system. We just need to teach each other how to have these systems speak to each other. In the end, ladies and gentlemen, here is the secret of electronic health records. It will most certainly have a positive impact, not only on coding, but on the future of healthcare in South Africa. Because it will have a cost-saving effect. It will ensure that we serve our patients better. It will ensure that coding is much more robust than what we have at the moment. Thank you very much.
Thank you, ladies and gentlemen. We will now break for tea. Please may we reconvene at 14:25. We'll give the last few delegates just a few minutes to grab their seats. Welcome back, everyone, and welcome to the graveyard shift. Maak jy vol oogies toe is what we would normally say in Afrikaans. For those who don't understand Afrikaans, when your tummy is full, you're very sleepy. But we are trusting that this will be an insightful and engaging discussion as much as the breakout sessions were. We will now continue with the next component of our program, the hands-on coding lab sessions. These sessions are designed to provide practical insights and real-world application within the evolving healthcare coding environment. We are privileged to have the following experts leading these practical and interactive discussions that will follow in series. First up, we have Manisha Bates, presenting on coding for an unlisted service. Manisha is a clinical coding and auditing specialist with extensive experience in coding governance, claims integrity, clinical auditing, and healthcare funding. She has worked with organizations including Discovery Health, Amplify Health, and Insight Health Solutions with expertise in coding standards, billing rules, and healthcare risk management. Following her will be Ramona Singh, presenting on the role of modifiers. Ramona is a clinical coding specialist with over 20 years of experience at Discovery Health. She specializes in coding, billing rules, clinical auditing, and procedure code implementation, and works closely with medical societies and SAMA on coding and billing standards. And finally, Zandile Shabane, presenting on add-on codes and unbundling. Zandile is a certified clinical coding specialist accredited by the AAPC with experience in medical scheme administration, reimbursement models, and coding compliance. Currently serving as senior coding specialist at SPESNet with expertise in both local and international clinical coding services. Please join me in welcoming our speakers. Before I start, I'd like to give a quick disclaimer, especially for Simon. Please don't bite my head off. I do use the acronym RPL quite frequently. And I do use the word coder. When I'm talking about coder, I'm also talking about a biller. And I do use the word provider, and I am talking about clinicians. So please don't take offense. For those of you are not familiar, my name is Manisha Bates, and I'm from Insight Health Solutions. We are a multidisciplinary healthcare advisory group. We bring together over 400 years of combined expertise within our team, and we support healthcare funders and healthcare professionals. These are the list of services that we actually support those individuals with. Today, I'm going to give you an overview on coding and unlisted service. possibly one of the most misunderstood areas in procedural coding. Not because it's complex, but because it sits at the intersection of clinical innovation, coding, and reimbursement risk. By the end, I hope you'll be clear on when it is truly appropriate, how to select a comparator, what is expected at pre-authorization, and how these claims are assessed. Item 6999 represents a procedure or service that is performed that is not listed in the RPL or SAMA structure. Governed by Rule C, it enables unlisted procedures to be coded by linking it to a comparable service. And that leads to a critical principle. It does not stand alone. The validity depends entirely on the strength and appropriateness of the comparator. There are also key limitations. It is not permitted for pathology services, and importantly, it's not intended to be permanent. So where a procedure becomes more routinely performed, there is an expectation that a formal request for a dedicated code be submitted to SAMA. So why does 6999 matter? It actually ensures that clinical innovation is recognized responsibly while supporting consistency and standardization in coding and reimbursement. Ultimately, 6999 is not a default code. It's a structured, rule-based solution for real gaps in the coding system. So why should coders master the use of 6999? Clinical innovation is moving faster than coding systems can be updated. We are seeing new surgical techniques, increased use of devices, minimally invasive approaches, and entirely different treatment pathways. From a coding lens, this creates a consistent challenge. We are seeing procedures being performed where there simply isn't a code available for it. This is where 6999 steps in. It acts as a bridge between clinical practice and reimbursement, allowing us to code even when a specific code has not yet been established. If we look at the 2006 RPL, the rules around unlisted procedures was already clear, but the process was highly structured, often needing direct engagement with SAMA. Clicker is not working. Okay. Fast forward to the current SAMA MDCM, the process appears much simpler. The requirements often just a procedure description and an ICD-10 diagnosis. But here's the key point. The rules have not changed. Funders still require a clinically sound, well-justified submission, especially for high-value and innovative procedures. Today, the responsibility for clear justification sits more prominently with the coder. So while documentation may appear more streamlined, the level of review remains unchanged. The most important step is the selection of the comparable procedure code. 3 questions need to always be answered. What is the anatomy being treated? What is the clinical intent? And what is the procedural magnitude in terms of complexity, time, skill, and risk? All 3 need to align in order for the comparator to be justifiable. From a SAMA perspective, there is an expectation to identify and use the closest equivalent within the existing structure. At the same time, we know that this structure may not reflect newer or more advanced procedures. In those instances, CPT can be used as a supporting reference. One common misconception around the use of 6999 is that it somehow changes how the coding rules apply. In reality, it doesn't. So once the comparator has been selected, the entire claim needs to align to the rules linked to that specific procedure code, whether that pertains to procedure classification, whether it's your modifiers or your pre- and post-operative considerations. 6999 determines how the service is reported, but the comparator determines how the rules apply. So if your comparator is a major surgery, then your rules need to behave like major surgery. Realistically, there is often a natural lag between when procedure codes are published and when they are formally adopted for reimbursement. So during this period, providers are performing clinically appropriate services, but there isn't always an established funding code available. And this is where 6999 is being used. Using it creates a way for these services to be reviewed against clinical appropriateness, cost impact, alignment with existing benefits. So this is not a breakdown in the system. It is a real and necessary interim process. When requesting pre-authorization, funders will typically authorize using 6999 linked to the proposed comparable procedure code. This decision is largely based at this point on the motivation submitted by the doctor. That motivation needs to clearly indicate what procedure is planned, what is the intended comparable procedure code, the ICD-10 diagnosis, clinical rationale, and why existing codes don't fit. Providing this information minimizes resistance in the process. It's important to note that pre-authorization is not a validation on the final coding approach. It is actually the initial decision based on the information at hand, often before the full clinical detail is known. The true validation actually comes later. When a claim with 6999 is actually submitted, it is not automatically reimbursed. It will be flagged or pended for review. Funders move beyond the initial motivation and now request the operative report or supporting clinical detail. The claim will then be assessed in full context. This includes validation of your comparator, as well as the application of your core coding principles, like your unbundling, your duplicate coding, appropriate use of modifiers, and any upcoding checks. So the review is not isolated, it is holistic. Payment is achieved when the clinical story and the coding all align. These examples represent commonly used comparator codes, but being listed in the RPL and SAMA structure does not automatically secure funding. As we have seen, there is a gap between publication and funder adoption, which means that these codes may still require review. That makes 6999 a shared process. For providers, the success begins with supplying a clinically appropriate comparator, matching it to true procedural magnitude, and also backing it with strong clinical justification. For funders, the role is to provide a consistent and evidence-based review to determine clinical appropriateness, financial impact, and alignment with existing benefits. This approach supports advancing clinical practice as well as responsible reimbursement. Let's look at a case. A patient with symptomatic uterine fibroids chooses a minimally invasive fertility-preserving treatment to avoid traditional surgery and reduce recovery time. This procedure is incision-free, ultrasound-guided, and energy-based, with no excision and no embolization. And this is where the true coding challenge begins. Existing fibroid codes are built around traditional approaches, whether that is open surgery, laparoscopy, hysteroscopy, or embolization. This procedure fits none of that. So forcing it into an existing RPA or SAMA code does more than create an imperfect match. It leads to a misrepresentation of the clinical intent, the technology, and the treatment. This is precisely where Rule C6999 comes in. By referencing CPT code 58580 as your comparator, we are not importing a billing code. We are establishing a credible benchmark for procedural magnitude and clinical intent. Because the goal is not simply to find a code, it is to ensure that the work done is accurately represented. And this is exactly how 6999 is meant to work. In closing, 6999 is not a gap in the coding system. It is how the system manages gaps. It is a legitimate, governed mechanism for reporting real and necessary procedures, but it comes with clear boundaries. It is not a default or convenience code, a workaround for poor coding, or a reimbursement guarantee. What remains constant for both funders and providers are three non-negotiables: a clinically justified comparator, clear alignment to procedural magnitude, and clear, complete, credible clinical documentation. Clinical innovation will always move faster than coding systems. That is inevitable. 6999 exists to manage that reality responsibly and not to create shortcuts or deny progress. And when done accurately, we move from unlisted to understood. Thank you. Thanks so much, Manisha. Now, our next speaker, Ms. Ramona Singh.
Hi, good day, everybody. Just thank you for having me. I'm glad to have this opportunity to present about the role of modifiers, and I hope after this you'll understand the importance of modifiers in clinical accuracy and in helping with reimbursement. So just to start with the basics. Modifiers. So what are modifiers and why are they so important? So modifiers are actually codes that are used to indicate a special or unique situation that occurs during a procedure. So I've done a little table to show you what are modifiers and why they're needed and the impact of modifiers. So firstly, they ensure accurate payment. So it indicates complexity, reductions, or multiple procedures. It prevents overpayment, underpayment, and rejections. And the other importance is that it reflects clinical reality. Not all procedures occur under the same circumstances. So modifiers show you the variations, like whether it's unilateral, bilateral, diagnostic versus therapeutic, or multiple procedures, unrelated procedures. It aligns billing with what actually happened clinically. And then it supports transparent communication. Adding modifiers clarifies circumstances for schemes and auditors. There's fewer disputes and faster claim reimbursements. Then the lastly is compliance. It aligns to industry tariff and scheme requirements. It reduces audit findings, clawbacks, and compliance risk. So modifiers are basically categorized into 4 groups, and the way they categorize is according to the function or role that they apply to procedure codes on a claim. So as you know, most of us, the most common one is your addition modifiers, your reduction modifiers, your compound modifiers, and information modifiers. And I'll just take you through some examples of each one of those groups. Okay. So your addition modifiers, it adds additional remuneration by adding a percentage or a unit value to your procedure code. So I'm just going to go through modifier 7 and modifier 18. So modifier 7 is divided into 2 parts. There's 2 definitions to modifier 7. So modifier 7A is for the use of your own monitoring equipment in rooms. It adds an additional 15 units regardless of the number of equipment used. So there are a few guidelines when using modifier 7A. So these are basically for procedures done under intravenous sedation. Only one provider builds. It's either the surgeon or the anesthetist, and it's generally the person that owns the equipment. It can be built with modifier 4, and is not for your pulse oximeter, whether you're using a pulse oximeter monitoring or reading. So they're more for your like your monitors, like your BP, cardiac, or respiratory monitors. And then modifier 7B is for your own equipment in theater. So here again, 15 units is applied regardless of the number of equipment used. The guidelines for these are also very specific. They're for use of your own equipment when not supplied by the facility. So just to add that standard equipment fees are recovered from the facility and not the funder. And it cannot be billed with modifier 74. Modifier 74 is for equipment used during endoscopic procedures. And just an important part to add is that ultrasound equipment is included in an ultrasound code. So therefore, modifier 7 cannot be billed in addition. And then motivations can't change the outcome of the funding. So those are the strict rules, like guidelines that go with these codes or these modifiers. Then modifier 18 is your BMI modifier. So modifier 18 applies to BMIs over 35, and it's a surgical modifier. And basically here, it adds an additional 50% to the surgeon's fee, and for the anesthetist, it's an additional 50% of the anesthetic time. So here again, the guidelines, it's for theater procedures under anesthetic only. It applies to all modifiers except modifier 11. And then one of the stipulations is that the weight, height, and BMI must be on the invoice. And addition modifiers are billed on a separate line with its own value on the claim. So that's the guideline. And then we have the reduction modifiers. The reduction modifiers is opposite to the addition. It reduces remuneration by a percentage or a unit value of the procedure code. So the most common reduction modifier is modifier 5. So modifier 5 are your multiple procedure reduction. So basically it's multiple procedures done under the same anesthetic. Your first procedure, which is normally of the highest unit value, gets paid at 100%. Your second at 75%, third at 50%, and the fourth and so forth is at 25%. So just to note that the reduction in units is not because of a reduction in expertise or time or risk. It's the reason for the reduction in units is due to the post-operative care component. So we all know that there's a post-operative care component in all the major procedures, and that's the reason for the reduction when it's done under the same anesthetic. So there are also, again, specific guidelines, and these are all on the SAMA book, right? So some of the guidelines is it's not for add-on codes. It's not applicable to add-on codes. And it's not applicable to codes where the descriptor says maximum or subsequent. It's not applicable to per catheter invasion procedures. It excludes purely diagnostic procedures, including endoscopic procedures. Including diagnostic endoscopic procedures. It applies to fractures or dislocations and applies to in-rooms procedures done under sedation. Then the other reduction modifier that we have is modifier 6305. And this is for multiple catheterizations when angiograms are done at each level. And these are specific to code 3559, 3560, 3562, and 3557. So again, the guideline is the first procedure is billed at 100%, and normally it's the first order catheterization code is billed at 100%, and then your second procedure is minus 20 radiological units. The fourth is another minus 20 radiological units. So it's slightly different from modifier 5 because this is a reduction in units. And again, it's just applicable to your multiple catheterization codes. The other reduction modifiers that we have modify 13, 15, and 18, 83. So there are quite a few other modifiers that are reduction modifiers, but these are just some of the examples. The claims guide on reduction modifiers, you either do it on the same procedure code or you do it on a separate line. I don't think there's any hard and fast rule on that. Then we go to compound modifiers. Compound modifiers link to applicable procedure codes to add remuneration. So the most common compound modifiers that we have are your assistant modifiers and your emergency modifiers. So your assistant modifiers are your modifier 8 and your modifier 9. So modifier 8 is for your specialist assistants, and it reimburses 33.33% of the surgeon's fee. So SAMA has assigned 40% to modifier 8. The percentage is aligned to CPT, but in CPT there's a defined list of procedures where specialist assistant is applicable. And then in modifier 9 is your GP assistant, and that's 20% of the surgeon's fee, and it's a minimum of 36 clinical units. So the guidelines on these are it's either the surgeon or the assistant can render the account. The surgeon can do it on behalf of the assistant. When the surgeon renders the account, the assistant's name assistant's details must be on the invoice. So it must be the assistant's name, the PRO MP number that's required on the claim. If there's more than one assistant, and if it's a specialist assistant, the first specialist is billed as a modifier 8, and the second and subsequent assistants are billed as a modifier 9. It's preferably billed per assistant on the last claim line with the total RAND value, that is either 20% or 33.33% of the claim. At the moment, it's not billable for clinical associates until we get an industry standard on how to bill for clinical associates. Okay, the next compound modifier is your emergency modifier, that's modifier 11. So modifier 11 is for any bona fide emergency procedures, and it's all hours. This adds an additional 12 units per 30 minutes or part thereof. And it applies to the entire team. So here, so the guidelines here is that it's your emergency cases. It's basically your priorities given over booked cases. It's a surgical modifier. Again, it's not applicable to medical admissions. It's billed by all team members. This includes assistants and anesthetists. If a surgeon bills for the assistant, then a separate claim line for the surgeon's Module 11, as well as the other assistants are billed. It's appropriate for emergency C-sections, but not appropriate for vaginal deliveries. Okay. The next slide is just an example, a claim example. So you'll see there's the first procedure code is a cholecystectomy, and modifier 5 will apply. So the first procedure code of highest units pays at 100%. Right? Then the next procedure code, I've got 1757, which is suture for liver wound. Modifier 5 will apply, and it's paid out at 75%. Okay, then this patient has a high BMI of over 35. It's an addition modifier, and then the way it's paid out is the value of the cholecystectomy after applying Mod 5, plus the value of 1757 after applying Mod 5, and an additional 50%. So that will be the value of your BMI modifier. And then on this case, there was two assistants. One was a specialist. So the specialist assistant is billed as modifier 8, which is a compound modifier. And again, the billing of this is your value of your cholecystectomy, then the value of the next code, plus the value of your modifier 18, and then that's multiplied by 33 1/3%. And then your GP assistant or your subsequent specialist assistant is billed as a modifier 9. It's calculated the same way as the specialist, but it's times 20%. And then you'll have a look now. This was an emergency, so the provider billed the emergency modifier 3 times for himself, for the specialist assistant, and then for the second assistant. And then with the modifier 11, it's applicable, like we said, to each team member. The time in minutes must be on the quantity field, because the time in minutes will then convert to the units. So just to show you how the part thereof works, the first 30 minutes is 12 units. The 30 to 60 minutes is an additional 12 units, so then that becomes 24 units. And it's over 60, then that will be 36 units. So that's how it works. And then lastly is your information modifiers. So the information modifier, it just adds additional information. It has no financial impact. And again, this can either be billed against the code or on a separate line. So just some examples. Modifier 47 is information that it was a fracture not requiring a reduction, and therefore it is just billed as a service. Modifier 25 gives information as to when anesthetic time starts and ends. Then we're also pleased to say that SAMA has introduced 4 new modifiers this year, and this will give us additional information about procedures, and it'll have faster resolution on claims queries. And so some of the modifiers, information modifiers that have been introduced this year are distinct procedures, procedures performed on the right side, procedures performed on the left side, and bilateral procedures. So modifier 22 for distinct procedures, it's used to distinguish procedures that are typically billed together, report if unrelated to a procedure performed, example, a different anatomical site, ipsilateral, contralateral. It's not appropriate for ICU codes or consults and does not negate modifier 5. Then your modifier RT, which is procedures performed on the right side, is used to indicate procedures on the right side, required when a procedure is unilateral. It's reported for your paired organs, your eyes, your ears, limbs, etc. It does not negate modifier 5 and does not apply to add-on codes. So your modifier LT is the same as your modifier RT, but it's obviously to the left side of the body. And again, all the guidelines are the same. And then lastly, it's your procedures done bilaterally. Your modifier BL is used to indicate when the exact procedures are done on both sides on the same theater event. Add to each procedure performed bilaterally, not required when a procedure description indicates it is bilateral, does not negate modifier 5, and not for add-ons. And that's our modifiers. Not sure if there's anything. Thanks.
Our final speaker for this session, Ms. Zandile Shabane, on add-on codes and unbundling.
Thank you, Program Director. Good afternoon, everyone. I'll say again, good afternoon, everyone. That's better. I was checking that we are still all alive and not asleep. My name is Zandile Shabane. I'm a clinical coder at SpaceNet, And today I was asked to present add-on codes and unbundling. Firstly, I would like to also thank Sama for providing us this opportunity to relearn and go back to basics, guys, to learn all about the unlisted codes again and the use of modifiers, because refreshers are also important in our daily work. What are add-on codes? Let me start by saying medical coding ensures accurate billing and reimbursement, but accuracy depends more than just assigning codes. It also requires a strong understanding of add-on codes and the practice of unbundling, which can significantly impact claim validity and healthcare compliance. So these two important concepts will make us understand how to prevent claim errors, claim rejections, audits, and fraud risk. Because if indeed, after all the audits, it was found that it is fraud, we know that Mkhwanazi is coming, and you'll be asked to present yourself at the Matlanga Commission. So I'll also touch on coding practical examples for each. What are add-on codes? We know that add-on codes describe additional services performed during our primary procedures. So your plus codes, they are never reported alone. So you'll always have your primary code followed by your add-on code, which is therefore your secondary code. They often represent additional time, extra anatomical site, increased complexity. And for you to add add-on codes, you'll always need proper clinical diagnosis, supporting surgical reports, pathology, X-ray, etc. So the key features about add-on codes is that no standalone reimbursement, meaning if you're just going to submit your claim for an add-on code, which is your plus code alone, the scheme will reject and tell you that you need your primary code. No modifier is needed in most cases. If you take all your add-on codes, those codes already have reduced units. So that's why modifier 0005 is not applicable. The codes are identified by a plus symbol in your SAMA medical coding structure. For example, because I see a lot of coders actually struggle with identifying your plus codes. Same as identifying, I'm going to go off topic a little bit, your musculoskeletal modifiers. They'll just add your musculoskeletal modifiers, even though the guide states that if it doesn't have a TM annotated to it, you don't apply modified musculoskeletal modifiers. But you'll see that your plus codes, for an example, your 1588, that's plus polypectomy. That's your add-on code to your gastrostomy code, which is code 1587, or 1591, which is plus removal of your foreign body. So we're just going to look at the examples for your add-on codes. I've just excluded consultations and your materials and your modifiers. Focus is just on add-on codes. If doctor does a gastroscopy and plus removal of polyps, your primary code will be 1587 plus 1588. And if it's more than 2 polyps, then it means you can charge your code 1588 times 2 without the application of modifier 0005. Second example is excision and repair of your direct suture for 2 lesions. We know that our code 007 is the go-to code for all the excisions because we still don't have a broader codes for excisions per anatomical site. So your 0307 will be your first and primary code, and then 0308 will be for each additional small procedure. Biopsy with suture of the vulva, more than one biopsy. That code, your first code will be 2273, which is your biopsy with suture of the vulva, and 2270 will be your biopsy of the vulva or the perineum. And this code is telling you, list separately in addition to code 2273. Your primary code is 2273. If you apply it to any other code, it's going to reject. Okay. And before I go to unbundling, remember that your add-on codes, some of them don't say add to or have a plus code, for an example. They will say each additional, subsequent, or additional to the primary procedure. Okay. Then what is unbundling? Then I saw a note somewhere that says medical coding is the only job where unbundling gets you in trouble more than the airport security. So what is unbundling? So unbundling basically is the fragmentation of the main procedure into multiple procedure codes that form part of that main procedure. Okay, so it's when a provider reports multiple codes separately for procedures that should be built under a single comprehensive code. These services are not regarded as add-on codes because they are already included in your main procedure. Okay, so, and these units, the units for the main procedures are already inclusive of the extended time and complexity. So you find that most of the time those procedures have higher units. So as Dr. Chetty mentioned earlier, was that in some errors, they are not intentional. It can be a case of misunderstanding or misinterpretation. I'm just going to make another example of the gynae changes that happened in 2019. If we look at the old structure, I'm even scared to say RPL now, but if you look at the old RPL, for an example, the code 2560 for, it said surgery of endometriosis stages AFS 1 or 2 to 3. But if you look at the current structure from 2019, that code is more detailed. It includes, the description of the code also includes what is included in that procedure. So, same as the revised codes in your digestive system, that if you look at the new series codes that were added last year, you'll see that they give you guidelines and rules and which codes to add on and not add on. So unbundling often is considered incorrect billing or fraud. Why it matters is that it leads to overpayment, because if you're going to fragment the main code into multiple procedures, it will lead to overpayment. It triggers audits because once you are flagged by the medical scheme and there is evidence or proof that it was unbundling of codes, you'll be asked to pay back the money. It violates coding guidelines because if a code already tells you that this code is inclusive of these procedures and you do unbundling, which violates the coding guidelines. I would also like to add that as coders, we also need to use other sources for information. If you're just using a because it happens, people are still using 2011 MDCMs in their desks, and there's a 2026 MDCM. Obviously, that book is outdated and it doesn't have much information like your 2026 book. Also, use other sources. Like I use CPT when some of the complex cases come, because as South Africa, we also benchmark CPT as well. And other books like your Coder's Desk Reference for Procedures, which details what is or how is the procedure performed. So the relationship between add-on codes and unbundling is that add-on codes are allowed structured additions. Unbundling is improper separation. The key difference is that add-on codes are approved extras and unbundling is unauthorized breakdown. So the examples of unbundling, we have code for an explorative laparotomy for appendectomy. So the procedure includes the incision, the removal, and the closure. So if doctor is going to theater just to perform an appendectomy, code 1809 cannot be added because already that's a duplication of service. So it's the combination of code 1675 and 1809 is incorrect. Hysteroscopy plus polypectomy with sampling plus DNC. So if you look at 2437, it tells you that it is a hysteroscopy and sampling of the endometrium and or polypectomy with or without DNC. 2443, it's your dilation and curettage, which is your DNC. So if you're gonna code both codes together, that's another unbundling and duplication of service because already code 2437 includes your 2443. Last one, endometriosis with the removal of your ovarian cyst. This code, if you had to look 2560 in your 2006 RPL, it would just say it's surgery of endometriosis. It does not provide any additional guidelines or a full descriptive description. So, therefore, it was open for interpretation. However, now, if you look at code 2560, it's now more detailed. It tells you exactly what is being done. And if you're going to add code 2527 for the removal of your benign ovarian cyst, unilateral or bilateral standalone procedure, you'll see that in the SAMA MDCM guidelines states that 2560 includes your ovarian cyst. So common mistakes to avoid is that billing add-on codes without the primary code. So you need your primary code before you can add your add-on codes to avoid rejections. Double billing procedures, so unbundling is not allowed. Ignoring bundle services and misusing modifiers to bypass rules. So in conclusion is that add-on codes enhance accurate reporting, unbundling leads to compliance risk. Proper use of RPL, MDCM system use ensures that ethical billing is always adhered to, correct reimbursement, and reduced audit risk. In closing, I would like to say accurate coding isn't just about payment, it's also about integrity in healthcare documentation. I thank you.
Thank you so much. To Manisha, Ramona, and Zandile, I will find you afterwards to give you your gift as a special thanks. Simon, I didn't realize you had such an effect. People are saying MDCM instead of RPL. Before we move into our next innovation spotlight sessions, if you'd allow me, I think we could all benefit from a quick reset after a very full and engaging day. So if you are able to, I'd like to invite everyone to be upstanding. I'm glad that got you so excited. Now, let us close our eyes to the lovely camera lady. Just for a second, can you close your eyes too? Now I'm going to invite you all to stretch or shake or, Conrad, you need to close your eyes. It's not fair. To stretch or shake or reset for a moment before we continue with our final session. Let's go. I'm not seeing people stretch or shake or... Come on, we need to close our eyes so people can have their privacy. Sure, my eyes are closed. Awesome. Thank you so much. You are welcome to have a seat. Now let's move into what is certainly one of the most exciting components of today's program, our innovation spotlight. Our first speaker is Dr. Hilary Mukudu. Dr. Mukudu is a medical practitioner, digital health entrepreneur, and healthcare innovator with expertise in primary healthcare, public health, and epidemiology. He's the founder and CEO of TeleDoctor SA, a digital health platform focused on telemedicine, EMR systems, and remote patient monitoring to improve healthcare access across South Africa. Help me welcome Dr. Mukudu.
Thank you. Thank you very much. I certainly needed that stretch more than anyone, for my own reasons, rather. But people talk about the graveyard shift and the negatives of it. I just found this quote that says, the only time that's about a graveyard shift, it's the only time working late feels productive because nobody is awake to give you more work. So let's go straight into the presentation. I think the introductions have already been done, they've already been mentioned, but forget about the postgraduate qualifications. I'm a practicing general practitioner for the past 11 years. So this presentation and the startup is purely based on the pain points. And sometimes it feels safe to be in a room full of people whose survival and independence depends on the doctor, so it's quite safe. So I think let's go into this presentation. Firstly, just a quotation. We train doctors to save lives. That's what we were all told when we became medical doctors. But we then expect them, especially in the private, this is the expectation. They need to be entrepreneurs. They need to understand things about accountancy, about compliance, about coding as well, and also technology managers. When? Overnight. That's what we expect them. And I've heard quite a few comments earlier. I could hear the frustrations earlier about doctors need to be taught about coding. Everyone agrees. But you also know these are people that we've tasked to save our lives. So how can we make life easier for them? This is where the technology that I'm going to be talking about. So firstly, this is my lay person's understanding of medical coding. And the experts here will now correct me if what I'm projecting is wrong. Firstly, we translate our care into standard codes, which are acceptable for making a diagnosis, procedures, and the services that we render. You convert the documentation that as a doctor we do. You convert that into reimbursement and payments and also support billing. And so if you look at the channel, how things move, it's care, documentation, cause, claim, and the payment. And I'm happy that I was here from the morning. I could hear the pains that we all have. Where does it go wrong? Our notes are incomplete as medical providers. And surprisingly, the best person that I found who could read a handwriting properly is actually a lawyer. And it was in a medical legal case. He was able to read things that my colleagues had written. So diagnosis and procedures may not clearly match. Supporting records, difficult to retrieve. Patients may not know what the likely cause. And this has brought us into conflict with the patients. We charge a patient, and the medical aids have got intermediaries that work with us, and they send the bill, and the medical aid comes and says there is a co-payment, and that co-payment puts a friction between who? The doctor and the patient. And also, poor documentation, of course, increases query rejection and audit risk. If the font and the color is not clear, that's what I got from the template, so you know who to blame. So this is our platform, what we're talking about. And this is the pain points that personally I can relate to. Number one, if I'm looking for a specialist for this patient, I'm not going to find a specialist now, no matter how urgent it is. There's a channel to follow. Documentation is incomplete. There's a burden. I need to see the patient, but at the same time, I need to do all these tasks. And also, I send a query for a patient, but I'm not able to see exactly how much will be paid for this patient for this particular condition. And we'll talk about the solutions. Don't worry, these are pains, but they're solutions. And also, chronic disease disconnected. We see patients every 6 months. What is happening between the 6 months? Are we able to have some bit of visibility? Patient education and communication. In 15 minutes of a consultation, am I able to tell these patients the 7 medications they are on, exactly what the side effects are, how they need to store the medication and all those things? Even if a pharmacy may do that, but also there's expectation from a doctor to do that. And then when there's a mismatch in consultation, I know with GEMS and also with Discovery to a certain extent, we are graded based on that mismatch. But the mismatch is done by who? There is an intermediary that works with the medical aid that determines that. And so I may score 100%, but when it comes to the payment and consultation, what I charge, I can score 0%. Not because of the practitioner, but because of the intermediaries. So there's also time that is also spent in admin. But when talking about the solution that we're looking at, it is a patient-connected and clinician-branded platform or ecosystem. By clinician-branded, what we mean that each clinician is able to brand it the way they're looking at, because the technology now allows us to. Also, Google Cloud, I heard Anton earlier on mention about these big platforms that are there. Most of them now have data centers in South Africa. I know AWS, I know Google Platform as well. But they've invested quite a lot in technology. They are way ahead of us. We can learn from them, certainly. And also, serverless architecture, for example. If you want to host in South Africa currently, you are given, okay, what are we talking about in terms of data storage? How much do you want? Do you have pictures? Do you have images? And then you'll be charged. And then when you reach that point, you'll be saying, no, we need to extend. You extend. But serverless architecture, what it does is that it's flexible. I can build a solution now for one patient. I can multiply that by 1 million anytime because of the architecture that they have. So our platform was also recognized already by Google Accelerator Program. Last year we were one of the 10 startups, the only medtech company. And also RaiseCorp, and most of you are familiar. We are currently with GAP. Chisel Phase 2, I think Anton also mentioned about Singapore. It's our solution, but it's been recognized in Singapore. We are in the second phase, but that is specifically related to ECG 247. Now, when you look at this solution, I've already mentioned, but I just want to do a few videos. I didn't keep track of the time. Is there somebody checking on the time, please? Yes. All right. Okay, so let's go. I just want to go through, like the patient app. The one thing that we want to mention, some of the data that is missing that you would want to compare as a coder may actually come from the patient. There is no system at the moment that allows the patient to upload enough data. So let's look at what the app can do. So firstly, when you look at it, it's a persistence login, which means it's easier for the patient to actually interact. They just open their app, and then they log in, obviously, in terms of security, multi-factor authentication. Those are the things that are really needed. But the things about tips, it's in chronic management, you want to tip patients. It can be on a weekly basis on what they need to do. This is a little bit faster than I was hoping to. Can you pause a bit? Yeah, sorry, just there. Can we pause there? Can we pause this? All right, so here what it does is showing us is that patients sometimes, they want their prescription to be sent to their nearest pharmacy. So if they have data sharing location, it will actually tell them which one is the nearest clicks or discam, then they can go and collect the medication from there, especially when they are away from home. You can go on. So those are some of the things that are embedded. So this is just the patient-facing app. We'll get to the clinician app shortly. So in terms of some of the information that is needed, all of us would need, sorry, if I don't just pause again, if at all your name is whatever that appears here, it's sheer coincidence. You will just put these are dummy names that are there. So in terms of patient monitoring, chronic disease management, if, for example, you can, within the app, you take a picture. Patients are not allowed to type in their blood pressure, but they just take a picture and the app is able to read. We don't use anything fancy like Bluetooth, but it's just OCR technology that is used there for them to upload their results. And those are the results that are seen. So we can go ahead, sorry. And so it will analyze and it will give them, if something is very high, it will give them initial assessment. They're allowed to book on the platform, they select the time, they select the appointment, they can look at their calendar, and then they can book even for somebody else using the same phone number that they have, because the main link with the app will be the phone number, and they can attach anything. You can look, you can stop here, just pause here. So as I mentioned, the patient can upload anything, including a prescription that they got from another doctor. Because sometimes the patient is in front of you and you ask, what medicines are you taking? They say, no, I don't know, it's a pink tablet. So how many pink tablets do we know? So if you allow them to put in as much information as possible, there is a way of knowing exactly what's happening. Let's go continue with the video. Then of course it talks about your symptoms. They can put one main symptom that's really troubling them, and that allows you to actually have the patient, and they can have a drop-down menu. They can also do narration, like using the voice to also upload some of the things. Now, when you look here, things like collecting information about allergy, if we can stop at this part here as well. This is something that we personally went through. About 45% of the patients that we see at the primary healthcare level, there could be an element of mental issues that are happening, or anxiety or anything like that. We tend to miss that, but this we put in just 3 questions for them to answer. It doesn't go back to the patient, but the provider has some insights about the patients even before they continue. You can continue with the video, please. How many minutes? Okay. Can continue with the, yeah, I think in terms of this video, I think those are the main issues that I just wanted to highlight, but also there could be something that I wanted to highlight in terms of the management of the practice. Maybe let's go to the next video. Okay, so now the next one is even more critical, because now this one is a clinician platform. This app that we talked about is directly linked to what the clinician sees. So this is what the clinician sees. They have a dashboard, whether it's virtual consultation or it's in-person consultation, the platform shows everything. And they are able to select which patients, they see how many are on the queue. I just wanted to pause here quickly. So what we're trying to do here is, from the pain points again, you can't be seeing the patient and making sure there's booking management is done. You make sure your online presence is there, your human resources managed, you are compliant with SARS, financial management, OHSC compliance is there as well, which is something we are learning as GPs now, and then CPD, you are compliant, all those things. So what this platform does, it brings everything within the same space so that the doctor can spend more time on taking care of the patients. Let's continue the video. And so some of the things that we're seeing here in terms of the engagement queue, as I said, these are just these are dummy records. There's 2 records that are real records, and we have consent for that. Can we quickly move to minute number 7? If possible, yes. These are real patients that are there. What we wanted to highlight for this is specifically, is it possible for systems to be interoperable? So just using our portal login into Discovery and into GEMS, we're able to get the information that is needed on a patient that has given us consent to actually access their records. And using that, you are able to get more information about what the patient has. And so some of these things that are there, one patient there is Discovery and one of them is GEMS. I think those 2 have got a strong portal where you can try and get as much information as possible. So something else that we wanted to highlight is the mismatch in terms of the consultation fee. How have we gone? So here, I just want to highlight, it's also interoperable with your WhatsApp. So you can communicate with the patient in the system, but you're communicating with them using WhatsApp. And what are some of the things that we do then? After the consultation, I may not have enough time to teach the patient about essential hypertension. But what can I do? I can send a 2-minute video, a 3-minute video, which later on in the evening at 6 o'clock when they are relaxed, the video comes to them and it tells them not only about that, but also about the medication they are taking. Last final one, I see you standing. So the final one that I wanted to highlight is in terms of the mismatch in what they pay, what is paid. So what the system does, it goes and gets a virtual consultation from Discovery first, and it will tell and say there's an error in this before we actually submit the final report. So that is less likely to create errors. So that's my time. Thank you very much.
Dr. Mukuru just left me. Our final speaker for this innovation session is Dion Burrs. As a qualified healthcare professional, Dion has evolved over the years from a rehabilitation clinician and practice owner to a provider of services and support for healthcare professionals and institutions. Within the SpaceNet group, this has expanded into the development and provision of software solutions across the healthcare landscape. Thank you, Dion. We look forward to your talk.
All right, thank you very much for the introduction. And yeah, it's just such a privilege to share the stage with such great speakers, to everyone who's gone before me. I think what's really exciting for me is that I think healthcare is in good hands. Everyone who stood up here and said, this is what I'm doing to shoulder my responsibility to do something about improving and moving us forward. So I think the title, Innovate to Elevate, is just so apt. I'm on a mic because apparently I've been told at the back by Nash that I'm a walker. They call me a walker. There's a name for this. And it's the graveyard shift, so maybe I'm a white walker and this is a zombie apocalypse, right? But what I wanted to do today is take you on a journey. We've decided to embrace artificial intelligence to see how we can advance some of the software solutions that we've put together. And one specifically that I want to talk about is around coding. So I'm going to take you on that journey and share some of the things that worked for us, some of the things that didn't work for us, and some lessons that we learned along the way. But I think we can all agree that, listening to coding, Zandile, my colleague, as you were going through that, I'm listening to this going, man, this is complex stuff. And trying to assimilate all of that and move that forward so that everybody's on the same page is a mammoth task. So I think the challenge is one of huge amounts of data and understanding. And how do we simplify that? What tools can we actually use to make our lives a little bit easier? And that's what we're aspiring to do. So disclaimer, I've been watching everybody's slides. I'm an AI enthusiast. And I've been watching the slides trying to figure out, okay, who's used AI to create their PowerPoint presentations? I'll admit I did as well. And the reason I do that is to try and understand, like, how far is AI really advancing in some of the real tools that we can use in day-to-day work. And I think we're getting there. Unfortunately, it's not Microsoft, strangely enough. That's managing how to put a PowerPoint together. But certainly the latest fun one is Claude Code, and I found a lot of value in that. But that's this week. Next week it might be different. When I do talks on AI, I always have the first slide blank, so apologies for not using the template. But I put this one up because there's some questions and advances that actually happened this morning and yesterday and last week. So you can't prepare your slides and put them up and have them ready a week beforehand because things are moving so quickly. But I wanted to share just some questions that I think certainly keep me awake at night. And maybe some of you can attest to this. But maybe just asking the audience generally, how do you guys generally feel about artificial intelligence? Who's like super excited about it? Yeah, about 50%. Who's super scared about it? And you can put your hand up for both, right? Because I certainly flick-flack on that, is where do we sit? But what's really interesting, I wanted to see what is the adoption of AI, because we often have these conversations amongst, it's almost a pool of people that are already convinced and are interested in technology, right? And so we start thinking, but that's what the general population looks like. But it's quite interesting to see 85% of the South African population has never used AI. And I want to add on there intentionally. I think some people are using it and they don't know it's there. It might be operating in the background on your WhatsApp, for example. But I've never used it intentionally, and that's the general population. If we reduce it to working adults, then the adoption rate in working population is about 23%, which is ahead of the global average of 17.8%. So we're doing quite well. The adoption is actually quite quick. And we'll talk in a minute about what does the adoption look like in the healthcare space. And again, adoption is heavily concentrated in urban, English-speaking, higher LSM segments. And that's a Microsoft report from earlier this year. Questions I ask myself is, what about patients using AI? I think for many years, and Dr. Lee spoke about it as well, you use Dr. Google, right? And the patient comes to you and you just know they've researched this and they've got some idea, but they've got the dog by the tail. This is not really the full picture, right? So how do we shape that? But patients starting to use AI, I think, is a whole different idea. It's taking Google and putting that on steroids. And if you look at some of the work that's coming out from Google as well as OpenAI, they have health AI coming up soon. Some of it has been released in the US. I'm on the waiting list. I can't wait to see it. But what's interesting is what they say is, what is the actual use case? What are they solving for? There's two things that are going to, I think, change the way clinicians are engaging with patients. The one is, it's to empower the patient to understand their results. So you're going to get your blood results, you're going to get X-ray report, put that in and say, well, what does this actually mean for me as a patient? Okay, so your patient's really going to come with an idea. And the second one, which I thought was really interesting, is they specifically state that it's to prepare the patient before they go and see their doctor. So the landscape could change quite dramatically in those 23% patients that we may be seeing. This is an interesting one. It's a debate that's been had with AI thought leaders, Peter Diamandis being one of them. And the question is, when will it become medical malpractice to diagnose a patient without using AI? It's an interesting thought, eh? And there's some research. It only came out 2 weeks ago, and it's actually pre-publication. But there's research that was done at Chris Hani Baragwanath Hospital to actually look locally at what is the success rates of diagnosis next to the patient's bed in the ward diagnosis, hospital ward diagnosis, versus what AI can do, and how much better it is than the diagnosis happening at bedside. So interesting article, is worth reading. I'm happy to share the reference there. What about when we can't tell the difference between AI and a human? And this will speak a bit about online consultations, virtual consultations. In psychology, I think, is an example. And there's been some advances, and I look forward to hearing from our American colleagues about what AMA is doing and their position on online consultations and impersonating a doctor as such. So they've done some really good work in that space. What happens when AI escapes the server room? So right now you can turn your phone off, you can close your computer, and AI is no longer around, right? What happens when it escapes the server room? And we're looking at humanoid robots, we're looking at activities happening, and we think it's far away. Would you let a robot operate on you? Many people will knee-jerk say no. How many of you have gone for LASIK surgery? I don't think that laser is held by a doctor's hand, right? It's been operated using laser, using robotic assistance. When quantum computing kicks in, what is that going to look like? I think it's going to change the landscape dramatically. When we move from generative AI to artificial general intelligence, and AI becomes self-aware, some argue that it is already. And where can AI be really valuable in the healthcare space today? I think this is what I conclude with. With all that noise that we've gone through now, the question is, how do you filter out the hype from the help? How do we see, like, what can AI really do to help us on the ground, especially in healthcare? Prof. Chetty said in the opening this morning, the question about how can we add value to the healthcare system? And that's really the story about Project Lumina that we engaged on, to see how we can enhance the value that we're adding into the healthcare space. So just as a bit of background, in the SpaceNet group, we created the Health Code Index that was created back in 2002. So going on to 24, 25 years that we've utilized the Health Code Index. And we recognized at that point that there's complexity within the South African healthcare landscape with multiple coding systems and structures. From RPL, I'm going to use the word RPL because outside of the doctor space, I think the physios and the OTs and the biokineticists are all referring to this as RPL, but we know what we mean. We're talking about ICD-10 and ICD-11 in the future. We're talking about CPT-4, NAPI codes. And so what we started doing back then is put them all into a database and start getting cross-links between that and making sense of it. Like, what is the cross-map then between this CPT-4 and ICD-10? What's the relevant RPL and vice versa? How do we do the lookups? How do we understand the coding sets and make sense of it? And I guess that's early stages of bringing in intelligence, maybe not machine learning, but human learning intelligence that we codified. And we were able to present that as a lookup and a tool that coders are using. That has expanded really well. We've got close to 150 hospitals in the country using Health Code Index and thousands of healthcare professionals integrated into systems and standalone. But when we looked at it, we thought that there's really an opportunity to take this and put it on AI. Some of the challenges that we were facing that we wanted to do as part of our roadmap all along. Number one, colloquial terms or alternative terms. If you've got a basic lookup system and a database, if you just misspell it, it's not going to find it. If you use the word quadriplegia instead of tetraplegia, it's not going to find it. If you say the patient fell off a bucky, it's not going to understand it, right? But we understand what we mean by that. And so what we always had is the project about colloquial terms, layman's terms, and how do we enhance the data set to add that, which is a massive task. And when do you ever stop, right? Everyone's got a different way of speaking. When we saw AI coming in, that was obviously one of the first things that we could do is actually use natural language processing and use AI power to actually translate that in. The second thing that we've always wanted to do is translate Health Code Index into another language, Afrikaans, isiZulu. And again, a massive task, but AI has allowed us to do that. So we were quite excited about what the prospects were. We started this project about a year ago and have just launched it into a pilot phase. We've actually released it now to close to 5,000 healthcare practitioners, and we'll share some of the findings. So just a couple of things just about the lay of the land. AI is doubling every 6 months, which makes it very difficult to regulate. By the time regulation comes out, it's doubled and you're chasing a moving target. So that's the challenges we sit with. We've seen some of the regulatory attempts in South Africa, which have been pretty disastrous. AI sabotaged the AI document by giving wrong references and had people fired. So I'm not sure who's assisting who anymore. The investment, I actually just until yesterday still had $1 billion per day being invested in AI around the world. And I re-looked at it, it's now $3 billion a day, per day. People are saying there's a bubble coming. We'll have to see what happens, but the pricing model certainly has to change. And then this is interesting that while healthcare was slow to start the race in AI, it was more in the fintech space that adopted it. Now that healthcare is on board and really chasing what can be done in AI, we're running at 2.2 times faster than other industries. So we're moving really quickly. I don't think there's anybody here who doesn't now have part of their vocabulary the ambient listening conversation. And it's just a real example about how AI can move from hype to help and really make a difference in reducing administrative burden for healthcare professionals. And if we look at 50 years ago, there were essentially 7 data points that a doctor would look at, blood pressure, pulse, skin cold and clammy, a couple of others. I don't want to oversimplify it, but it was very few data points. We're now sitting with, I've got a watch and I've got an Oura ring, thanks to Discovery Health, and I'm wearing these and it's monitoring everything, and the data points are just by the 1,000. There's about 1,300 data points. How do we make sense of that data, and how do we use that in a predictive manner to benefit the patients? So massive growth. The acceleration we're looking at now, that what took 100 years technology to advance is taking 10 years. Now, to put that in perspective, the motor car was just invented a couple of years before, 100 years ago. And look at what the motor car looks like today. Autonomous, self-driving, battery-operated. What is it going to look like in 10 years' time from now? So that acceleration curve is massive. Just some regulatory frameworks. Firstly, the American Medical Association is referenced a lot in both SAMA and in the HPCSA policies and positions. I quite like this. I wanted to steal this. Is that AI in healthcare is augmented intelligence, not artificial intelligence. So how do we adopt and embrace this technology to augment our intelligence and assist us in what we're doing, not to replace us? The HPCSA booklet, this was interesting. They published the draft in September 2024, and then the final document in 2025. So that just shows you that from draft open for public comment to final document took a year. AI doubled twice in that time. So the regulation is really a challenge. But a couple of key points. You remain ultimately responsible as a healthcare provider for the AI that you use and the advice and the recommendations that you give off the back of that. It's important that you inform the patients and get their consent that you're using AI. Wherever you can, de-identify, anonymize the data before putting it into an AI model. And of course, do not put it into free models. The models are, if anything's for free, my colleague always says, if something's for free, then you are the product. So the data is the product, and that information is going in to train the model. Even if you pay, you used to be able to say, well, if you're paying your $20 a month, then your AI is your data safe. That's no longer the case. There are a few models that you actually have to go in and change the default settings to not use their information to train the model. So be careful of that. All right, so there's a couple of things there. I want to just accelerate. We've got a short time. But what we're really wanting to do when it comes to embarking on the Lumina project was the pains that we're trying to solve is the admin burden, coding complexity we've spoken about, scheme friction, and revenue drain. All of these, when you get a wrong claim sent through with the wrong codes, we all know what that rework looks like. It's a hell of a process, and you often increase your bad debt ratio by doing that. There are different coding systems, and what we've done traditionally in Health Code Index. So just to introduce Lumina. So we took our Health Code Index, and some of the key things to consider always, the two key principles when it comes to AI is, number one, what is your foundational knowledge base? Thank you. What is your foundational knowledge base? What are you grounding your AI system in? If you're not grounding it, it's open to the publicly available information, the web, the World Wide Web, and then people say, but it's hallucinating. But it's got so much data to reference, it makes it very difficult. So we've anchored Lumina in our Health Code Index, which is only South African code sets for South Africa, cross-mapped, and the intelligence brought in by our clinical team, who sit there and painstakingly over the 24 years have constantly kept that up to date and managed that code set and what's appropriate and how they cross-map and so on. So that's the one thing that's so important, is how do you ground your AI? The second one is, what are the guardrails you put on? And when you say you can do this and you can't do that. And so we've been very specific about that, as well as where we store data and information and the local systems that we use, and ring-fencing that data off. So the best interaction method is speech. But then again, we don't always sit and talk to our phones, do we? We often sit typing. So we started off with typing, but we'll open up speech, and we'll be bringing that in as part of ambient listening, so that you can actually record your session, and after your session for your clinical notes, you'd simply be able to say, well, what are the clinical codes that are related to this, both RPL, ICD-10, and so on. So the system comes back, it suggests and validates what you've been saying, gives you PMB flags, drafts codes for you, validates, you however decide, and it never auto submits. Our clinical team is there to assist. So through your process, and I think there's a concept of human in the loop, which we've all heard about. I certainly see that our clinical team are the humans in the loop. So as you're going through your query and AI is helping you with your coding, you might have dropped in a clinical report or some notes that you have, or you might be typing that on the fly and saying, give me the following codes or cross maps. As you're doing that, if you run out of talent and you're like not quite sure and it's not really what you're looking for, you simply hit a button, escalates to the human in the loop, which is our clinical team, and they pick up on the call and assist you. And I think that is vitally important, is that we keep the human in the loop on this one and don't just blindly trust AI systems or Googling. But there's another concept which is human in the lead. And I see us as clinicians, administrators, case managers, coders, as being the human in the lead. You're leading that process. You've got a tool that assists you. You go through using that tool. If you see that the tool is not quite giving you the answer you need, you can escalate it, and we can even set it up in an organization that the escalation goes to your head clinical coding team within a hospital group, for example, and they can then escalate to our clinical team if needs be. So a very helpful way of presenting it. Just the last few, I've got 2 minutes left. I'll just give you an idea on if we had more time, I'd do an actual demo, but I'm just going to show you some screenshots. If anyone's interested to see this, we're more than welcome to set up some time with you and run you through it. But many of you may be familiar with Health Code Index. That's the old system there. With the search, and even here, if you put in your code and you didn't change from code to description, then it goes, it doesn't exist because you're still on code, not description. And so this just opens it up. You just have your conversation. You just say paraplegia. It knows what you're looking for and it'll give you the answer. So that's the old. You just see that what we've done here, just to overcome some of the technical barriers of entry, is very often people are saying, well, have you got APIs? Can you integrate with our systems? Now, sure, we can do that. But that is quite a process. You're normally talking about 6-month process, not from our side, but the technology team on the other side needs to put it as part of their development plans. So what we've done is introduce a widget that just quietly sits in the bottom. You click that widget. The widget opens up and you carry on your screen as you normally would, your hospital system, your practice management system, whatever it might be. It opens up on the side, you have your conversation and you run through and Lumen assists you with your coding. Very simple way of introducing that. It's 2 lines of code that we then introduce and we can do it in a day. It's really as simple as that. This just gives you an example of some of the multi-language. Yes, we want to go through to all, do we say 12, 13 official languages? I'm not sure sign language is in yet, but it's probably not far. Not impossible to do with a camera, I'm sure. But I've started with Afrikaans because I can QA that. I understand the language. Zandile has done some work in isiZulu and will continue to work that. But this does depend on the language models and what they're able to do. We are exploring some local partners who are building local language model systems to actually manage our different dialects and languages in South Africa. But there you can see we've just gone to Afrikaans. I told it to switch to Afrikaans, that questions and answers in Afrikaans even gives me my ICD-10 codes back in Afrikaans. So very helpful there. And then this is just an example of how we escalate to the clinical team. As you're going through, you then escalate. There's a query, that's a cancel query, but you'll then be able to escalate to a human in the loop, and they'll be able to assist you through the remaining part of the process. So I just want to conclude on this, is what worked and what didn't work. Firstly, we had the context, we had the grounding, and we had the guardrails in place. What didn't work is keeping it open and using large language models openly, because it does open it up to hallucinations. And we also thought that we could create one single instruction prompt. For those of you working with AI and technology, you have a prompt that explains what the AI agent is supposed to do, what it can and can't do, what its purpose is, and so on. That doesn't work. We've broken that up into different MCPs, which are connectors to other skills and tools, and that's worked very successfully for us. Where we are now, we're wanting to move from a coding system assistant to a funding assistant. So what we'll be doing going forwards, just on the last one coming soon, is including a funders file, which we already have in an analog format. It's digital, but it's not on AI. We have a provider index and payment arrangements. And imagine bringing all of that into your coding system, where you can actually just ask your AI assistant, Dion Beers is coming in, he's a discovery member, he has his number, card holder check, is he valid? Yes, he is. Coming in for the following procedure, this is the hospital, these are the doctors, well, they're on network, they're not on network, this is co-pays, this is the funding that's available, and so on. So you can imagine the strength of that as we continue to advance forwards. So yeah, I think AI-empowered, human-inspired is really what we're about, and we're there to amplify, scale, and empower the clinical team that is there. We're so short on coders, we want to give them the tools that they can have where the majority of queries might be answered, but the tough ones come through to them. We don't want to be sending everything through to the clinical coding team who are experts in what they do, but should be handling the tougher questions. So there's a website if you want to have a look, healthcodeindex.co.za, and you're welcome to reach out to us. Thank you for your attention.
So in my community service years, I once had a female patient genuinely ask me to examine her prostate because she was struggling to urinate. So let's hope the AI is slightly more accurate than Dr. Google. My favorite part of being the program director is standing in the mirror in the morning going, Ngugu doselo, Ngugu doselo. It gives me great pleasure to introduce Dan Schweibach. Dan, did I manage? Dan is a senior healthcare executive with 25 years of experience in revenue cycle management and operations. He holds a master's degree in hospital administration from the University of Washington. Dan began his career at PricewaterhouseCoopers, leading RCM transformation initiatives for major health systems. He joined AAPC in 2010, establishing their professional services division, and now serves as Senior Vice President, leading AAPC's international business expansion and strategic partnerships. Welcome, Dan.
Well, thank you for having me. It's an honor and a privilege to be able to be here. This is my first time to South Africa, beautiful country. So just want to thank Sama for inviting me to be here and to be able to speak with you guys today. For those that aren't familiar with APC, just to give you a little bit of background, so we're an association that's based in the United States. We're in Salt Lake City. We were established back in 1988, so I think we're kind of a little baby or infant compared to some. I think you guys have been in existence for much longer. But we have about 300,000 members in 50 countries. So my role within AAPC, I get the opportunity to travel the globe, and I meet with regulators, with health ministries and medical coding professionals all around the world, helping support their initiatives. So I was asked today to give some perspective just on kind of the global coding community and what's happening. Sometimes we tend to operate within our little bubbles, so it's good to see what else is going on out there around the world. So there's a lot of things we could talk about, but there's only about 20 minutes, so I had to try to narrow that down a little bit. I want to focus on basically three kind of macro trends that I'm seeing in the marketplace, and we'll get into a little more details about each of these. But the first one is that in a number of markets, there's this shift towards insurance-based financing. Governments are trying to move healthcare costs off of public budgets, trying to mandate and bring models of insurance into their markets, doing private and public partnerships for funding infrastructure and things like social health insurance programs. Second macro trend is this shift to alternative and value-based payment models and trying to move away from fee-for-service. And then the third kind of macro trend here I'll talk about is this acceleration of digital infrastructure and digitizing healthcare services. Just to talk for a minute about the insurance-based healthcare reform. So right now there's about 40 countries that are focused on building or expanding insurance-based financing. So I've kind of lumped these into three buckets. Sorry, got a dry throat here. The first is really, there's about 16 countries working on putting insurance schemes in place. They're focused on kind of more the legislative side of that and getting that in place. And then the second bucket are countries that are actively, they have schemes that are live now, they're growing enrollment, and they're focused on kind of building out the infrastructure to support insurance schemes. And then you have other countries that are, already have schemes in place. They're established and they're moving to making that compulsory or dramatically expanding in those markets and capabilities. Just to give you an example of a few of countries and what's kind of going on. So you have Indonesia, for example. They're one of the largest national health insurance programs. They have rolled that out to 270 million people, and they're in the process right now of trying to move those 270 million records from paper into a digital format. You also have the GCC region, which is the most active area really right now introducing insurance reforms. So UAE, for example, just implemented mandatory insurance for all private sector workers across all of their 7 emirates. They did that last year. You also have the 5 northern emirates, which just rolled out the Riyadi platform, which enables them to do claims adjudication and electronic payments. You also have Qatar, for example, which just adopted the use of the AMA CPT classification, and they're in the process now of expanding insurance offerings into their marketplace. You have Saudi Arabia, which has their 2030 initiative, and they've been focused on privatizing their hospitals and shifting all public employees to private insurance schemes. Just to kind of talk about alternative payments for a minute. So every healthcare system right now is basically focused on doing that, whether it's advanced countries or nascent marketplaces. Everyone's engaged in payment reform, and they're all basically moving in the same direction, which is really how do you get away from fee-for-service and move to more quality-based outcomes. So again, I kind of lump these into 3 buckets. You have these markets that are introducing or want to move to more DRG payments, so they're moving away from fee-for-service and trying to put things in place that allow them to incorporate DRGs and those kind of payment models. You have these, what I call kind of the mid-layer value markets, where these are countries that are utilizing DRG, and now they're trying to incorporate more layers like pay for performance or quality reporting programs. And then you have some of the more advanced countries that are actually moving away from DRG as kind of a predominant payment model, and they're moving to more population health-based models, such as full capitation or shared savings or global budgeting type programs. Again, just to give you a couple examples of countries. So Vietnam, for example, they're early stage in working on standardizing their coding and improving their claims infrastructure so that they can support DRGs, and they're looking to roll out DRG schemes by 2030. You have China, which has been working on DRG-like models. Theirs is called DIP. It's Diagnosis Intervention Packets. That's similar to DRGs, except they also incorporate diagnosis and procedure codes into that, and then they assign point values. But they've been piloting this program for a number of years, and they're right now in the process of doing large-scale rollout across their country. And then you have Denmark as another example of a more mature market, where they're moving away from DRG to global budgeting and quality incentives for population health outcomes. And you have the United States, for example, which is dabbling in all kinds of models. So they experiment with things like the accountable care organizations or risk adjustment programs. And then just to highlight again the global digitization, I won't spend a lot of time on this because there's been quite a bit of discussion there, but this is the most common theme across all countries. You have 130 plus countries focused on this right now, and they're all in various stages, whether it's just rolling out national health IDs or implementing electronic medical records, all the way to incorporating digital claims processing, telemedicine, to more advanced AI diagnostics and things, interoperability. But again, I think everything going on with AI, there is an urgency for most countries. When I talk and meet with them, everyone is trying to move quickly to digitizing their healthcare systems and advancing their progress there. So we've got these macro trends going on, but I want to highlight how does this affect medical coding and the coding community, and what's the impact there. A few key points to make here. First off, coding's no longer a back office function just to get paid. It's what I refer to as the most strategic, invisible discipline. I call it invisible because medical coders, I think, are, they don't get the credit that they deserve or the appreciation for the critical nature of their role and what it plays in healthcare. Coding is really the foundational layer that's the common language that allows information to be shared across healthcare systems, whether that's for billing, research, quality, population health. Also, as payment reforms become more sophisticated, it requires more precise, more specific, and more clinically meaningful coding. So this complexity is becoming more and more difficult for medical coders to manage. Also, the pressure for better data. So what that really means is the quality of clinical documentation. It's becoming a true bottleneck. Data is becoming a much more critical component of the healthcare ecosystem, especially as AI comes into play here. And CDI, clinical documentation improvement, is the buzzword that I hear in basically every country I go meet with. That's a key focus. And then as the market continues to shift to insurance-based payment models, there's growing scrutiny on claims accuracy, and there's certainly a lot of pressure on coders to be defensible in everything that they do. So the result of some of these dynamics, there's a number of impacts that we're seeing are affecting the global medical coding community. And the first one, Solventum alluded to this a little bit earlier in their presentation, but the global demand for medical coders is far outpacing the supply. Again, as you have these insurance reforms, payment reforms, digitization, if healthcare, as those gain greater adoption and maturity in different markets, it's increasing utilization and the reliance on medical coding. Just to give you an example of the impact there and what that looks like. So these are some of the markets. You can see kind of the supply and demand shortage here. So Saudi Arabia, a little over 1,000 coders. They need about 18,000 to support the market. Qatar and Oman, again, several hundred coders right now, but they'll need several thousand. Even your more mature markets like Australia, Canada, United Kingdom, Germany, significant shortages in the medical coders to support that market. The U.S., frankly, is in an existential crisis as far as I'm concerned. We have about a shortage of 100,000 coders. One of the problems we face in the U.S. market is about 60% of medical coders are all coming up on retirement age in the next couple of years. So we've got a number of people coming out of the market, and we're having trouble replacing them. So, there's a lot of talk about AI and the efficiencies. We need that to come into play because right now we can't service the needs of the markets in many countries. What I did here is I took AAPC's global membership, and this is over about the last 15 years. Again, as I mentioned, AAPC has about 300,000 coders, members in 50 countries. I broke out the domestic versus the international so you can kind of see the difference in growth patterns. The U.S. is a mature market, so we've had about 4% compounded annual growth over the last 15 years, which is actually very good, but it's a stark contrast to the international markets, which have had a sharp increase in the last 5, 6, 7 years at a 35% annual compounded growth rate. So if you average that out, that's about 14%. So we're seeing growth accelerate, particularly across the international markets, and particularly as coding ecosystems start to mature. And again, keep in mind, this is just the AAPC membership, so it's just a small segment of the coding workforce. But what I think is important to note is the trajectory and the pace in which we're seeing the growth start to occur. If we try to look at kind of the global supply, it's a little challenging to do because there's not like a set database where everybody exists there, so it's hard to pull numbers. But as we look at that, our estimates are there's about 700,000 medical coders globally. Again, as these coding ecosystems mature, the need for coders is accelerating, and what we're seeing suggests that we're already in the early stages of a multi-decade expansion globally. So if you look at the implied growth about, again, historically 14%. That means that the industry will scale to need about 2.5 million coders in the next 10 years and about 5 million coders in the next 15 years. So we already have a supply shortage, and that's going to become even more acute in coming years. Now that brings me to my second point here, which is to highlight that training for medical coding is not really meeting the workforce demands. We have a supply problem. I think that's certainly addressable, but I see some very common patterns in a lot of countries that really inhibit and become barriers to scaling their coding workforce. Just to highlight a few of those. So first off, one of the key issues we see is what I refer to as excess regulatory control. So there's a tendency for regulators to want to control and dictate the training and what training requirements are and what the curriculum should look like. And I certainly appreciate and understand that. We want to make sure we have good training that covers the skill sets and the requirements. I'll pick on Saudi Arabia for a minute, though. They have what's called the Saudi Commission for Medical Specialties. That's the organization responsible for that, determining the curriculum requirements and training, testing, certification. But you also have other entities in the market that also require review and endorsement of the training materials. Part of the issue is this process takes 6, 12, 18 months to get endorsements and to go through that process. So it's severely crippling the involvement, particularly of the private sector, in getting the workforce trained in a timely fashion. Also, we see that there's tend to be overly academic in the requirements. So again, regulators, oftentimes they try to make these programs university in nature or extensive prerequisites. I think Canada is a good example of this. They have a very difficult time getting coders into the profession because it's a very long process for education and training. Oman's in a similar situation. You have to graduate with a health sciences degree, and then in addition to that, you go on for further training for medical coding. I'll admit APC is very biased here, that we believe training should be vocational and focused. It should really look to just target specifically what are the skill sets needed, and we believe that you can train within 4 to 6 months to do things rather than drag that out. I don't see why medical coders have to have statistics classes for medical coding, so let's strip out irrelevant things and speed up the training so that they can get the specific targeted skills that they need for their jobs. Many emerging markets also simply don't have enough experienced coders to do what's needed. So, and then another point, probably the most critical, is that everyone underestimates the importance of training. They tend to implement things first and train later, and that's a real problem that they need to address. So if we don't address some of these issues, we're going to struggle to develop the workforce that's needed. And then just the last thing here I want to highlight is the impact of the growing surge on payment scrutiny. So this chart here basically shows the claim denial rates by region in the global markets. Most countries for the last several years were around 3 or 4% of claim denials. That has spiked in the last few years. For example, the US and the European markets are now at 8 or 12% of all claims denied. Asia's had a 200% increase in the last couple of years. They're now gone from 3% to 9%. And then globally, it's on average about 10% now, up from 4%. So key question really is what's driving that and what's the impact there? 2 more minutes. There's several things really kind of driving that at this point. First off, again, the digitization of information, so both providers and payers have greater access to clinical information that can be scrutinized now. You also have evolving more complex payment schemes, which requires higher precision of medical coding. Coding errors, as we know, are the primary trigger for denial reviews. AI is definitely the largest component here, though. That's increasing the ability and sophistication for payers to review and flag errors. It's also bringing down the cost to make it much easier to conduct larger volume of reviews. The implication here, particularly on the provider side, is that they're not prepared for this. This is U.S. information, but the average denial claims dollar values is increasing. Hospitals don't have the staff necessary to manage claim denials. 1 in 4 indicate they don't have the coding staff for it. And hospitals in the U.S. in particular, 10 to 15% of their revenue is lost to denials. In emerging markets, that's even more acute. Sometimes it's upwards of 30%. So again, this is in a mature market. With the 40-plus markets that are undergoing extensive insurance reforms right now, they have very little experience here in managing denials and denial process, and many of those hospitals are struggling severely. Just to make a final point here, so there's certainly, from a coding perspective, what does all this kind of mean for you as medical coders? First off, healthcare is undergoing continuing transformation. There's a lot of things happening, and medical coding in particular is no longer just about assigning codes. It's really rather you're becoming the critical infrastructure for healthcare. This picture here, I don't know if anybody's seen this. This is actually kind of a famous picture, but this is Sweden back in 1967. This is the first day in which they decided to switch driving from the left side of the road to the right side. I don't know what prompted them to make that switch, but you can see it's just kind of utter chaos there. I love this picture because that reminds me of what the healthcare system would be if we didn't have medical coding. It would be utter chaos. So it's important to know that medical coders, they bring order to what otherwise would be chaos. And just the last slide here, I think this quote's important, but the success of healthcare reform increasingly depends on the strength of the coding workforce behind it. Your role is many. It's your clinical interpreters. You're not just assigning codes. You're translating clinical reality into usable data. You're the financial gatekeepers. Your coding accuracy is dependent on you as medical coders, which increasingly drives reimbursement and the risk for organizations. And you also manage the quality and outcomes with your coding because that impacts quality metrics, population health, and eventually national policy. We know that medical coding is a very complex profession. The industry will continue to evolve, and we know that medical coders will evolve with it. I applaud you as medical coders for the effort you put in and your contribution to the medical coding community. I encourage you to keep moving forward, to keep sharpening your skills, and we're very grateful for the roles that you play in healthcare. So thank you for your time today. Appreciate it.
Our second to last speaker in this session is Leslie Prelwitz. She is the Director of CPT Content Management and Development at the AMA, with over 30 years of experience in coding analytics, healthcare management, and consulting. Her work focuses on CPT content development, coding guidance, and the proper application of CPT codes across the healthcare industry. Thank you, Leslie.
Thank you, and hello everyone. It's so great to be here with you virtually today. I'm going to share my screen, and let's see, it will allow me to share. Fantastic. All right. Okay, so I'm going to be talking with you today from the AMA, and first I wanted to acknowledge the great work that was done by the morning CPT session. I think there were 3 SAMA coders in a fireside chat format, very informative. Hopefully I may have the opportunity to participate in person in one of those in the future. It's always great to be back here. Today we're going to talk a little bit about bridging the gap between AI, clinical transformation, and clinical practice as it's seen from the AMA perspective. We have a few slides to go over, and I realize we'll make sure that we keep you on time for your conference. So let's just kind of get right into it. So our first area, I'm going to give you a couple of highlights from the 2026 AMA Physician Survey. And this really is something that we've done for a couple of years now to provide some feedback about how you as physicians are seeing and feeling about AI in clinical practice. With many of us, we use it in our personal lives, but clinical practice is a little bit different. Now, the survey that we're going to talk about, our results are from mid-January through early February of this year. When our physicians were surveyed, we had about 1,692 physicians who were surveyed in that time period. And the survey is designed such that we're able to have certain questions from previous surveys, 2023 and 2024, replicated across surveys to allow for some trend analysis. The difference between the trends that we talk about today is about 15 months, and that's important to understand how physician use, sentiment, and concerns are all shifting over time. The first finding that we're finding is that in terms of physician AI adoption, physician AI adoption is really now going mainstream. So when we take a look at our current survey results, over 80% of physicians reported using AI in a professional context. That's a significant jump up from 2023, the first survey, where it was only about half that percentage. So it's really come up quite a bit. And in addition to breadth of use, the number of use cases has also gone up. So physicians are reporting more AI use cases, on average about 2.3 use cases per physician now in 26. In 2023, it's up from only 1.1 from 2023. So we're getting broader use and more in-depth use. So physicians are starting to layer AI into more workflows than they have previously. And all that is pointing to the fact that the uncertainty really is starting to shrink around AI as it becomes more visible in practice. Now, it's not an entirely smooth road, but that's good positive news, moving in the right direction. The other thing that's more interesting is that now, in terms of use cases of AI, there's been a lot of talk about AI sort of working in the background, where people were aware that it was there. And now the tide is changing, and that physicians are shifting from guessing about how to use AI or what it used for, to naming concrete AI use cases. So they're becoming more prominent now. The number of physicians or percentage of physicians who were uncertain about which AI use cases were in their practice declined pretty significantly. In 2024, that percentage was 18%. They figured it was there, but weren't quite sure how. That is now down to 9% in 2026. So the presence of AI, and specifically, is much more pronounced now. In terms of use cases and what they're being used for, knowledge synthesis, so the work on research and guideline summaries, doing medical research has really taken off. In the past 15 months, that has tripled from 13% of physicians using that in 2024 now to 39%. That's a threefold increase, and far and away the most that really leads physician AI usage. Other usage on the right-hand side, we also asked physicians, where do they expect AI to be used by the end of this calendar year? As you can see, research and guideline summaries certainly do lead the list. They're already there, and they expect more of them expected to be expanded, as well as some of the areas you might expect: discharge instructions, care plans, progress notes, chart summaries. Both of those are very, very close. At least 2/3 of physicians expect those, and only a slightly lower percentage will expect AI to be more incorporated when it comes to documentation of billing codes and visit notes. So in terms of the near-term growth clusters, these are really the areas that physicians would be expecting to see AI more in use. And there's a pretty good level of enthusiasm around what's coming down the pipe, we believe. Now, while the trends are definitely positive, it also helps to remember that there's optimism, but it's a cautious optimism, because we also asked where they expected to see it, but how do they feel about AI? What is their sentiment about it? Now, the sentiment is trending positive. 76% of physicians now say that AI gives them an advantage in patient care, and that's up from 65% in 2023, so moving upwards. In terms of those who are more excited than concerned, about 37% are more excited than concerned. About 40% remain equally excited and concerned. So a little bit of guarded optimism, but optimism nonetheless. On the right-hand side, we talk about where physicians expect AI most to help them or harm when it comes to clinical practice. And the real three areas that are seen as upsides are in terms of efficiency, diagnostic ability. That's with a little bit of an asterisk, because we talked about a diagnostic ability, but not necessarily the AI diagnosing all on its own. It's a little bit of a difference there. And then obviously help to reduce cognitive overload and burnout. Administrative burden, the one thing no one has more of is time, and so that's still an area where physicians are definitely seeing the benefits from AI. Now, in terms of the patient-physician relationship, it is seen as a net positive, even for the area of, say, an ambient scribe who can help to capture some of that conversation so that the physician can focus on looking and working with the patient rather than a screen, is helpful, but it's probably had the lowest rated benefits there. The one area with a net negative expectation and concern comes in patient privacy, in terms of the ability of that information to be appropriately protected. I think there's quite a bit of caution around that now. So, but things are moving in the right direction, but there's a healthy dose of skepticism, which we would certainly expect. Nothing is an absolute and immediate adoption, and that's quite reasonable. A big part of that is trust. Obviously, any physician or anyone, if you're using a particular tool, it's very difficult for you to really embrace and adopt it if you don't have the trust in there. Now, there is a little bit of a trust gap, and a lot of it comes to how the AI is actually rolled out in an organization. Is it coming from an external vendor who may be looking more to promote a particular product versus a process where it's really been thought through and worked within the institution? So institutional AI, when it's rolled out on an institutional basis with that sort of buy-in, acceptance, and the vetting, helps to reduce privacy concerns. The percentage of physicians who were somewhat or very concerned about privacy, for institutional tools, you can see it's around 41%. For non-institutional tools that are coming in sort of off the shelf, you don't really know much about them, that concern goes up by a pretty hefty amount, about a 29-point gap, so it's pretty significant. Now, this year we also asked physicians about concerns with skill loss with all of the AI. It can certainly help in terms of a lot of work, but you want to make sure that certain skills aren't dulled by the use of too much technology. And 70% of our respondent physicians did have some concern about skill loss with AI use, particularly for students and residents, those who are just entering the profession. They were a little less concerned about skill loss for themselves. Only 28% there were concerned. But that is something, as AI rolls out, to make sure that I think that points more to make sure you've got a good, solid, appropriate use rather than completely replacing a physician. That did vary based on various characteristics of our physician groups. So early career physicians showed a higher concern for this or skill set loss than later career physicians. And in terms of specialties, primary care physicians had higher concern about skill loss than many of the specialists. So there is some variability in perceptions about skill loss, but it is there and something to be considered going forward. In terms, which is actually helpful when we asked what do physicians want next in terms of AI? What are they looking for? One of the top areas is certainly around liability clarity. I think there's been discussion in previous presentations. Is there, what's the accountability framework? And among regulatory actions to help increase the adoption, clear accountability frameworks rank very, very high. among physicians. What's also heartening, though, is that physicians are definitely clamoring for more training. They are not shying away from the technology. They actually want to use it more. About 1 in 4 physicians actually said they had received no training in use of AI in a professional context. So a lot of opportunity is there, and the demand really is very high. It's overwhelming. They want now, with that training, what they are looking for are a couple of characteristics. They want to make sure that the training is very practical and that it is connected to their workflow so they can see that benefit, and that's going to be very key. The other part is they want to have a seat at the table in terms of consulting or how it's rolled out within an organization, and not just to be informed afterward that this is something the IT department has done and now you have to work with it. They really want to be involved in that process, and that can be a great benefit of working on getting adoption and appropriate use is to incorporate those physician champions, but they really are willing to do that. So bottom line, trust grows where physicians can help shape, validate, and learn on the AI tools. So a lot of positives there. In the last couple of minutes, I did want to go over a few things that are happening within the code set that you'll want to know about. So with all of the changes, the CPT code set is also evolving. Currently in the CPT code set, we have 32 codes that would be AMA approved CPT codes that have come forth under the AI, our new AI rubric. Most of those, as you can imagine, are in our category 3 area. That's emerging services, new service paradigms, not too surprising there. And of the 3 different categories of AI services, we have assistive, augmentative, and autonomous. The vast majority really right now are fitting in the augmentative space. And so augmentative, remember, that's where the AI is analyzing and it produces an output, and then that augments the physician's interpretation. So it's not completely replacing it, but it is providing some additional information for the physician and doing some output, but it's not taking over the physician's work in any particular way. The other thing we're doing, we are starting to see more applications that are incorporating AI, and what we've noticed is that we also need to make sure that we sharpen our taxonomy so that for applicants as well as individuals who are using those tools, that they're able to appropriately distinguish between the 3, both for evaluation of code change applications and then for application of those codes themselves going forward. So a lot of the work that we've done, we still have our 3 categories of AI, and what we found is to really work on refining definitions lately, particularly between the assistive and augmentative realms. Autonomous is a little more cut and dried. But our DMCC, or Digital Medicine Coding Committee, we talked about them briefly last year, they have been submitting a revised taxonomy language, and it really tightens the distinction between those 2, helping to define what counts as a clinically meaningful output. We had a high level of stakeholder input on those discussions, public discussions on those. There was a proposal that was submitted at the most recent CPT editorial panel meeting in May, and those changes will be becoming effective on January 1st of 2027. So Appendix S will still be there. There will be some improvements and sharpening of some of the language in those areas. So if you're looking for 2027, watch for those changes. The last thing I wanted to just touch on briefly is, as new codes have come on, what we've identified is that there is a coding gap and a need for an additional framework within CPT to address it. And again, the gap really comes in to look for a coding pathway for clinical services that are really software-only clinical services that don't have traditional physician work. Physician work has been the bedrock of many CPT codes for quite some time, and it really wasn't built for standalone software purposes. And so a growing category of these are producing these types of outputs, and we're not quite sure, how do you address that? How do you address that within the CPT coding framework? And that's what the DMCC has been working on, is an additional new framework called CMAA. This is primarily in the laboratory space right now, but that discusses clinically meaningful algorithmic analyses and a way to code for those services when there is not a traditional physician work component. They have been working on a structure to help expand CPT's reach to encompass these types of services. And it's still in development at the moment, but we anticipate, future open stakeholder feedback sessions. Those have been extremely informative in making sure we hear from all segments of the healthcare community that are impacted. But I would say coming down the pike, they will be coming back to the editorial panel again with a proposal to assign and create a new coding category to work alongside all of the other CPT categories as we move forward to capture these new realms of services as AI evolves. And with that, I know we are pretty much right close to the end of time, so let me cease sharing here. Okay, so I think that's all that I had to present for today. I know we are close to the end of time, but it's been a great opportunity to be able to come back to you this year. And looking forward to the wrap up of this session and things for next year. So I'll hand it back to all of you. Thank you so much.
Thanks so much, Leslie. As we conclude today's program and introduce our last speaker, I would like to personally also thank all of our speakers, delegates, organizing teams for your contribution, engagement, support, patience, and for laughing at my jokes. We recognize that time was limited and that we were unfortunately not able to accommodate every question and discussion during the sessions. We would, however, like to encourage continued engagement beyond today's conference as we heard collaboration, collaboration, collaboration. Should you wish to submit questions, request speaker presentations, or connect with any of our speakers or panelists, please feel free to email coding@samedical.org and the team will respond as soon as possible. For delegates who have arranged accommodation through ConfCo, kindly remember to reconfirm your check-in arrangements tomorrow at the hotel. To formally conclude today's conference and provide the way forward, I have the privilege of introducing my friend, Dr. Ziyanda Mguguduselo, Acting Head of Professional Affairs at SAMA, to the podium. Please join me in welcoming Dr. Mguguduselo.
She did very well. Ladies and gentlemen, I'm going to do it like we do it at church. Look at your neighbor on your left and say, "We made it." Look on the other side and say, "We made it." So we are going to finish now. I'm not going to take longer than 6 minutes. Thank you very much to everyone. We've noted we've got a lot of work to do from talking about errors, as you know, as part of fraud, waste, abuse, and error, electronic health records, existing solutions. Thank you to all the presenters. That was actually quite intriguing. To recommendations that we should make to the HPCSA with regards to making coding compulsory for CPD points, to strengthening collaborations, of course, to, revising and making sure that billing codes have got descriptions. We will find different ways of doing that with all the different stakeholders that we engage. We'll make sure we put some of those on the agenda. We may not be able to do everything, but one thing for sure about me and my team, we will find an opportunity. If we are not dealing with it, we'll put it on somebody's agenda. Talking about PMBs, thank you to Dr. Sandile Mhlongo. And of course, remembering we do have the 2026 MDCM, which we have outside on the table. No RPL, people, MDCM, 2026 version. And then it is also our pleasure to gift you with our Coding Campus. This is the second edition. The first edition was last year at the Coding Connect. So this is, some of you, I'm sure you can recognize yourselves in this edition. So please, you have one at your table. If you don't have one, speak to Deshri over there. I'm sure we still have copies, right? Yes, we still do. Thank you to the chairperson, Dr. Mzukwa, who is not here at the moment, our CEO, Dr. Mzulungile Nodigida, Prof. Dai, thank you. The chairperson of EST, we appreciate you. Dr. Mashilwane and Dr. Andrea, please stand up. We just want to say thanks to both of you. These are full-time clinicians, specialists, anesthetists, obstetrics, gynecology, but every time I give them a call, they're there, and we give them so much work, and we hardly ever pay them, so yeah. It is what it is. So medical schemes, don't reject their claims, please. My amazing coding team, please stand up. Summer coding team, Deshri, please stand up. Nosipo, please stand up. Mhlengi, please stand up. Anton, please stand up. Benita, please stand up. Karen, please stand up. These are all the people. Anton has left us, but he's still part of our furniture. I really just want to thank Karen is joining us as a contractor. Thank you for the valuable work. Desh has been an absolute star. I've just been giving instructions. She's been executing. So everything you see is really so much what the team has done. Thank you very much, guys. Delegates, to all of you, we wouldn't have this without you. And we can see the demand, and so we're going to have many more of these. So please say yay. And then to our sponsors, we really just want to thank you. Discovery, Solventum, all the other sponsors, you will be acknowledged. Today is only a side event, but we're going to have a whole health summit that is going to end on Sunday. So ladies and gentlemen, please stand up, all of you. Please clap for yourselves. Thank you very much. The 2026 Coding Conference, Summer Coding Conference has officially closed. Have a good day.